Yes. So let's see. Let me go through some of the rules in this committee. I'm going to take my time, and good afternoon. Welcome to the Health and Government Operations Committee. I'm your chairman, Jocelyn Pena-Milnick, and I'm joined by my vice chair, Delegate Bonnie Collison to my left. And the attorney for the day is Lisa Simpson, who is the expert on these bills that we're going to hear. So I'm going to go through some of the rules. I kindly ask for your patience, first of all. If we encounter any technical or streaming issues, don't worry, we'll take care of it. We're going to hear your bill. I want to also ask you to be patient because sometimes you have to wait a long time. And sometimes your bill will be the last, but don't leave because sometimes I change it and I call it, first, depending on who's here. I want to start by saying, please set your electronic, and I'm going to do this myself so I don't get embarrassed, to vibrate. If you have to carry a conversation, please go outside. As a reminder, there's no food or drink allowed in the gallery. You will see us drink, but that's because we sit here for hours and we need to stay hydrated. Otherwise, we get sick. For each bill, we're going to hear from the bill sponsor and the sponsor panel, followed by witnesses. In this committee, I decided not to time the sponsor. However, do not abuse it. While all the other witnesses have 2 minutes to provide their testimony. A timer is displayed on the screen and it will sound and it will tell you when your time has expired. If you could be so kind and wrap it up, that would be great, so I don't have to do it for you. Please adhere to our wonderful committee, to our usual committee rules of 1 question and 1 answer, and please keep your questions brief. You guys are doing great. Members of the public, you'll be able to view this live stream of this hearing on the Maryland General Assembly YouTube channel website as well. So today I'm going to go through the following order of the bills, but keep in mind that I may change it. The first one is House Bill 676. Delegate Morgan, will you please bring your panel with you? And then it's going to be House Bill 880, House Bill 1056, House Bill 879, House Bill 1270, House Bill 726, House Bill 876, and the last bill of the day is House Bill 1368. Today we have with us, I have Shadow with me, and I want her to introduce herself, and then Delegate Martinez also has a Shadow, and I want them to say hi to you.
Go ahead.
Hello, everyone. I'm Sophia. I'm from Howard Community College. I've been given the absolute honor to shadow the delegate today. I'm really excited to sit in and see, what this process looks like in real life. I've had the opportunity to be a part of the student legislature, in which I've done a bit of like a role play of this process, but truly I'm honored to be here today. And so thank you so much for having me.
You're most welcome. Want to introduce yourself?
Hello, everyone. My name is Laura Triana. I'm a Howard Community College student. I'm really interested in legislator. I'm part of the MSL Maryland Student Legislator, and it's a pleasure to be here to participate and meet everyone. Thank you so much for the opportunity. Thank you.
Thank you. Welcome. And it's really important to have students, right? And we have young kids, I remember my kids used to come during Easter. The former chair, Pete Hammond, would allow me to bring them, and they spend the week with me, right? There's a saying that says that you can be what you can see. So it's really important to provide and be a role model. So thank you for your patience as we introduce them. So welcome to our committee.
Thank
Good
you, Madam
afternoon,
Chair.
Delegate.
It's always fun to testify in front of my own committee, which is the most professional and frankly, best looking committee too. You all look great out there.
We'll be kind to you for those words.
So I'm happy to present to you the right to try for individual patients. To give you some background information on the right to try. This legislation was originally passed by the Maryland legislature in 2017. And it was passed by 41 states and then signed into federal law in 2018. And basically what the original legislation was to give you the right to try if you're in a terminal illness or if you had a rare infectious disease. There's over 7,000 rare diseases. And this allows people that are out of options to try advanced medical treatment. Let me tell you a little bit why I think it was originally important to me. About 6 years ago, my father was diagnosed with melanoma, and he had a small spot on the middle of his back, and they went and cut it out. And they're like, you know what? We didn't have any margin on this. We need to try this again. So he goes back to the doctors. They cut out a bigger hunk out of his back. Doctor calls him up and said, well, we're looking at this and there's no margin. You need to come in an office and do a PET scan. So he goes in the office and does a PET scan. And it turns out that he had 4 tumors left side of his body, and it spread to his lymph nodes. And if you ever get a diagnosis like that for yourself or your loved ones, they always tell you not to Google it, but you can't help but Google it, right? And you Google it and you find out that stage 4 melanoma, which is what he had, has a 15% life expectancy for 2 years. 2-year life expectancies of only 15%. And look, because of the treatment options by traditional methods of radiation and chemo, it's not a great 2 years by any means. So his oncologist brings him in and said, well, we'd like to try out some advanced treatment. And this isn't a quite apples to apples comparison, but you'll get what I mean by the end of the story. There was some immunotherapy. He said, we'd like to try you on those. So I was like, okay. So they went and they do his genetic code, and he did qualify for this advanced treatment. And they started on him. It's given to him through an IV by his oncologist every 3 weeks, $8,000 a dose. And what it was a demasking drug. And the oncologist explained it to him, and he's like, well, your body's immune system would kill this cancer if it knew it was there. So we're demasking it. And what really drove it home for me is just how advanced some of these treatments are. I went to the doctors with him after about 3 months of treatment. Doctor says, are you okay? He's like, well, I'm feeling fine. Like, he didn't have any of the traditional symptoms that you would with radiation or chemo. I mean, he looked fine. He felt fine. He goes, I think I'm having a rash. And he takes his shirt off, and it looked like he like somebody dotted him with a Sharpie, red Sharpie. And the doctor goes, have you ever been diagnosed with basal cancer, which is a lesser form of skin cancer? He's like, yes. He goes, that's the medication uncovering your immune system, and it's now attacking the basal cancer that you didn't even know existed. Mm-hmm. So after 10 months of treatment, they rescanned him, and all 4 tumors are completely gone. That was 6 years ago, and he's been cancer-free ever since.
That's wonderful.
So some of these advanced, and it just really drives home the point that some of these advanced treatments are absolutely amazing, and they're really what I would call second chance drugs that are out there. We are in the golden age of oncology. Delegate Kipke and I went on a tour out a couple of years ago to AstraZeneca, and you can really see where it's molding the CNC technology along with the database technology, and where they can keep track of these massive experiments. So what this bill does, it updates the code to allow individual patients that are desperate to try some of these advanced medications that might not be FDA approved. And the way technology is changing at a record pace, the problem with the original right to try law is that it requires the drug to be in a clinical trial. And some of these diseases are so rare, and the drugs are made specifically for that person, they're never going to be in a clinical trial. So this legislation is to update that. It's already been passed in Arizona and Nevada, and this legislative session is being considered in California, Mississippi, and Ohio. If you look in the legislation, there's also some guardrails in there to prevent, I would say, medical experimentation. Deals with the safeguards are you're going to have multiple doctors agree to this treatment. And there's also some safeguards in there as far as cost control, that insurance companies aren't held liable for some of this experimental treatment. So with that, I'd like to turn it over to my panel here, and she can probably give you some more information on this bill, and we'd be happy to answer any and all your questions. Thank you.
And I'm so glad your father's doing that. He's, healed. That's wonderful.
Well, one more statement on this. For years I sat and heard legislation like that, and I've sat her over there, maybe up there where Heather was for years. I'm like, man, that's a pretty good idea. After the summer that I had, let me tell you, you never know when something like this might apply to you. So keep it open mind.
Thank you. Hi, how are you?
Doing well, thank you. Good afternoon, Chair Pena-Melnick, Vice Chair Collison, and delegates of the committee. My name is Naomi Lopez, and I'm a senior fellow in healthcare policy at the Goldwater Institute, which is based in Phoenix, Arizona. Thank you for allowing me to offer my public comments regarding HB 676 today on Rare Disease Day on this important issue to protect the right to try to save one's own life without having to beg the federal government for permission to do so. Imagine that there is a treatment for a rare or ultra rare disease. There are about 7,000 that have been identified so far, affecting about 30 million Americans, half of whom are children. It's custom made for you based on your own genetic profile. It offers you hope, but you can't access it, even though your doctor says it could save your life. The reason? Federal regulations are ancient by today's standards, and they're not designed to allow these new genetic treatments. Maryland, which is home to world-class research institutions and hospitals, has an important opportunity to lead the nation in solving this problem and save lives by championing a law called the Right to Try for Individualized Treatments. The original Right to Try law needs to be upgraded and modernized to account for rapid advancements in medicine, such as gene therapy, which aren't covered under the original law. And that's where Right to Try for Individualized Treatments, or Right to Try 2.0, comes in. This new language does not in any way alter the original Right to Try law, which is a federal law and law of the land. It does create a physician-directed pathway for those patients with rare and ultra-rare diseases who don't have treatment options in clinical trials or who need an individualized treatment approach made specifically for them. Individualized treatments are being pioneered all over the world, but too often, U.S. patients like little Kira Riley and her family have to relocate across the globe for potentially life-saving treatments. Maryland lawmakers have the authority, as well as the legislature, to unleash the potential of today's medical innovations to further benefit patients. I'd be happy to take any questions.
Thank you. I'm going to open it up for questions now. Delegate Shalega.
Thank you, Madam Chair. Thank you for bringing this bill. I guess this would be to Delegate Morgan, the Board of Nursing. I'm sure you've seen their opposition, but it sounds like they just want you to tighten up what a physician is or care. I don't know if you've had a chance to look at that, but it looks like
I did see it, and I believe it was the Board of Physicians that turned in information that kind of contradicted what the Board of Nursing turned in, I believe. I don't have that testimony in front of me. But look, to me,
May I, 1 second?
Yeah.
Delegate Shalega, can you read what the Board of Nursing said?
yes. The board believes this legislation is unclear concerning the providers making decisions about the individualized investigational treatments. So and then they go on to say, recommendation from their physician. It does not explicitly identify which treating physician makes or receives the recommendation. So that seems pretty easy to fix, to just clarify more.
yes, we could open for amendments on the legislation, but really the person that should be deciding the ultimate treatment is the patient. So I don't view this as as legislation where somebody else would be making that decision unless there was some type of advanced directive from the patient. So, it says that you have to have two doctors' approval to consider a treatment option, but I would think the patient would be the one making the ultimate decision.
Delegate Bagnell.
Thank you, Madam Chair. And I just wanted to circle back to the guardrails. I really appreciate this bill. Thank you for bringing it. And I know in previous conversations, sometimes the question has been, to your point, people go on, they look at Dr. Google, they panic, they start looking at treatments. But one of the guardrails is that two physicians signing off on it, and that this is based on the recommendation of a physician. Is that correct?
Chair Pena Melnick,
Yes.
Delegate, I apologize. Bagnall, thank you for your question. So the guardrails that have been established for this law for patients go well and beyond most guardrails. We absolutely appreciate your responsibility to ensure patient safety, and that should be one of your highest priorities, as it is. So what we've done with this particular legislation is we've used a more than 4-decade-old regulatory framework that is governed by the Department of Health and Human Services, called the Federal Wide Assurance. What it does is it requires that these treatments only be made in facilities that are covered by a federal wide assurance. It's the highest standard of protection for individuals who are patients. It also has patient consent requirements. It has an institutional review board requirement, and it also covers all the facilities under the organization that would be creating the treatment. There are very strict rules around the physicians that would be operating, or researchers that would be operating in the facility, and there is a requirement for ongoing monitoring of these treatments. So they are these are in addition to patient consent. So there is a very strong regulatory framework that does address, this very important issue of protecting patients.
You're welcome. Any other questions for the delegate and his panel? Seeing none, thank you so much.
Thank you.
And delegate, if I may, I know that the AG, I send you the letter from the Attorney General's office.
Yeah, and I appreciate you trying to drive them to a meeting. I was kind of shocked by that letter because the source that they sent in the link, that the information for that letter was taken from not from like a how can I say, pharmaceutical authority by any means. It's written by CA Capital, which is a venture capital firm that invests in pharmaceutical companies with FDA approval. So I was kind of shocked that they used that as a source to write some type of opposition and a letter of concern. And I really can't wait to meet with them to try to figure out if they actually have concern about it, or is this just something they found on a quick search and didn't really see it through.
And I don't see Heather Forsyth. Is she here today? Yes, right in the front. And I know you're not signed up to give testimonies written, but can I ask you, will you be so kind and schedule a time to meet with a delegate regarding your concerns and see if we can address some of it? Thank you so much.
Sure. Thank you. Thank you, Madam Chair.
And if I may, I'm going to volunteer the Chair of Public Health, Delegate Bagnall, and Dr. Hill, Delegate Hill, to be in that meeting, please. Okay?
Good. Sounds good.
Thank you.
Thank you. I appreciate that.
You're welcome.
Thanks.
So next I have the Maryland Board of Nursing. I have an unfavorable. Hi, how are you?
Thanks. How are you?
I'm doing well. Thank you for being with us today.
Thank you for having me. My name is Janae Gorwal. I'm here to testify on behalf of the Maryland Board of Nursing to this esteemed committee. We are expressing concern about House Bill 676, and thank you for referencing our written testimony. This bill alters the definition of eligible patient under the Right to Try Act to include individuals who have life-threatening or severely debilitating illnesses rather than only individuals who have terminal illnesses. And as this legislation recognizes, life-threatening and severely debilitating illnesses are of increasing impact across our population. According to the medical journal The Lancet, the global burden of serious health-related suffering will almost double by 2060, with the fastest increases among older people and those with dementia. As this phenomenon continues, science strives to provide humane and novel solutions. But when faced with a terminal or life-threatening condition, a patient can be especially vulnerable. While individualized investigational treatment may offer important hope to this growing population of patients, it also carries with it some risk. The board believes that we must be very clear and specific regarding which clinicians take responsibility for these different risks. We encourage the bill's sponsors to include language that identifies which treating provider makes or receives the recommendation for individualized investigational treatment. And as clinicians, we recommend that providers with experience in the specific area of specialty be given those charges. With greater specificity, we can help to ensure that this growing area of medical innovation is as safe as possible for as many people as possible. And we thank you for your time and attention to this matter.
Thank you, and thank you for being with us. Are there any questions? Delegate Hill.
Thank you, Madam Chair, and thank you. When your testimony reminded me of Laetrile, but I'm curious if you all have any specific recommendations.
We noticed that throughout the legislation, there were references to provider and physician. And we just, if there was language that could be added that specified, from whence that recommendation came or to where it went, it would be helpful throughout the legislation.
It would be helpful if you could give us an idea of what that language might look like.
Sure, we'd be happy to write an email to you.
All right, and give it to the delegate.
Of course.
So I'm gonna do one better. I would like you to meet with the Attorney General's office,
Okay,
with Delegate Hill and Delegate Bagnall and the sponsor, Delegate Morgan. If you can, the delegate's gonna get up when the bill is done, and he's gonna meet you outside, and you guys can set up a time, exchange information, okay?
absolutely.
And I don't know where the bill will go, but I certainly would like to see if at all we can work on it, okay? Delegate Shalega.
Thank you, Madam Chair. So I'm reading the bill and the language that they didn't change any language on treating physicians. So if I'm correct, this bill takes the original right to try and just expands who's eligible for it. So if the original right to try had adequate protections, because there isn't any change in that, it says, this is current language and what's currently happening, attests to the fact that the patient concurs with the patient's treating physician.
Sure.
So treating physician seems adequate to me. So I would ask you to look more carefully at the bill, because I don't think they changed any word in here about a provider. So thank you.
Thank you.
Okay. So you'll meet and you'll discuss it and look at the bill, look at the merits of the bill. Is it good policy for it to go forward? I'd like you to just sit down and discuss it with the parties that I just outlined. Delegate Kaiser.
Thank you, Madam Chair.
You're
And I'm sorry that I missed Delegate Morgan's testimony, and I am favorably inclined to this bill. And I just wanted to ask you a question, if I'm understanding what I thought you heard in a quick look at the testimony, the written testimony that you provided. Are you concerned that people aren't making an informed enough decision with their doctor's help? And then I probably have a follow-up to that, Madam Chair.
I believe that's
Sure.
one of the concerns, and I'm speaking on behalf of the board. I'm not personally a clinician. I believe that was one of the concerns, as well as the potential lack of expertise that might be present in making a recommendation. And I think they wanted to be specific about the specialty areas that were being addressed.
Okay, because thank you, Madam Chair. It seemed to me that the bill was very careful in ensuring that all of that information out there. And in fact, this bill seems very much a partner to the death with dignity legislation, and that we're giving people autonomy in decision-making and allowing doctors to do certain things and creating a very defined structure in the state to help people. So isn't that so? Thank you, Madam Chair.
You're welcome. Any other questions or concern? See none. Thank you so much. This actually concludes the bill hearing on House Bill 676. And we welcome you always here, okay? Thank you so much. Next, we have House Bill 680, Delegate Johnson, Pharmacy Benefit Administration, Maryland Medical Assistance Program and Pharmacy Benefit Manager. I have to get up because I have a meeting in the back. When you see me get up, which is not often, but this is sort of almost, we're 39 days away and people come and regarding their bills, I have meetings with people, but I will be back in the committee, all right? Just to let you know what's going on. Thank you. Delegate Johnson, will you be so kind and bring with you Caitlin McDonough, Steve, Jim, Kaylee, and Aaliyah? Okay. And I call you all by your first name, and Caitlin, I know all of you personally. Come forward.
18, come on.
And
Just pull up a chair. Pull up a chair and swap out. You can pull up a chair.
and whoever else you want, you can bring them forward as well. Yeah.
I'll just swap out.
Sorry. Delegate Johnson.
Thank you. Madam Vice Chair, committee members. I don't know if I can follow Delegate Morgan's after saying you all look the best looking committee in the House, but I'm going to do my best. Good afternoon, Madam Vice Chair, members of HGO Committee. For the record, I'm Delegate Steve Johnson here to present House Bill 880, Pharmacy Benefit Administration, Maryland Medical Assistance Program, and Pharmacy Benefit Managers. Is a bill that this committee is very familiar with. We've heard so many times about how pharmacies are struggling and how they with clawback fees and admin fees. Well, this is a bill about their reimbursements. The bill would mandate reimbursement parity for pharmacists dispensing Medicaid or medications under the state's Medicaid managed care program so that they are reimbursed at the same level as under the fee for service program. Basically, it would require the pharmacist who served Maryland Medicaid patients at the minimum reimbursement for the ingredients of the cost of the drug and for the dispensing service they provide. Currently, under the managed care program, the MCOs are significantly underpaying pharmacists for their dispensing services, less than 50 cents per drug, far below the $10.76 per drug that Maryland Medicaid has determined to be the appropriate amount. The result is that it's just not financially viable for the pharmacist to dispense the drugs under the managed care program. And similar to any other health practitioner who serves the Medicaid patient, if you don't cover the cost of those services, you will see a direct impact on the practitioner's ability to continue that service. That may mean closing or significantly limiting hours in high Medicaid areas, cutting back on a pharmacy staff because they can't reimburse, because the reimbursements don't cover those wages, or the inability to fully stock medications when the pharmacy takes a loss every time they dispense a drug. Not only is this current system shortchanging our Medicaid pharmacists, it is shortchanging the patients that they serve. This is particularly true for our smaller independent pharmacies. And we've all heard plenty about how our independent pharmacies are suffering. They do not have the ability to offset these losses with other sales and business practices. They are pharmacies that often provide services in places where providing care may not be profitable. But the longer they are forced to dispense without compensation, the harder it is for them to stay in those locations. I recognize that increasing reimbursement for these practitioners comes at a cost, but that is true with everything the state chooses to prioritize and properly fund. Medicaid pharmacists should be given the same rate consideration afforded to the other Medicaid practitioners. We are working with a few stakeholders on some possible amendments that we will have worked out for subcommittee. So I stand ready to work with the department and this committee to implement a solution to this ongoing program. And I urge the committee's favorable vote on House Bill 880.
Thank you, Delegate. Who would you like to go next among this very austere panel?
Good afternoon, Madam Vice Chair, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association. So let me just start with, we know what the fiscal note says, and that's a problem. And we met with the chair, we met with the vice chair, we met with the subcommittee chair. Thank you all so much. We know you all know that there's a problem, but we also recognize the state's fiscal situation and are working towards some sort of solution here. Hopefully that could be revenue neutral. But I want to go back to what we've talked about in this committee. I don't know how many times. We always do this little back and forth about how many pharmacies have closed. What's actually happening with pharmacies? Well, we finally pulled those numbers for you, and that's what I want to focus on, because ultimately, if we do not fix this problem, that problem is going to get a lot worse. So between 2013 and 2023, this state has lost a total of 43 pharmacies. We also tend to have conversations around independents versus chains. But this state has lost 27 independents in 10 years. And then this state has gone ahead and lost 21 chains. So yes, chains can hold on a little bit longer, but the reason we can do that is because of volume. So I really wanted those numbers to get out there because we have to do something around reimbursement. And I know Caitlin and some of my colleagues are going to talk about this, and certainly the sponsor talked about it. But if we do not fix reimbursement here, you're just going to start losing them one by one. And I know you guys are used to hearing about food deserts, but you're going to start having literally pharmacy deserts. And that's something that's happening across the country. And that tends to hit minority communities first. I'm glad to share that information. Forbes just came out with an article about it, but I wanted to draw this back to the heart of the issue, which is you have been losing pharmacies in this state. You will continue to do so. CVS, Walgreens, and Rite Aid have announced massive closures that are coming, and that's not even in these numbers yet. So I'll stop there. I'm glad to answer questions about the bill. Thank you.
Kaylee, would you mind sending that Forbes link to me, please?
I'm one step ahead of you. I already sent it to you.
Thank you very much. Who would like to go next? Steve, looks like you're nominated.
Good afternoon. My name is Steve Weiner. I own Mount Vernon Pharmacy and Mount Vernon Pharmacy at Fallsway in Baltimore City. I'm also representing Epic Pharmacies, and I thank the committee for allowing me to speak. 2019, we started the process with this legislation, and just a little bit of trip down memory lane. After a year or two of fighting over God knows what, we found out that there was spread pricing in this system, and shining a light on that saved the state around $60 million a year. And that's just in drug spend. There's also capitation rates that were inflated because that spread pricing was supposedly a medical expense when it was really just a service fee. A little bit of a thank you would have been nice from the state. They took the money, said, that's great. You keep suffering, pharmacy. Number two, the formulas that we've asked to get reimbursed is what CMS mandates every state in the country to do. So CMS goes to every state and they say, we're sick of this alphabet soup of terms. We want you to determine what the real cost of a drug is and what the cost will be for the pharmacy to cover their fixed expenses, not profit, to break even. And that's the figure we came out with. That's the figure the Department of Health says it costs to fill a prescription. Now, whatever the study and the fiscal note says, 60 million, 70 million, 120 million, that's what pharmacy is subsidizing the state of Maryland to fill a prescription. Again, just say thank you. I've never hoped I will be so wrong. There will be pharmacy blood in the water this year. And I hope next season, I'm not coming back and saying, I told you so. I hope I'm wrong. But the reimbursements are so bad that this little drip, and I'm done, the little drip you've just heard will be a gusher within a year. I'll see you next year. Hopefully I still own a store.
Thanks, Steve. Caitlin?
Thank you, Madam Chair, members of the committee. Caitlin McDonough here in support of House Bill 880 on behalf of the Epic Pharmacy Network. I am relatively new to working on pharmacy issues in the committee. I do work with a lot of other health practitioners, and particularly health practitioners who work in the Medicaid space. And it has been a unique learning experience that pharmacy is treated somewhat differently through the way they're reimbursed and how their services are reimbursed versus just the products they dispense. So, I'm learning through that curve, and it is a little shocking that I can't imagine, like, we're talking to one of my dentists or one of my other professions that I work with and have them getting reimbursed at a negative rate for the services they provide. So I am grateful to this committee. We're working with Maryland Medicaid. We're working with Deputy Secretary Moran to try and come to a solution, working with the PDAB, all these kind of entities, because I think people do recognize that there's a problem in the state. I think people are willing to do it. Believe me, I recognize there's a fiscal situation in the House of Delegates and in the General Assembly that they're facing this year. But beyond, you've already heard from the pharmacist about how difficult it is, but we've looked at like some half measures that would kind of cut the fiscal note in half or reduce it based on the ingredient cost. And honestly, like, we couldn't really sell it to the members. Like, they can't agree to take a rate where they're making a negative rate. And they can't accept that as a solution and then not see any kind of relief for additional years. So we're in a tough spot. Kaylee mentioned the fiscal notes. So, we'd urge a favorable report, but we also look forward to working with the state and the committee to try and come up with some solution to spread this cost around the various entities that are involved in the chain. And I think Jim can speak a little more clearly as well. So thank you.
Jim Doyle, I'm here representing the independent pharmacies of Maryland. And I don't want to repeat what's been said. All of that has been said is absolutely true. I get calls every week about from independent pharmacies about the low reimbursement rates that they're receiving. Just to give you an idea on the dispensing fee, a couple of years ago, a study was done by the state, and it showed a dispensing fee of somewhere 45 or 50 cents for managed care prescription. And the government itself, as was mentioned, CMS, has determined that the actual dispensing fee is $10.67. Well, no one, I don't care what business you're in, no one can run a business with that kind of a loss. And this is something that you've heard it many times before. Unfortunately, nothing has been done. I know last year there was a bill passed to do a study by an outside group. That bill was a big disappointment because one of its goals was to try to come up with something that came up with a reasonable reimbursement rate, and it didn't even address that issue. So we're right back at square one. And I know that our members, our independent pharmacies who serve throughout this state in many areas are extremely frustrated about the lack of progress. And to tell them that, we're going to do another study or we're going to, look at this again next year is just wearing very thin. And something has to be done. And
Thank you, Jim. Malia? Batting cleanup here today, on this panel anyway.
Yeah. Good afternoon. My name is Aaliyah Horton. I'm the Executive Director of the Maryland Pharmacists Association. We're an individual member professional society for pharmacists, student pharmacists, and pharmacy technicians. I wanted to go after the rest of the folks because they represent the pharmacy, the brick and mortar pharmacy community. My members are many of the owners in the Independent Pharmacists Association, in the Association for Chain Drugstores. And this issue impacts the profession. I started at MPHA in January of 2015. My second month on the job is when United Healthcare kicked all of many of the independent pharmacies out of the network. And that was like trial by fire, learning about all these PBM issues. And it just hasn't stopped. And one of the things that we said as a strategy was come into Annapolis, come share your stories, tell what's going on. You recall the hearings where the room was filled with white coats. Many of them have sold their pharmacies. They're not here, they're not engaged anymore. And that's really frustrating. The other thing that I was thinking about today as I was driving in is that the cost of a Snickers, this is kind of random, but go with me. The cost of a Snickers bar is $1.25 in a store. You go downstairs to the vending machine, it's $1.75. That's a 50-cent difference. What the state is paying pharmacists to do their job is basically equivalent to being a vending machine. And that is really frustrating for my members who have doctoral degrees, who specialize and work with your constituents and patients in all these communities. And the state has said you're equivalent to a vending machine, and that is not the role that they play. And so I do hope, I've been working with everyone else here to try to come to a solution, but at the end of the day, the state is underpaying pharmacists. What is it? That's $72 million. Those are the facts. And I don't know what else we can bring to the committee beyond that. Thank you.
Thank you. Is it Jill?
Yes.
Okay.
Good afternoon, Chairwoman and honorable committee members. I do not want to repeat what others have said, but I do want to just make a few brief points. First, I want to read from a letter that Vicki Cunningham, who was,
First, give us your name, please.
I'm sorry, Jill McCormick, NACDS.
Great, thank you.
Want to get that 2 minutes in, and Vicki Cunningham is the pharmacy director in West Virginia, and they had instituted a carve-in with a rate floor several years ago. And she wrote a letter to another state making a recommendation. And in it, she says that when West Virginia looked at this, the study showed a savings of $54.5 million to the Medicaid program, even though 116 million had been paid out to pharmacies to cover their cost to dispense and allow them a reasonable amount of profit to stay in business. That's basically the rate floor. The prior authorization agent used was the West Virginia University School of Pharmacy, directly contracted with Medicaid. This was a great relief to pharmacy providers because it allowed them to provide prescriptions to the Medicaid members and to stay in business. and because it allowed them to provide prescriptions to Medicaid members and to stay in business, and to Medicaid because it provided better patient access. So West Virginia taxpayers save money in the process each year while also preserving Medicaid members' access to the prescription drug benefits. Now, I know that what the cost of the study was and what it was reported as, but remember, there are pay-fors that weren't reported for in there. When you look at administrative fees, Maryland has 9 Medicaid plans, 9. Pennsylvania has 5, Virginia has 5. On average, as came up at the informational briefing, it costs $10 a prescription in administration fees to pay the MCO/PBM to administer the fees. There are rebates that the PBMs are getting. There are brands that could be generic. When there's too high of a brand. There's the spread and there's a steering issue. So just want to close by saying, don't just look at the report saying it costs this much. There are also pay-fors out there that we can get to. Thank you.
Thank you. I'm now going to open it up to questions, and we'll start with Delegate Chisholm.
Thank you, Madam Chair. I think Delegate Kaiser had herself.
Oh.
Do you want to go first?
Delegate Chisholm, is that all right, Madam Chair?
That's
Thank
fine.
you.
Go
My
for it.
question is for the woman who's next to Caitlin McDonough, whose name I didn't know, who used the vending machine analogy. I would like you to take that a little further. If I understand it, if I don't remember if you said Milky Way or Snickers, I love them both, and anyone can bring me one later. Thank you. But if you're telling me that if I'm buying it for $1.25 down the street and $1.75 in the machine, that's a 40% markup. But you're saying that the pharmacists are being treated no better than a vending machine. I'm seeing a 40% markup. So could you explain your analogy a little
better if pharmacists could be paid that? No, what I was saying is that 50 cents, the 50-cent difference, the direct cost of getting a Snickers bar out of a vending machine is the same as what the state is paying pharmacies on every pharmacy claim, on average, on pharmacy claims. In the report that the committee got earlier this year, I put my glasses on, it basically said that in 2021, pharmacy claims on average for the dispensing fee was 67 cents. And in 2022, it was 59 cents, and that averages out to about 63 cents. For every pharmacy claim, that's what pharmacists or the pharmacies were paid outside of the fee-for-service program.
But even when their costs were greater?
Excuse me?
Are you saying that even when their costs were greater than that? I just want to clarify.
No, what I'm saying is that when this has nothing to do with the cost of the drug. I'm just saying the dispensing fee. That's what the dispensing fee was.
Okay, thank you.
Delegate Chisholm.
Thank you, Madam Vice Chair. This is my 6th year on the committee, and we've heard this bill for 6 years in a row. Obviously, you're right, we are losing more and more of the white coats behind you, so it is getting worse and worse. And we're all very sensitive to what's going on budgetary wise here in the fiscal notes. So when, and Caitlin, you're probably the best one to answer this unless Jill wants to answer, but you talked about you're looking for ways and you think you could find some ways to make it revenue neutral and still come up with a solution. Do you want to expand on that?
So,
I was curious.
yeah, honestly, so we have, and I will again thank the committee for meeting with us prior to the hearing and trying to work with us and the department as well. So what we did is took the report that basically kind of determined the 70-ish million cost. And if we looked at just reimbursing the full amount of the reimbursement cost, which actually results in a savings to the state, and then redistributing that about a $30 million savings in dispensing fees, whether that would work. That was a compromise that we were trying to work out. Frankly, when we took it back to our members, they were still, it would still be such a significant loss that we couldn't even agree to the own proposal that we were trying to do. But I mean, I think it's illustrates like we recognize there's a cost. We've got to find a solution. We are trying, we don't necessarily have to get the entire amount, but we've got to get to a point where, we are being compensated for these services. And I think the analogy is we're not just dropping pills into a bucket. We are providing a health service just like any other provider in the state, and we are not compensated for that service. That's kind of the analogy. You wouldn't pay, I mean, I'm not saying you get paid what a doctor gets paid for what they do, but you don't get paid at all for the service, for just paying for the questions.
Thank you. Thank you, Madam Vice Chair.
Thank you. Delegate Salega.
Thanks, Madam Vice Chair. So I did a little back of the envelope math here. And so I guess I'd ask this, be a couple questions. I'm sorry, but math takes a little bit of time. So Steve, I'm assuming anyone that works in your pharmacy that hands the prescription to a patient gets paid at least minimum wage.
Not
you don't probably make that, but
my average salary is above that, but yes, I mean, so $18 to $22 an hour is my average right now.
Okay, so I'm reading in the fiscal note where it says DBM has negotiated dispensing fees of 35 cents and 50 cents per prescription. I think I would say shame on them because I did the math. And if I'm right, as on top of what you pay someone, your generous 18 to 22, you're paying workers' comp, unemployment, Medicare, FICA, general insurance, rent. You pay someone to process your payroll, an accountant. So, that I'm guessing at least 30% cost, at least. And then if you put on top of that, your back end costs for you to contact an insurer or a physician as a follow-up on that prescription, because unfortunately, I don't take many prescription drugs, but I did have a prescription last spring and it took me 3 trips to the pharmacy to get it because Care First kept denying the formulary of some simple, ridiculous, simple drug. So 3 trips to the pharmacy for me, that's multiple problems for you to make phone calls to figure out what drug I am actually allowed to be dispensed. That's got to be over 40% back. When you add those costs, you got to be over, but let's just say 40 because you've really trimmed it down. 40% on top of your $15 an hour comes to $21 an hour you have to make to break even, which I again think is low. At 35 cents a dispense, that's 60 prescriptions an hour. Could someone possibly one of your staff possibly hand one prescription a minute?
The math certainly does not add up. If you have any stores that are in a neighborhood that does primarily this line of business, we're not talking about Roland Park, okay? You're talking about stores in very poor areas. They're not going to be around much longer. That's the simple math. Now, you know, pharmacists have good hearts, often better hearts than we have brains for being business people. And it starts out where you say, you know what, I don't have to make money on this line of business. It's good for the community. I'm going to do it. But you turn around and all of a sudden that line of business has exploded and there's no other line of business to make up for it. So it's a real problem. And yeah.
This dispensing fee that DBM has negotiated of 35 cents or 50 cents per prescription, does that include the bottle you put it in or the bag you put it in?
No. So
on top of so you're making.
So just to be fair to DBM, there's always been this, here is a formula of cost and here is a fee. And that changes depending on which line of business we're talking about. So the Department of Health Choice, the MCO division, will say the cost isn't really cost. They're getting paid a little more than that. And we're just lowering the 35 cents because their cost is higher. That was true 5 years ago. It is less true today. The cost is really close to our cost or less, and the 35 cents is really 35 cents. There's no money for the vial. There's no money for the bags. There's no money for workman's comp. So you've got a choice. You got to cut. And chains are closing. The Rite Aid around the corner for me closed. So you cut lunches, you cut hours, you cut support staff, and then you close. And while you're doing that cutting, you have to decide if you can do it in a safe manner. I'm in a fortunate position where I own my store. I made my money years ago. I'm not making money now. I made it years ago, and I'm not going to poison people. So I'll make less until I've had enough. But if I have shareholders like Rite Aid, I close. You can't just decide to make less.
So in a community that has fewer commercial payers, you're just taking it on the chin and a serious way. Now, when family passes the Family Leave Act, which is going to add another huge expense, half paid by employees, half paid by employers. I mean, what is that going to do? Is that going to be the nail in your coffin?
Less staff, longer waits, close. That's what you're seeing in chains. Call a chain. See how long it takes you to get someone on the phone.
I think you made your point well, Delegate. Delegate White Holland.
Thank you, Madam Chair, and thank you, Delegate, for this bill and all of you for being here. I wanted to invite you to speak to something that was written in the Department of Health's letter as it relates to seeing the growth in pharmacy enrollment and how that has outweighed any closures. And so I just wanted to know if you could speak to that and to call out where we've seen some of these closures take place geographically, as they indicate that they have not been in rural areas. So can someone speak to that? And I know that we'll get some additional data following Kaylee's testimony, but can you share a little bit more about that in particular in response?
I think Kaylee just left with a piece of paper that we provided to the committee. So I think when the Department of Health study looked at closures, I think that whatever data they were looking at I don't think they were able to separate out retail from other kinds of pharmacies, like maybe hospital based or or other pharmacies that aren't public facing. Because I think that's the way that I don't know that the Board of Pharmacy kind of, I don't think they have a way to parse them from the overall pharmacy numbers. So I don't think that I think that the MDH's numbers were in good faith, but when we looked at it and actually pulled it from the NCPA database, I think Kaylee said before that in the last few years, we're down 40 some independents and 5 or 6 less chains in Maryland. That's only over the last few years. And you should have those numbers that were delivered to the committee, but we will resend, make sure you have them.
If I may, can you speak to where geographically they may be taking place?
I do believe those closures are more in high Medicaid areas, but and I noted that we're talking with Deputy Secretary Moran about this issue specifically and kind of some of the numbers that were included in the report. So I think we are going to work with the department to break those out by geography, by, you know, the clientele versus like type of insurance by the clientele and things like that, because I think our real world experience is a little bit different of which types of pharmacies are closing and where they are. So to your point, exactly, we're going to work with the department to get some clarity around those numbers.
Yeah, I'm guessing pharmacies aren't opening in areas where it's highly Medicaid because of what just Representative Delegate Saliga talked about.
Okay, thank you, Madam Chair. Okay, Delegate Kipke.
Thank you, Madam Chairman. Dr. Weiner, could you provide, in the last 10 years, there was a big influx of new pharmacies in the state, many of whom joined the association. Can you just, I know people that will come after you, maybe in even other bills today, they're going to brag about how great we're doing with the number of new pharmacy openings. And I think we need to bring it down to the real world so that especially the newer members of the committee can understand. I mean, it's very important what was just brought up about areas of high poverty. They're suffering the most, but why would somebody open up a pharmacy in Maryland? And if they did, what perspective do you have on that?
So it sort of goes hand in hand with the other question. The pharmacists that don't own their own stores, that are working in high volume environments are stressed out. And they either can leave pharmacy or, quite frankly, they're opening their own stores. They're not aware of the economics of the situation. They're working in a very busy chain and they're saying, boy, look at all this business and I can't handle the stress. I'm going to open my own store. So if you look at these numbers, you're going to see that there's stores opening, but there's stores closing. And these opening stores are one-person owners working by themselves, trying to get away from a very challenging work environment. And then they're closing within a year. The Board of Pharmacy, in their newsletter 2 springs ago, and I can get that to the committee. It's actually been submitted in previous years. Board of Pharmacy, which is a division of the Department of Health, said, yes, we've got pharmacies equal opening and closing, but the ones that are closing are in high Medicaid areas. And we're talking about a Medicaid issue right now. So.
Delegate, you good? Okay. Any other, seeing no other questions, that completes this panel. Thank you all very much for being here today. Stick around. And I'm going to call, do we have our virtual witness? She's not here? Okay. Then I'm going to call an unfavorable panel, which is a solo. Mr. Joseph Wynn. There you are. If it gets too hot, we'll put a fan down there.
Madam Chair, members of the committee, good afternoon. I'm Joe Wynn. I'm the Executive Director of the Maryland MCO Association. I'm here today with very brief comments in opposition to House Bill 880. This bill makes profound changes to the Health Choice Prescription Drug Program. And as was mentioned by the previous panel, been subject of a study was House Bill 382 last session.
Joe, can you move a little bit closer to the mic?
Yes, ma'am.
Thank you.
So that bill was heard last session. 382 became a study, which was briefed in January to this committee. The findings of that study showed that the change could cost as much as $78 million. And it also looked at pharmacy stability, which we just heard a little bit about, and that the study suggested there was relative stability with 20 openings and 6 or 9 closings in calendar year 21 or 22. I have them mixed up. Look, the MCOs rely on the PBMs just like a lot of other organizations, and that includes the state of Maryland. The PBMs provide a valuable service to the MCOs. They do seemingly simple things like ID cards all the way to super complicated things like formulary management, utilization review tools, P&T committees, and a whole host of pharmacy services. But we also rely heavily on our extensive network of pharmacist partners, the 1,400 pharmacy partners that we work with as MCOs. We just think this bill is too expensive and takes away a valuable tool from our PBM contract partners. And we urge an unfavorable report on the bill. And that concludes my brief remarks, Madam Chair, and happy to take questions.
Okay, thank you. Questions for Joe? So I'm wondering, and I understand and hear your concerns. Can you reflect on the issue that Delegate Shalega raised with respect to the pharmacist having being challenged to make payroll and to keep up the administrative and infrastructure costs of just the business itself?
I really can't. I've worked in healthcare almost my entire career, but I don't know enough about the day-to-day operations of how the different kinds of pharmacies pay their staff and operate their businesses. I know that they have, there are pharmacies and grocery stores and retailers. There are regional pharmacies. There are independents that work with PSAOs. But I don't really I've never worked inside a pharmacist office, so I don't know. Sorry.
Delegate Shalega, you want to follow up?
Thank you. Yes, can you tell us what your negotiated prices are per prescription? Can you give us a range?
I don't have access to that information, Delegate. I'm sorry.
Can you provide it? Can you ask and get back to us? Is that proprietary? I mean,
Yeah,
PBM published it in the fiscal note.
I'm happy to go back to the MCOs and ask, but I don't know what information they can share and what they can't share, but I'll follow up with you.
Thank you.
You got it.
Thank you. Any other questions for this witness? Seeing none, that concludes the hearing on, unless our virtual witness is here. No? Okay. Concludes the hearing on House Bill 880. Thank you all very much. And we will go to House Bill 1056, Delegate Gazzoni. And Delegate Gazzoni, would you like to bring up your panel of Nora Hoban, Mark Agunsusi, Kevin Lindemood, and Dr. Wendy Webb?
Good afternoon, Madam Vice Chair, members of the Health and Government Operations Committee. I'm Delegate Pam Gazzoni. I represent Howard County's District 13, and I'm here in support of House Bill 1056. I'm proud to sponsor HB 1056, Prohibition on Discrimination Against 340B Drug Distribution, for the committee's consideration. I'll start by stating the obvious. Health equity starts with legislation that supports access to primary and preventive care for all Marylanders. This bill aims to restore flexibilities allowed under the 340B drug pricing program and protect safety net providers' ability to continue to provide care to Marylanders most in need. As you may know, the 340B program was created to assist safety net providers to, and I quote, stretch federal resources as far as possible, reaching more eligible patients and providing more comprehensive services, end quote. At root, it allows community health centers to purchase outpatient medications at significantly reduced costs, which then enables them to provide affordable, discounted, or sometimes free medications to uninsured and underinsured patients, while also getting standard reimbursement from Medicaid. For participating community health centers, every penny of the 340B savings must be reinvested into the center to meet the needs of the communities it serves. Think things like dental services, behavioral health care, and wraparound services. Such services help mitigate inequities related to race, ethnicity, education, and/or social economic status. Healthcare entities covered under the 340B program include federally qualified health centers, or FQHCs, Ryan White clinics, and hospitals that treat a disproportionate share of low-income patients. Participating 340B providers, many of which cannot afford to have or have the space to have an in-house pharmacy. Many of them contract with community pharmacies to improve patient access to needed medication. This bill will prevent pharmaceutical manufacturers from imposing restrictions that limit the number of pharmacies community health providers can contract with to receive the discounted medications under the 340B program. These contractual arrangements allow patients to pick up prescription medication from their local community pharmacy without a return visit to the 340B health center or the hospital, which can be challenging, especially for patients in rural areas. Contracted pharmacies ease patient access, thereby improving medication adherence and health outcomes. Since 2020, 29 pharmaceutical manufacturers have begun limiting the number of pharmacies that 340B covered providers can work with to receive discounts on the drugs. This undermines the 340B program and puts vulnerable communities at risk. In September 2020, as an example, Eli Lilly announced that covered entities without in-house pharmacies must choose a single contract pharmacy. AstraZeneca and Sanofi followed suit on October 1st. Over the next 3 years, the list of manufacturers with restrictions grew to include Merck, Gilead, United Therapeutics, and others. The restrictions most often limit 340B providers to dispensing discounted drugs from just one contract pharmacy. This means patients have to travel farther to obtain essential and affordable medications, which is time-consuming for many and creates undue hardship for those who lack reliable transportation or who work non-standard hours. These restrictions force patients to make difficult decisions. Do they pay rent? Do they buy groceries or pick up medications? The result can be unfilled prescriptions, inconsistent intake of medication, and deteriorating health conditions. Over the last 32 years, the 340B program has been shown to increase medication adherence, improve health outcomes, and prevent acute escalation of chronic conditions, all of which avoid the need for more costly care. If manufacturer restrictions are left unchecked, safety net providers, like our federally qualified health centers, may have no choice but to cut services. The patients most affected by these restrictions are Marylanders living in poverty and who have the least access to care. The loss of access to 340B medications is not unique to Maryland. 12 states throughout the country have introduced similar legislation this year. House Bill 1056 will protect the federal 340B statute in Maryland, where national efforts have stalled. Swift and robust state action is required to preserve essential safety net provisions and high-risk communities from further damage and inequities. I respectfully request a positive report on HB 1056.
Thank you, Delegate. Who would you like to go next?
Mark's going to go next. Thank you, Mark.
Good afternoon, Madam Chair and members of the committee. My name is Mark Ogunchusi. I'm an attorney and doctor of pharmacy. I've practiced pharmacy throughout the state of Maryland and currently practice law at Powers Law Firm, where I focus on the 340B program in pharmacy law. Established 30 years ago, the 340B program combats the rapidly rising cost of drugs and provides critical support to safety net providers that serve as the backbone of our nation's public health system. So how does the program work? Drug makers offer 340B discounts to safety net providers at no cost to taxpayers in exchange for their drugs being covered under Medicare and Medicaid. So that means that drug makers unlock massive taxpayer-funded markets for their drugs under Medicare and Medicaid by providing 340B discounts. So 340B is essentially a taxpayer relief program. So what does the federal 340B statute govern? And this is important, the federal 340B statute governs pricing of 340B drugs and purchasing. It sets a price and says who can purchase the drug at that price. Safety net providers, not pharmacies. But critically, the 340B statute does not state how drugs should be delivered or govern delivery of drugs to pharmacies. In fact, the statute doesn't state the term pharmacy once, and that's exactly what HB 1056 would govern. Why? Because Congress intended for covered entities and safety net providers to be able to use contract pharmacies as a matter of state law. As evidence of this, the Health Resources and Services Administration in 1996 specifically stated that contract pharmacies are a matter of state law. So your governance of contract pharmacy delivery is not only consistent with Congress's intent for the federal program, it's also consistent with your historic power to police public health and safety within your borders. That's why 19 other states are pursuing similar bills or have enacted similar bills to protect contract pharmacy distribution. And it's why pharma's attempt to invalidate one state's law failed at the Arkansas District Court. Please enact HB 1056 to protect public health within your borders.
Go next.
I'll go. Good afternoon, Madam Vice Chair and members of the committee. I am Nora Hoban, the CEO of the Mid-Atlantic Association of Community Health Centers. I ask the committee to support House Bill 1056. The association supports Maryland's community health centers as they deliver comprehensive primary health care to more than 340,000 Marylanders residing in all counties and jurisdictions of our state. 87% live at or below 200% of the federal poverty level. That includes an individual that makes about $30,000 or less a year. More than 2/3 of our patients are from historically marginalized ethnic and racial groups. And addressing health disparities does start with access to primary and preventative care. Maryland's nonprofit centers provide wraparound services to ensure care can be delivered, including medication adherence programs, discounted labs, maternal and dental care, transportation, and more. Manufacturer restrictions have put population health progress at great risk, and highly profitable multinational corporations are dictating Maryland public policy and medication access, threatening our primary care safety nets. Patients simply suffer, and expecting patients to go to one pharmacy to access affordable medications is just not feasible. Not for the busy new mom who needs to be treated for postpartum depression, or the diabetes patient who just really needs to fill their insulin. Providers are forced to cut access to critical services at a time when Maryland is being watched as a leader with the total cost of care model aimed at keeping all Marylanders healthy. Restrictions impact the financial viability of health centers. In October, 2 locations in Cherry Hill and Brooklyn closed. The financial losses from pharmaceutical restrictions contributed to the center's inability to maintain behavioral health services and their payroll. Maryland's pursuit of health equity cannot backslide further. Please support House Bill 1056.
Thank you very much. Dr. Webb?
Good afternoon. My name is Dr. Wendy Webb, and I'm the Chief Pharmacy Officer at Greater Baton Medical Services, and I want to share with the committee the importance of House Bill 1056 and the 340B program to Greater Baton, a federally qualified health center in Southern Maryland, where we serve 19,000 patients, mostly low income, at 8 clinic sites throughout Prince George's, Charles, and St. Mary's counties. With one in-house pharmacy, we cover 96 zip codes. So community-based contract pharmacies are essential. Financial constraints, qualified workforce, space make it impossible for us to have contract pharmacies at each of our locations. So contract pharmacies offer longer hours, helps ensure patients have access to 340B medications, and mitigate barriers to obtaining life-saving medications. This is even more critical in rural areas. Additionally, 340B savings provides 33% of Greater Baton's operating budget, allowing Greater Baton to offer critical medications at a discount, recruit and retain more providers, and develop specialty services to meet community-specific needs. For example, with 340B savings, Greater Baton has expanded maternal health services to address scarce obstetric care in Prince George's County. This legislation will preserve and save lives of Marylanders. As stated previously, health equity starts with legislation, and manufacturer restrictions are an assault on health equity. For example, patient X that we serve lives in Glen Burnie. If they use their nearest contract pharmacy, due to restrictions, their insulin costs them $1,040.90. If they travel 2 hours round trip to our pharmacy, it's $21. So this is dramatic but true. Patients die without their medications. In conclusion, please protect our people. They rely on us. Thank you.
Thank you. Is Kevin Lindemuth here today? Don't see.
He is probably on his way. Maybe he could sit on the next panel if that's possible.
If he arrives before we close out this bill, we'll allow him to speak. Okay.
Thank you so much.
Then I will open up the floor to questions from the committee. We're going to begin with Delegate Kipke.
Thank you, Madam Chairman. Nora, one of the concerns that gets raised around this subject is that it becomes sort of a profit center for whether it's the pharmacy that gets contracted with or whatever entity would be fulfilling the prescriptions, and it doesn't necessarily work out to benefiting the patient financially anyway. So in terms of the compliance piece, can you share some perspective on that?
Yes, that's a great question. Thank you. You know, HRSA has an entire program based on compliance. HRSA, the federal government that regulates the 340B program. And not only does the federal government audit the program, manufacturers can audit the program just as much. And because of that, this compliance program actually has teeth, and the teeth sits in that if any covered entity is found out of compliance with the rules of the program, they actually have to pay back money to our manufacturers. They could also lose the benefit of being a 340B entity. The status of being a 340B entity happens annually. It has to be recertified, and they have to go through the laundry list of the compliance mandatory rules to make sure that they are committing to that each and every year, or else they lose their ability to maintain covered entity status.
Okay. I see Delegate White Holland.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill as well as for the panel. I have a question, I believe, for Dr. Ogunchisi. Because you mentioned Arkansas as an example, and so I was wondering if you could talk about challenges in other states where there have been similar laws passed, especially around litigation. So can you speak more to that?
Yes, thank you for the question. I represent safety net providers in Arkansas, Louisiana, which are two states that have passed similar laws. As I mentioned, Arkansas's the challenge was from Pharmaceutical Research and Manufacturers of America. And the main argument of the drug makers is that the 340B statute is exclusively federal, leaving no room for any state legislation. And as I've just mentioned, that is flatly incorrect, which is why they lost at the district court. You know, the legislative history indicates that Congress considered limiting the 340B statute to cover entities that have on-site in-house pharmacies. But Congress heard from safety net providers like those speaking today about the high costs and regulatory burden associated with owning and operating pharmacies. And they also learned that contract pharmacies were in existence preceding enactment of the 340B statute. So Congress purposefully chose not to regulate delivery of drugs to contract pharmacies or contract pharmacy arrangements. The practice of pharmacy, distribution of drugs, contracting are all traditional matters of state law. And that's the reason why the pharma's argument, field preemption, failed. And it's currently being appealed to the Eighth Circuit. The first question that the Eighth Circuit in oral arguments asked was, does the 340B statute contain an express preemption clause? It does not. I can't say which way it's going to go, but it indicates that the court understands that the 340B statute does not govern contract pharmacy arrangements. That's within the traditional police power of states.
Okay, thank you. Delegate Johnson.
Then a contract pharmacy arrangements are with pharmacies associated with the three largest PBMs. And in Maryland, only 17% of contract pharmacies are located in medically underserved areas. And so where's the investment in these areas, which this program was designed for?
I can take it. So there's a couple of things going on there. Firstly, contract pharmacies oftentimes may be located out of state or located in disparate areas because either manufacturers are requiring limited distribution pharmacy networks, so the covered entity can only get access to the manufacturer's drugs where the manufacturer says you can. And also, you know, this pharmacy consolidation. I mean, you contract with one pharmacy chain, you have to contract with all of the pharmacy chains. But the bottom line is the purpose of the contract pharmacy arrangement program is to allow patients access to drugs where they can conveniently receive the drugs. So, you know, I don't know about the particular stats that you've mentioned about underserved areas, but there's two critical points here. One, Contract pharmacies are used so patients can actually access the discounted drugs. Like, for example, FQHCs are required to provide drugs on a sliding fee, regardless of a patient's ability to pay. That's statutory. But secondly, the program is not only about discounted drugs to patients, right? Not all patients that are of covered entities are low income or uninsured. The legislative history indicates that the purpose of the program is to give funding to support safety net providers so they stay open in these rural areas. So they stay open and available to provide undercompensated and uncompensated services. So in short, I'm not sure about the specific stats you've mentioned, but I can tell you that covered entities are restricted right now to the contract pharmacies they use based on manufacturer limited distribution plans for specialty drugs, and vertically integrated payers and PBMs require that you use their limited distribution specialty pharmacy networks to access certain specialty drugs from them. So it's not really within the safety net provider's control, but I can tell you they want to get the drug where the patient can actually access the drug.
Good. Okay, are there any other questions from the committee? Seeing none, thank you all very much. I'll call up the next panel, please. That's John Hassel, Steve Weiner, Kevin, Lindemood if he's arrived, and Marve Howard. Good afternoon. Steve, you want to go first?
Sure, I can. Ladies and gentlemen, my name's Steve Weiner. I own Mount Vernon Pharmacy and Mount Vernon Pharmacy at Fallsway in Baltimore City. We serve Baltimore's neediest population. Our second location at Fallsway is located at Healthcare for the Homeless. I currently have contract pharmacy relationships with 4 different entities, the longest one being Healthcare for the Homeless, and that relationship has been for over 22 years. I don't want to repeat what you've heard. I'll just tell you a few little things. One of the arguments why these restrictions occurred, they started around 3 or 4 years ago. As you heard, Eli Lilly, which is the largest, most profitable drug manufacturer in the world right now, started the restrictions. And their excuse was that there is fraud and there is people who are not entitled to get these discounted drugs are getting them. And they said, we're going to do 2 things. We're going to restrict where you can get them, and we're going to require some reporting requirements. In 2014, the state of Maryland Medicaid program mandated that pharmacies that dispense 340B inventory for prescriptions put identifiers on those claims so we identify exactly who's getting this discounted inventory. So the state of Maryland solved the diversion problem. That's number one. Number two, my testimony has a link to every manufacturer letter. Initially, they said, we want you to report who you gave it to. They don't even care about who we gave it to anymore. That by restricting access to one pharmacy, they could make a fortune. And that's what they're doing.
Thank you, Steve. And who'd like to go next?
Go ahead. Sure, thanks. Good afternoon, Madam Chair and members of the committee. My name is Dr. Marvy Howard. I'm Pharmacy Director at CCI Health Services. Here again to ask for support of the House Bill 1056. CCI is a federally qualified health center, and we serve over 40,000 patients in the Montgomery County and Prince George's County area. More than 90% of our patients or our members are historically marginalized racial and ethnic groups, and nearly 1/4 of our patients receive their care in another language other than English. Most of our patients live in areas of poverty and can't afford their medications without substantial discounts made possible through the 340B program. Nationally, the top 3 conditions that our community health centers treat are with these medications are diabetes, high blood pressure, and mental health conditions. And we see more patients with complex medical needs and chronic conditions than the average primary care provider because we provide care in underserved communities. And while consistent, appropriate treatment can often keep patients with chronic diseases healthy, and out of hospitals and out of emergency departments, manufacturer restrictions do make it difficult for our patients to obtain affordable medications. It is dangerous to discontinue medication that is effectively managing chronic conditions like high blood pressure. However, in situations where a patient cannot afford to get to this designated pharmacy, providers are often forced to consider medication changes or worse, where the patient can't afford the new option and ultimately goes without the medication. This was the case with one of our families where a mother couldn't access her blood pressure medication and was ultimately transported by ambulance to emergency. And that being said, I urge you to pass House Bill 1056 to support the journey of reducing health disparities.
Thank you very much. John Hassel?
Thank you, Madam Vice Chair, and members of the committee, and thank you, Delegate Guzon, for introducing this bill. We're very proud to support it. I'm John Hassel. I work for AIDS Healthcare Foundation. We operate a Ryan White HIV clinic in Temple Hills and in Baltimore. We take care of about 1,000 Marylanders who are living with HIV who have no other way to pay for their care. We use the 340B savings. It's not profit. Let's be clear, it's not profit, to go back into our mission to take care of people living with HIV, to provide the services that they cannot get otherwise, even in the private sector and commercial market. We pay for things like food assistance, we pay for transportation, we pay for case management, we pay for the linkage specialists so that when someone knows they've been diagnosed with HIV, they have someone hold their hand for the first 3 meetings with their doctors. And then after they're into routine care, we keep them into care 4 or 5 appointments a year so that they can stay consistent with their medication and they can achieve viral suppression. 90% of the Ryan White population has achieved viral suppression. In the US population, it's only 50%. So it's working, and it can't work without the 340B program. So let's be clear. Drug companies want to restrict the use of the 340B program. They want to limit the number of pharmacies that can participate in it so that fewer prescriptions can qualify for the 340B price. That's it. So this is an arsonist that set the barn on fire, and now they're claiming to be the fire department. So I urge you to enact this bill into law, and I thank the committee for your time.
I'm going to ask again, is Kevin Lindemuth here? Okay, don't. Oh, he's in, okay. Questions for this panel? Delegate Johnson.
Thank you, Madam Chair. So the 340B program was designed to help vulnerable patients access to medications that they could not afford. So is there anything in place right now that when patients come in that they are the ones qualified for the 340B program? And is there any possibility of someone with insurance getting the discounted rate of the 340B program?
Let me take that one.
Whoever's best to answer.
Yeah.
Thank you very much for that question. So the way we use the program is that we want our patients who are 300% of the poverty level to leave the clinic and the pharmacy without having to pay anything. And so we use the savings. So if someone who has private insurance and wants to come get their HIV care from us, that's great. We'll charge that insurance company a higher price than what we paid for the drug, and we'll use that savings to help that patient that can't afford anything. So that's how we use the program. I don't know if that gets to your question. Sort of?
Or do we know that the people coming in getting the 340B price qualify for that in all pharmacies?
So here's a situation in the Ryan White context. You're 300% of the poverty level. The average HIV medications, $4,000 a month. If you got the 340B price, it's $2,000. Maybe it's $3,000. That person who's got that kind of income level cannot afford the price, the 340B price. So we use the savings so that we can hire someone to use all the different payer sources so that that patient can leave the clinic without having to pay.
Hold up, Madam Chair.
Yes.
Thank you. That really didn't get at my question. Steve Warner, can you? answer
Yeah,
that at
yeah.
all?
So the program, there's two purposes, to be clear. One is to provide discounted medicines to people with no insurance who can't afford it. And that's easy. We all get that. The other purpose of the program is to provide revenue for the covered entity so they can expand services to more patients and diverse services maybe not covered by Medicaid. So the rules are you have to be a patient of the covered entity. You can have insurance, you cannot have insurance, but legally and federally, all the rules, an insured patient of that covered entity, you can use this discounted inventory, and the profits from that benefit the entity. That's rule one. Rule two is you can't use this inventory for Medicaid fee-for-service patients. And the reason is Medicaid gets the best price in the country. And now we're asking the manufacturers to give us effectively the best price in the beginning. If Medicaid went back and asked them for a rebate, the poor manufacturers would get double hit. As much as I'm poking fun, they shouldn't get double hit. They deserve to pay one discount. When I testified about those identifiers that the state of Maryland mandates that we put on these claims, those identifiers prevent a double hit on the manufacturer. So directly for your question, both insured and uninsured, if they're a patient of that entity, you can use this inventory for. Does that?
Before I ask my question, we're gonna let Kevin speak and clearly he was running across the street from the Senate. Take a deep breath. Thank you for getting here. Yeah, the colleagues on the panel have just spoken in favor of the bill. Your name was there on the sponsor panel, but you were busy in the Senate. Thank you for making it over here, and please tell us your feelings about the bill 1056.
I apologize, but when the governor calls. So fortunately that wrapped up and thankfully the tunnels provide a quick getaway. Good afternoon. My name is Kevin Lindemood, the CEO of Healthcare for the Homeless. We're a federally qualified health center serving 11,000 people in Baltimore City and County, and Maryland's leading provider of integrated health services and supportive housing for individuals and families experiencing homelessness. Here in strong support of HB 1056. Homelessness is devastating to health, with those experiencing it much more likely than their housed counterparts to die prematurely due to acute and chronic health conditions and restricted access to care. We meet our clients where they are, and we work to make care as accessible as possible. It's absolutely critical to the health of our clients that we can purchase drugs at a lower cost, because we can't pass that cost on to those that we serve, and work with a full range of pharmacies, one of whom is right here today. We cannot overstate the importance of the 340B program to the financial sustainability of our agency. The program allows covered entities like HCH to purchase prescription drugs at the lowest prices manufacturers have negotiated nationally. This lets us purchase and provide lower cost medications for folks who are uninsured, the cost of which we cover for our clients, and receive reimbursements for drugs dispensed to those with insurance, which we then directly reinvest into our services. We do not operate our own pharmacy and are increasingly required by continually changing restrictions of drug manufacturers to choose a single contract pharmacy or to take a range of administrative steps, again, continually changing in order to access 340B prices. These manufacturer practices are escalating month after month, and they go directly against the intent of the federal program. We urge this committee to prevent these harmful practices in Maryland and to issue a favorable report on HB 1056. Thank you.
You're welcome. And I want to say just as personally, how much I admire your work. Thank you for the work you do for the homeless in Maryland, which are, they don't have a voice, and you really truly do it with your heart and soul. So thank you.
Thank you, Madam Chair.
I want to also take a minute to recognize one of my colleagues who I learned a lot from when he was here in this committee, Dr. Morheim. You can get up, and he's here visiting us today, and someone that did a lot of great work here in this committee. So thank you for being with us, and he continues to help us. Thank you so much, and welcome to the HGO Committee again. This is your house always. And if I may now, I'm going to open it up for questions from the committee. Are there any questions? I have Vice Chair Collison and then Rosenberg.
Thank you, Madam Chair, and thank you all for being here. And I add my thanks to all of you for the work that you do for our underserved populations. With the identifiers, Steve, maybe this is you. With the identifiers that are attached, is it possible to follow the money so that we see the services that I don't call it profit, but the money that's made from the 340 distribution what it goes back into? I mean, I heard what it is, but does it show in the records?
The identifiers identify when that inventory is used on a prescription claim. So you can certainly, it essentially tells the state of Maryland, hey, you're not entitled to ask for a rebate on that drug because a discounted price has already been given to the covered entity on the front end. Again, it's on a prescription claim, so it doesn't track where the covered entity used that revenue. I can tell you from experience with the 4 covered entities I've used in Maryland, none of the CEOs fly on private jets. But if that's what you're asking, no, it doesn't track it from start to the end, but it does identify exactly who got it to make sure they are a patient of that covered entity and that there's been no diversion and that Medicaid has not been billed.
Yes, just a quick follow-up then. And unfortunately, it just left my brain. So I'm just wondering, the reports that the manufacturers ask for, is there any indication, or do they ask for that information? Let me ask that.
Yeah, so again, there's a hyperlink to every manufacturer letter that's been released. And when the program started, initially they said, we want you to report your dispensing data to a proprietary company, and that company is going to determine if you build Medicaid, if you build it incorrectly, the thing that the state of Maryland's already doing. As the manufacturers have seen over 4 years that no one's smacking their hands, that they've gotten away with it, that they're limiting the sales of these drugs, they don't really require that anymore. I mean, they ask, please report to our central billing agency, but really we don't care if you do or don't. We're still going to restrict you to one pharmacy location. And I mean, listen, this isn't brain surgery. We've got an entity and you can sell a product up here or you can sell it down here. What do you think they want to sell it at? But the problem is they're not supposed to. They made a deal with the federal government. If someone testified with Medicaid, Medicare, they'll argue that they're paying rebates to other entities and they can't afford it. The deal in 1992 was before the gatekeeper fees with PBMs. They knew what they were getting into. If they've made a deal with PBMs for kickbacks to get on a formulary, they did it with their eyes open. They should have known better. Now you don't take it out of these people.
Thank you, Madam Chair. You're welcome. Delegate Rosenberg.
Since this is a federal program, has any thought been given to seeking changes or at the federal level to address the problem that you're asking us to address?
Thank you for the question. I don't think it's news to you that the US Congress right now hasn't been able to do much legislation. However, there is this there is legislation about to be introduced by Congresswoman Doris Matsui from Sacramento, who would basically clarify this whole contract pharmacy issue, basically say there should be no restriction whatsoever on the use of contract pharmacies. However, she's not in the majority. I don't think anything probably will happen during this Congress. Who knows what's going to happen after the election? There's a lot of noise in the system, primarily produced by the drug industry, that it's out of control program, that people are abusing it, blah, blah, blah. But basically, they seem to have not been able to get much traction with that position. So I don't know if that answers your question.
I don't see any other questions. I do have two unfavorable coming up, but since you don't get to ask any questions, can you tell me and anticipate what their argument will be? And can you address it?
If you look at my testimony, which I didn't read, I literally give you 12 or 15 questions that are the pros and cons of this. Here's what they'll say. Here's the answer. The big thing is that they allege there is abuse in the program and that patients who are not entitled to these medicines are getting the medications. What else? That Medicaid is getting billed twice, and that is it. And that, at least in Maryland, is not happening.
I got a few zingers for you. If the witnesses coming forward are preaching to us about transparency, why didn't they care about contract pharmacies until 2020? They didn't start these contract pharmacy restrictions until 2020, until after, I know this sounds very wonky, until the US government published.
It's a pretty smart committee. You can be wonky.
But I'm sorry, but
Okay.
until the federal government published the 340B ceiling price database, which revealed that for 9 years, the drug industry had been overcharging covered entities like us for 9 years, and they got away with it. And so now they had to refund all that money back to the covered entities, and they got caught with their pants down. So if they really believe in transparency, why weren't they transparent for the first 9 years? This was after the Affordable Care Act passed. The second thing, if they believe in transparency, why don't they tell us where they get the average manufacturer price, which is a factor in the formula for determining the lower 340B price? They won't tell us that. That formula includes things like the consumer price index, which is factored into how they get the price, where we know that where the CPI comes from. So these people that are advocating for restrictions on the contract pharmacy thing say it's about transparency, but I beg to differ. So those are a couple of things that you might want to consider.
And I asked each and every one of you, so feel free to.
And I would add, Madam Chair, in the meantime, and perhaps this answers Delegate Rosenberg's question about why, in the absence of federal action, we're bringing this to the state level. In the meantime, covered entities like Healthcare for the Homeless and the other federally qualified health centers represented here face declining revenue sources and an inability to meet a growing need for access to healthcare among the most vulnerable members of our community. The program was designed federally to ensure that we had that income source. And because of these practices, right now, this is why we can't wait for Congress to get its act together. Right now, we're receiving both more hurdles to accessing these resources and demonstrably fewer dollars because of these practices in order to provide those services.
Thank you very much for the work you do for the state of Maryland and for people that are truly need a voice. We thank you for being with us today, okay? You have a blessed day. Now, I would like to call a panel of unfavorable, which is Kristen Pardee, and I hope I pronounce your name correctly, and Brad Stewart. And good afternoon, how are you? You're not there yet, so you can't answer me. I'm so glad. Thank you for being with us today, and thank you for being patient as we called you. And I want to thank everyone else who's waiting for their bill to be called for being patient, okay? Why don't you get started? Who would like to start?
Good afternoon, Madam Chair and members of the committee. My name is Kristen Pardee, and I'm a Deputy Vice President for State Policy at Pharma. I have to say it's great to be home. I was born in Columbia, Maryland, and was raised in Baltimore. My parents still live there, and it's always nice to be here. I want to thank you for the opportunity to offer testimony today in opposition to House Bill 1056. I want to start by saying Pharma is absolutely committed to the 340B program, and we believe in the need for systemic change to the program at the federal level. As mentioned, this program was created by Congress in 1992, so it's well over 30 years old, to help safety net entities access affordable drugs to treat low-income and uninsured patients. But due to weak oversight, this program has expanded in a way that has allowed covered entities, which we discussed earlier, so that's these grantees like the ones that you heard from today, as well as large nonprofit hospitals, to use the discounts intended to help patients for their own growth and other needs. This is now the second largest prescription drug program in the country, right after Part D. The reforms that must come at the federal level are because, again, it's a federal program. It is gone away from its original intent to help these safety net hospitals, and we are on record being 100% committed to reform at the federal level. We're actually in a coalition called ASAP 340B fighting for this. And I know this just came up, and a discussion draft was just recently released in Congress to do comprehensive reform. Actually, one of the lead sponsors is Senator Cardin. And there's some additional legislation that is also being considered by Congress. House Bill 1056 would exasperate and codify existing problems as a handout to certain middlemen like PBMs and contract pharmacies, and it's under litigation. Both bills that have passed are current litigation. And I'm sorry, I will not go further. Thank you.
You can go ahead and finish.
Oh, well, thank you very much. So the requirements of this bill, we talk a lot about the covered entities, but they're about the contract pharmacies, which have grown by 8,000% just since 2010. And when we look at access, the patients that are receiving drugs at these contract pharmacies, it's estimated that only about 1.4% of them receive the discount. So that is, and those are for those who we saw with a discount card. And when they did, it was about 92%, which is great, but too small of a percentage. And finally, actually, I already went through the litigation. So with that, I will close. Thank you.
Thank you. Hi, how are you?
Good. Thank you, delegates. I appreciate the opportunity to be here. My name is Brad Stewart. I'm with the Maryland Tech Council. I'm the chair of the organization. I serve with the esteemed Kelly Schultz, who's our CEO. The Maryland Tech Council represents 789 companies in Maryland, life sciences and technology companies, and tens of thousands of employees here in Maryland. Met many of you before. I've spent the last 30 years in the life sciences industry, 27 of them here in the state of Maryland, advocating for our companies and helping the industry to grow. As you'll see today, we're in favor of anything you do to help reduce the cost that our citizens of Maryland pay for prescription drug prices. The pharmaceutical industry provides discounts of hundreds of billions of dollars a year to the healthcare system. Unfortunately, most of that money does not go to the patients. Most of it is absorbed in other entities in our arcane healthcare system that has billing and collections that are almost impossible to comprehend by people who even do this for a living. The 340B program is a great program, and delegate, to your question, I acknowledge and stipulate the intent of the program is to allow those 340B entities to retain the profits they make from selling those drugs at a discounted price, and to use those profits to subsidize other services they provide to the patients that they serve. I think you've had a great panel of people here speaking in favor of this bill, and I think those are the exact entities who should be benefiting from the 340B program. The challenge is the people who are benefiting who are not those entities. And that's ultimately the challenge. I think there's an opportunity for this committee to figure out how to address, whether it's in amendments or in further thought about it. What essentially happens in many cases, these are the people who should benefit from those services they provide should be subsidized, and we agree to that. The challenge gets to be when you have large healthcare companies who take these drugs, purchase them at prices intended to support our healthcare system, and then sell them for a profit to subsidize their other businesses or to generate profit for themselves. And that's really the issue that we disagree with here and request an unfavorable report.
Thank you very much for the work you do and for being with us today. I'm going to open it up for questions now. Are there any questions? I have Vice Chair Collison, followed by Rosenberg and Kipke.
Front row.
Actually, may I go to Kipke because he hasn't asked one. Go ahead, Kipke.
I don't mind if the vice chair goes, but thank you. It's interesting. I thought I knew a lot, and then I learned about this and realized I didn't know a whole lot. But the thing that was said, that there's two things that were said that caught my attention. One was that this is the second largest program aside from D, which was surprising to me. It's an enormous program if that's the case. In that vein, I imagine there's a real need nationally to create clear rules around it. And you mentioned that Senator Cardin is sponsoring a bill in the Senate to do that. But what I'm curious about is this pocketing the difference that's charged between a private payer and with a negotiated rate for this 340B. Has that always been the program? Is that or is this an evolution that people have taken advantage of a loophole or something like that? I was surprised to learn that they could pocket it to help with their operating costs, because it sounds like that's what they're using it for. And then quickly, the gentleman just mentioned that I think your words, the problem is the people who are benefiting from it that shouldn't be. But you didn't say who they are. Could you help me better understand? So there's two questions there, Chairman. I put them out there quick to save time, but if I could get an answer to those two questions.
For the first question, who's the best person that can answer that question? Because I know one is for you. Can you handle both or?
I'm happy to handle both if you'd like. So yes, from the start of the legislation, the intention was that entities like community healthcare groups like you've heard from today, that they be able to buy those drugs at a discounted price, sell them to whoever they were, whether they were people who were indigent or otherwise, retain those profits to be reinvested in other services for those people. So if we were to provide dental care or other services that people are talking about, absolutely the intent from the inception at the very beginning. So it is a source not only to provide discounted drugs to underinsured, underserved, uninsured patients, but to allow those safety net providers to make profits where they can, but to reinvest those profits. I'm fully in support of that. I think we all should be. I think the challenge gets to be when you look at large healthcare systems. If you were to take a healthcare system, let's say had a hospital in Baltimore, and as a result of their population qualified for the 340B program, but operated other facilities around the state of Maryland where people had many means, had the ability to pay for healthcare, were insured and otherwise, and yet we're still using those the drug pricing for 340B to subsidize their other operations to make profit. That's exactly what this program should not be used for.
Welcome. Delegate Collison.
Thank you, Madam Chair. So I guess I'm puzzled because I hear what you're saying, Brad, in terms of who the program was meant for.
Yeah.
But those were the people who came to the table today to say they needed this bill. It's not the folks you're worried about, the major health care entities. So why are we hearing from the exact organizations that the bill was made for and they're concerned about it when I'm hearing you say those are the people we want to give them the drugs to?
Yep.
If you don't mind, I can quickly jump here. I think it's good to keep the perspective of when this law was created in 1992. It was really focused on safety nets. So you had fewer than 50 hospitals that were participating in the program at that time. Now it's close to 2/3. Now you have so many other third-party entities. And so it's become sort of this machine, which, there's over $100 billion in discounts last year. And so while, when you look at the grantees, and grantees are called that because they receive a little bit of federal money, they have some more transparency. They are doing absolutely wonderful things, and we absolutely agree with that. We're actually working with their national association at the federal level for systemic reform for the community health centers. The hospitals have really taken over the system. And then the contract pharmacies have, and the contract pharmacies apply across the board. And so when we look at this bill, it's about contract pharmacy, which is not in federal statute and which has grown, as I said, over 8,000%. It went from having about 1,000 across the country to 33,000 because there's a lot of money to be had in it. The pharmacy profit margin is 71% on 340B drugs compared to about 22%. And so you've really created this whole new world economically. And that's why Congress needs to revisit what was 8 pages of statute back in 1992 to address the new size of this program.
Delegate Rosenberg.
You may have answered my question, but again, what can we do at the state level to address these problems to the extent that we're not preempted?
Well, I would start by the problem is across the system. So it's every single state, and having a patchwork of different fixes to one element of the system is problematic. But the real issue is that because it's a federal program, there is the problem with preemption. So that's why there's litigation in Arkansas and Louisiana. The Arkansas litigation is on appeal right now. I would encourage you to also encourage federal reform. I know no one wants to hear that at the state level, but this program is specifically federal, and it is incredibly important. And there's so many elements to it that need to be addressed that just doing something on contract pharmacy really codifies what is the problem in it right now, but it's not addressing all the other things that could really make this a more patient-centered program where they are benefiting from the discounts, where, there's a little bit more ability to follow how these dollars are being used. And they are being used for many good things, as was said. But again, that really involves a 100% reform to the system.
And I know Delegate Kipke has a question, but I have, actually, let me allow Delegate Kipke and Johnson, and then I have a few that I'll get to if it has not been asked. Delegate Kipke, followed by Johnson.
Thank you, Madam Chairman. If the issue is that it's being used for people that it wasn't intended to be used for, isn't there a way to restrict its use to the individuals that flow through the whether it's the Ryan White Center, through these community-based healthcare centers, either through auditing, or isn't there a way to, if the idea is that the hospital in Baltimore that's rightly participating is using it in their a sister hospital in a more affluent community, and they're pocketing money off of that, which wasn't the intention of the program, isn't there a way to prevent that from happening?
So, do you mind? I'm sorry. So the way the law is written federally is that it's an entity-based law. So not, you don't have a patient that qualifies like in Medicaid where you might have, certain income requirements. In 340B, it's just if you go to a 340B facility, and those can be things as large as University of Maryland's healthcare system or Johns Hopkins. And that's why regardless of having commercial insurance, regardless of what your income is, you would then be considered a 340B patient because that's not defined.
Yeah, and I agree with that. I think the challenge is, I don't have a pragmatic answer to your question about preemption. I think the reality is it's the large healthcare system providers who are the people who complicate this process. If you're talking about community providers like we've had here to testify today, I don't think, one, those are the issues that are causing problems in the system. And two, I think their points about their patients being able to access drugs are perfectly fair and appropriate.
Delegate Johnson.
Thank you, Madam Chair.
You're welcome.
So you brought up something that I wanted to ask a question about. So a hospital that participates in the program. So say they have other clinics that are affiliated with the hospital or pharmacies that have a contracted or agreements with that hospital. in the program. Since this is a federal program, can they expand those into some of their other facilities or pharmacies or clinics outside the state, and some of that savings, we'll call it, that should be spent in Maryland underserved areas? Could that money possibly be going outside of our state?
Yeah, I think there's almost two parts to that. So on one element, when I was speaking about contract pharmacies earlier, in Maryland, if you look at the amount of contracts pharmacies, I think it's around 900, give or take. About 600 of them are in other states, 25 other states. Of course, here, there's going to be some in Virginia. Of course, there's going to be some in the areas surrounding, but they're as far as Texas and California. And so there's that issue. So yes. The other issue is, as we've seen, hospital growth, a lot of, physician-owned practices being purchased in all sorts of different areas, that really expands their 340B sort of extension, where they're also getting the profit from those different, what they call them child sites, but, just basically outside of the one buildings, having other entities.
Thank you. So are there any other questions before I ask a few? All right. So when you spoke, sir, you talked about some of these entities perhaps doing something improper or not using the funds where they're intended to. But my question to you is, all 340B cover entities are required to have regular audits, correct?
They're required to have regular audits, but that doesn't necessarily tell you what the use of those funds is. So if you're a 340B entity and you have 60% of your patients are billed to insurance and other things, you can use those discounted drugs and bill the insurance company that full price. That's permitted currently under the law.
But it's permitted, but they receive audits, right? They are audited to see if they're violating the intent or not fulfilling the intent of the program.
Would you mind if I step in?
Sure.
So yeah, under HRSA, which, oversees the 340B program, they do have the opportunity to audit. Audits are roughly fewer than 200 a year. So when you look at the mass world of the 340B program and how many covered entities there are, that's obviously a very small portion. They do highly encourage 340B entities to self-audit every year, which is of course just a good business practice. Manufacturers, you'll hear a lot of times, have the ability to audit. That is a very challenging process. They have to go through a lot of efforts with HRSA to be able to get that ability. And you see those in very, very, we're talking small digit numbers of audits that happen on that level.
But they can be audited, and they know that they can be audited, right? And
Absolutely.
if an audit is done and it's improper, or they're not fulfilling the intent of the program, it will show, correct?
That's correct. And if you see a lot of the ones that they've done, they do show that they have, there are issues with diversion, which I'm sure happens. I mean,
But for some, but not for all, correct?
Oh, correct.
Because I can tell you that the ones that were in front of us have not, right? So we cannot paint broadly.
No, I absolutely would not do that.
And there are currently about 12 states that have pending bills like this one, correct?
So this year, there are actually 19 states.
19 states.
Yes.
And the reason why, it's because, and with a lot of these bills, the federal government doesn't have their act together, right? So the states are the one that are basically, when these entities don't have the resources, we, the state, have to go into our general fund and pay for a lot of these services. And that is the reason why states are now acting. And will you tell us and tell this committee of the lawsuits that are pending and the lawsuits they have actually gone through the system, have they fared well for the states?
So there's really two sets of lawsuits. The ones you hear about that are largely more individually about whether contract pharmacy is required by federal law. Those have largely sided with the company stating that that's not the case.
Mhm.
The two that are specifically on this type of law, similar
Mhm.
laws, are still in the process. Louisiana just passed a law last year, so they're very early.
Mhm.
Arkansas, it was 2 years ago. There was an argument that was, I'm not a lawyer, so I don't want to misspeak. But as we had mentioned earlier, that is on appeal. We don't have a timeline on it though, and
An
sometimes.
appeal for who's appealing?
So we're appealing in Arkansas.
The company's appealing, so
company-
the state won in that one.
Yeah, that's actually a pharma as well as some other
Mhm.
entities.
Right. Okay, thank you. Thank you so much. I appreciate you today.
Thank you.
All right, have a blessed day.
Thank you.
Thank you. And actually, this concludes the bill hearing on House Bill 1056. We are now going to go to the next bill hearing, which I believe is House Bill 879. Am I correct, Delegate Johnson? All right, and will you be so kind and bring your panel, which it is Melissa Hurt, Megan, and Matthew. Thank you. And thank you so much for being with us. And for those of you that are waiting, we're very grateful and we'll be with you.
Two Matthews.
Call whoever you want to. Thank you.
If you wouldn't mind if I let Matthew tell it right here, but. Somebody drop their phone. Let's see, 4 years, 5 years.
Now that's a picture, Delegate Johnson and Mr. Shalantano. Guys, take that picture now. You may not see it again.
It's a rare thing.
Go ahead, smile for the camera. We're taking it. All right, Delegate Johnson,
Thank you.
you're welcome.
Good afternoon, Madam Chair, Vice Chair, and members of the HGO Committee. For the record, I'm Delegate Steve Johnson here to represent House Bill 879, Health Benefits Plan, Calculation of Cost Sharing Contributions and Requirement of Prohibitions. We've heard it for the last couple of weeks that there are going to be a couple bills come to this committee that will create instant relief for patients at the pharmacy counter. Well, this is one of those bills. And so I'm proud to have this bill this year. Marylanders living with chronic and rare conditions rely on high-cost specialty drugs. To offset the high out-of-pocket costs, patients will apply and receive copay assistance. The majority of the copay assistance is provided by pharmaceutical manufacturers to patients taking one of their products. Copay assistance is also provided by patients by some nonprofit organizations. In recent years, health insurers and pharmacy benefit managers, PBMs, have begun implementing new programs that prevent any copay assistance funds from contributing or counting towards a patient's deductible or out-of-pocket maximums. These programs are often referred to as copay accumulators or copay maximizers. These programs eliminate any benefit from copay assistance and result in a significant financial barrier to accessing treatment. Instead of refusing to accept copay assistance, insurers and PBMs pocket the assistance funds and then double dip by again collecting full out-of-pocket costs from the patient. When facing high out-of-pocket costs, patients do not use their medications appropriately. They skip doses to save money or abandon treatment altogether. To date, 19 other states, including neighbors, Virginia, West Virginia, and Delaware, the District of Columbia, and Puerto Rico have passed similar legislation. House Bill 879 ensures that copay assistance, a vital source of financial assistance for Maryland patients to afford medications, will count towards their deductible or their out-of-pocket maximums. When calculating an individual's cost sharing requirements, insurance carriers and pharmacy benefit managers must include amounts paid by the individual or by other persons on behalf of the individual. The legislation separates health benefit design from the availability of patients' assistance. There is no evidence to suggest that premiums have increased in any states due to legislation enacted to ban copay accumulators. This is something that we can do. that will instantly help patients at the pharmacy counters. It's the right thing to do. And for that reason, I would request a favorable report on House Bill 879.
Thank you very much. And I have to say, Delegate, you are a miracle worker. That's a
It takes a
compliment.
team, Madam Chair. It takes a team.
Thank you.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Matt Prentice, and I'm the Director of State Policy with the Immune Deficiency Foundation, headquartered in Hanover, Maryland. On behalf of the Maryland All Copays Count Coalition, we strongly support House Bill 879. I don't want to repeat what the delegate just provided in terms of what these programs are or what they do, but I will want to highlight a few points. Health insurers and PBMs will say that these programs help reduce healthcare costs by making doctors and patients try cheaper alternatives. However, as we have submitted for this hearing, studies show that for specialty medications where copay assistance was used, only 3% of those claims were for a product that may have a generic alternative available. Additionally, you may hear that these programs are in place to reduce costs for all patients and consumers. However, in the 19 states that have banned this practice, there is no evidence to suggest a correlation between banning these programs and an increase in premiums for all of us. That means that copay assistance doesn't steer patients to costly medications. It doesn't make healthcare costs increase for all consumers. It only provides financial help for patients to access the medications they rely on and that their doctor has concluded is best for them. To date, 19 other states, including neighbors Virginia, West Virginia, and Delaware, the DC and Puerto Rico have passed legislation to ensure that copay assistance counts. We respectfully request your support for House Bill 879 to ensure Marylanders can fully access the lifeline that copay assistance provides.
Next, please.
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP in favor of House Bill 879 with the sponsor amendments. It is getting really strange to say that over and over, but here we are. And I want to personally thank Delegate Johnson for listening to our concerns with the bill that was introduced. He convened a stakeholder meeting a few weeks ago in which we discussed the bill, our problems with the bill, and potential amendments to alleviate our concerns with that bill. And Delegate Johnson has graciously accepted those amendments. So I think we had a very productive conversation that led to the bill that you saw or should see before you today with sponsor amendments that add consumer protections to the bill. And it appeases our worries about the runaway drug pricing concerns that were in the introduced model. This, like Delegate Johnson referred to, the sponsor amendments that you should have are based on the DC model, so right down the road. Once again, we want to thank the sponsor for working with us. We're happy to sit here favorable, although it's messing with me on a very existential level. And we urge a favorable report on House Bill 879. Thank you.
Thank you so much for, coming to the table always. We appreciate it. Next, please.
Sure, please.
Good afternoon. My name is Melissa Hurt, and I am here on behalf of the hemophilia community. My son Jay was born with severe hemophilia, and I have moderate hemophilia. We live in Lothian, Maryland, and I am here today to ask you to vote yes for HB 879. In November, I signed up at the Maryland Health Connection for health insurance, and we rely on copay assistance from the manufacturer to offset our out-of-pocket expenses. So I was shocked to learn the insurance carrier I selected on the Maryland Exchange will be pocketing the $10,000 copay assistance provided by the manufacturer for our benefit and will prohibit these funds from being applied to our deductible and annual maximum expenses. I read my policy and nowhere is this information disclosed. I ask, how is this practice ethical? I attended yesterday's Senate meeting, and here's what some of our opponents said to this policy. The word coupon was used a lot. The copay assistance I receive isn't a $10 coupon off Nexium that I redeem at pharmacy checkout. My copay assistance from the drug manufacturer goes directly to the insurance carrier. Excuse me, but the analogy to this is that carriers are taking the manufacturer coupon at point of purchase, but not changing my price to reflect the coupon discount. Copay accumulators also prohibit third-party assistance from all organizations, including nonprofit. Our opponents also said that copay assistance steers patients to more expensive drugs. This is not true. I'm retired now, but I spent 25 years in pharmaceutical sales, and here is how a medication is selected by a provider. The drug maker agrees to a discounted price in return for formulary position. Drug makers agree to rebates for further discounts based on market share. Specialty drugs, I will end my testimony. Thank you.
You can go ahead and finish it. Finish the sentence or two.
Thank you very much. Specialty drugs are not one size fits all. If they were, they'd be generic. But my one last important point is when a provider selects a drug for a patient, he or she considers two things. One, which drug is the most efficacious and safe for the patient, and will the insurance pay for it? Insurance companies enforce formularies by requiring step edits for patients. So drug selection is absolutely not something that I have very much participation or say in. Thank you for your time, and I very much hope that you will vote yes for HB Bill 879. Thank you.
And thank you for sharing your family's, journey with us, okay? We appreciate it.
Thank you.
And Madam Chair, if you
Yes.
don't have those amendments yet, they are on the way.
Okay, wonderful. And then to give it to Lisa, send to the committee. Thank you, Delegate. I'm gonna open it up for questions now. I have Delegate Hutchinson.
Madam Chair, I do sort of a two-part question. First, I want to ask Matt number two. I wasn't sure for your facial reaction and all, but did you agree with everything that woman next to you testified on?
We are in favor of the bill with the sponsor amendments. I don't necessarily agree with some of the things that some of the other proponents have tried to characterize as the way that the drug price chain works and how carriers feel about coupons overall, but I'm happy to support the bill as amended.
And Delegate, since we don't have the amendments, could you possibly walk us through quickly what the amendment did to change the bill from its original form?
I'm happy to do it. So there's three basic amendments. First, one of the main problems the carriers have had with copay accumulator type bills is that the coupons only last for a certain amount of time, and they generally lead to the higher priced brand drugs, which is fine, but those coupons are tied to those specific drugs, and it's not all drugs, it's just some. So if we want to make sure that we're helping the consumers, the First Amendment would make sure that the coupon lasts for the entire plan year, not a part of your insurance year. The second would be that we would not offer a coupon if there's a generic alternative. If there's a generic alternative that's just as effective, we should be encouraging folks to use the lower cost drug. That's not to say anything about a doctor. If the doctor says that you have to be on another drug, that is still the doctor's choice. It's just in the coupon sense. It has nothing to do with doctor's decisions. It has everything to do with the payment structure and the coupons. And the last amendment is to make sure that we have that high deductible IRS amendment that you have to put on basically all the bills to make sure we don't preempt federal law. And that's it.
Do you have a follow-up, Delegate?
Sure.
And thank you for your question. It was very good. Taveras, followed by Chisholm.
Thank you, Madam Chair. How many patients, this question is directed to Mr. Matt.
Celentano.
No.
Oh, other Matt.
Second
Matt number one.
Matt number one.
We'll argue about that later.
How many patients can access a cheaper drug that works the same as the medication they're currently on? And are there any biosimilars?
Sure. Thank you for that question. And I think it provides a bit of pretext, or I'd like to provide a bit of context to the First Amendment in two ways. I think the idea of the amendment that would still permit copay accumulators, copay maximizers, these programs we're talking about, to be applied for a patient that's choosing a generic drug, or I'm sorry, choosing a branded drug when a generic alternative is available. I think that misrepresents the situation in a couple ways. One, I think I want to highlight that would assume that either the patient or provider has identified a branded drug as being better than a generic for any reason related to the copay assistance, which I think that kind of accusation, or at least characterization, is troublesome. And then two, I just want to highlight that copay assistance does not circumvent health plan design. right? So it lives outside of it. Now, copay accumulators and what this bill is trying to stop bridges that gap between copay assistance and plan design. And so that patient who would like to use copay assistance for a branded drug, even though a generic is available, I would find that hard to exist because, for one, PBMs would have and do set formulary restrictions where they would not even have a branded drug available with a generic. That is, or have a branded drug on the formulary with a generic available. Second, for that patient to get to the point to use copay assistance at the pharmacy counter, it's highly likely they've already gone through one, if not multiple, episodes of utilization management where, through prior authorization, they and their doctor have sufficiently shown that they need access to this branded drug versus the generic alternative, or in the case of step therapy, they have gone on an alternative, perhaps the generic, have failed on that in order to have access to the branded drug. And so, although I'm very respectful to the interest in compromise, and I'm very open to talking about these amendments and looking at them in language, I just want to highlight that I think that First Amendment is trying to address a problem that I don't believe exists. And at worst, it potentially will exclude patients from what this bill is trying to do.
Okay, you okay, Delegate? All right. All right. Wonderful. Delegate Chisholm, followed by Delegate Olston, then the Vice Chair.
Thank you, Madam Chair. And I think
You're
Mr.
welcome.
Prentice just answered the question. But because we've become the committee of Kumbaya here recently, I just wanted to make sure that, because I saw the Care First is in, they're in favor of the bill as well with an amendment. And I think that your comments just address that, but I wanted to give you another shot at making sure that Care First amendment is what you just spoke to. Am I correct on that?
Yes, so I'll just kind of touch to it in totality. And again, full respect for both the panel, Delegate Johnson, his leadership on this issue. The HSA language, do not have a problem if it helps with the enforcement of this. I think that's great. The information about the patient assistance being required for the year, the notification, again, from the patient perspective, I don't feel particularly strong, and I know patient organizations don't either. I will highlight that the only issue with copay assistance right now that I'm aware of, and that on behalf of the coalition, is the PBMs and the payers not applying it to the out-of-pocket costs. It's not in the manner that they receive the copay assistance from drug manufacturers and other third parties. And so, I guess in some ways it seems fine. I again believe it's searching for a problem that I don't think exists. And then again, I don't want to reiterate too much of what I just said, but for that First Amendment, I do worry that we are kind of establishing a baseline that these programs are harmful to patients. And then that First Amendment tries to navigate to a certain patient population where these can continue to exist. And that's concerning.
You're welcome.
Thank you,
Go
Madam
ahead.
Chair. I'm gonna stay with Mr. Prentice here. Could you explain the difference between coupons and copay assistance?
Yeah, I mean, I think just briefly, I'll kind of build upon what Melissa touched on. That terminology of a coupon, I think in some ways is used okay, right? It's a way that patients save money. So it's called a coupon. I think in some ways that characterization is troublesome because I think it suggests, again, that these are a marketing tool, right? That there is some role of copay assistance in steering patients towards a certain drug, or doctors and patients towards a drug, or convincing a patient to choose an alternative instead of another one because they have the copay assistance. So I think of a coupon as a way to get somebody in a store to buy something because they got it out of their Sunday newspaper. And that's not what copay assistance is.
Okay, you need more? Okay, thank you. Vice Chair.
Thank you, Madam Chair. So Mr. Prentice, I'm going to come back to you. I represent an area with a very large senior population who are very active and vote and talk to me a lot. And I hear from them that they got a coupon and they were very happy. And they were able to buy their drugs, and because they had this assistance. And then all of a sudden they couldn't because they were told the coupon ended. They're not notified that the coupon ended. They never know how many coupons they're gonna get. So for me, what that First Amendment does is give some predictability to the patient, number one, and the carrier, number two. So for me and I would suggest that in every single pharmaceutical ad that I see on television, it says, and these are expensive drugs that are advertised on television, if you need help paying for this, see the manufacturer. Again, without some sort of reliability about how to make this work for the patient, to me, there is an element of steerage there, particularly when they're spending billions of dollars on advertisements. So I guess I'm puzzled that you haven't heard from patients their concern, particularly about, the coupons or the assistance being cut off.
Yes, so I'll just kind of touch on that. So first, I want to make it clear that in terms of the amendment that I'm talking about that I have issues with, it's not that one with the patient assistance being provided for the entire year and advance notification being to the patient. I think the point I was trying to make is that addition to the legislation is not coming from the patient perspective in the sense that we didn't introduce it. And I think I want to speak to, my organization in the rare disease community. I am not aware of the patient assistance programs that serve our patients, leaving them stranded. I mean, that's just me being as honest as I can. I would not doubt that it exists for other medications, other patient groups, or other prescription drugs. So I just wanted to speak on what I mostly clearly can be honest about.
Madam Vice Chair, being a previous pharmacy owner,
Let me just say, Delegate Johnson, I have a follow-up for you. Can you tell me your experience so that I don't violate my own rules because I've been doing it? Go ahead.
thank you, Madam Chair. We want to keep it square in the pharmacy, in this committee. Being a previous pharmacy owner, we used to call that the dangle and snatch because they would dangle the coupon and it was good for usually up to 90 days. And then when they came to refill the prescription, there was no coupon. And then they were paying the higher price for the drug for the rest of their plan year. So one of the amendments does address that if they're going to offer a coupon, it has to be for the rest of their plan year. So they don't get started on a brand drug or whatever the drug may be. And then next thing you know, the coupon's pulled out from under them because this has yielded quite a bit of money for the manufacturers to get them started with a coupon and then leave them with the high price of brand drug for the remainder of their contract year.
So I don't see any other questions. I do have one for Mr. Prentice. Usually when we have a sponsor panel is supportive of the sponsor's position. So I must say that you have left us a little bit, we don't get shocked here, but a little bit surprised. That being said, I'm very respectful of your opinion and I understand your position. So I want to say to you, it is with these kind of bills, it is difficult. You have pharma, you have the insurance companies, and you have the little person here that you represent that we're trying to help with no voice. And oftentimes, it just takes a lot to get to that table where you get someone like Mr. Chalentano, which is why you saw we took the picture, to come on board and say yes. So we are, in this committee, we're not all or nothing. Right? Because right now, if we don't pass this bill, it's worse than if we were to pass it, right? So I just want to leave you with that thought that it is compromise, it's an art, and it's very difficult, right?
Absolutely. And thank you, Madam Chair.
Okay, thank you. I hope you have a blessed day, and thank you for everything you do. Next, I'm gonna call the following people. Is there a Therese Hessler or you testify? You, okay, wonderful. I have Tricia Swanson, Brad Stewart, Kaylee Locklear, Len Kilpatrick, Dana Kaufman, Donna Kaufman. Okay. Good afternoon.
Afternoon.
You go.
Who would like to get started?
Okay, if I go.
Definitely.
Delegates, once again, thank you for allowing me to be here. For the record, my name is Brad Stewart. I chair the Maryland Tech Council. And as I mentioned earlier in this session, we are wholeheartedly in support of any bills that actually help to reduce the cost of the money that patients in the state of Maryland put out of their pocket to receive medications. The pharmaceutical industry provides discounts and rebates of hundreds of billions of dollars per year throughout the healthcare system, most of which are retained by people who are not the patient. This is a bill that makes an incredibly foresighted effort to change that, and we fully support the efforts to cause those rebates to flow back down to the patients. We have another bill that we'll talk about later, but in this case, many of these are expensive medications, as many of you have said. To make these affordable for the patients, the companies are willing to give them discount cards or pay their co-pays, which may be hundreds or thousands of dollars. We'd like to see that patient actually go to the patients. For those of you over the years who've become familiar with pharmacy benefit managers, in my opinion, most of their purpose is to maximize the profits they receive. It's not to minimize the cost of medications. It's not to improve healthcare. It's to steer a patient to the most profitable medication they can dispense. So this is an example of that. When the patient is given the opportunity to save money, pharmacy benefit managers say, well, that's fine. You can save money there. I'm just going to take it out of your pocket on another side. And I think this is a great opportunity to rectify that situation. Thank you.
And thank you for your testimony. We appreciate it. Next, please.
Madam Chair, Madam Vice Chair, members of the committee, my name is Tricia Swanson here on behalf of Care First. I also want to thank Delegate Johnson for his leadership on this bill and convening all of us together to allow me to be up here favorable on this bill with the sponsors' amendments. You have the amendments in my written testimony. I know that they've been referenced, and a lot of what I was going to talk about was addressed in some of the questions that happened. The only thing that I'll highlight is in the Senate hearing yesterday, there were a lot of conversations about how many states that this is passed in. And I wanted to just let the committee know that Arizona, Colorado, Georgia, Kentucky, Maine, New York, North Carolina, Tennessee, Texas, and Washington State have all passed this bill with that generic language in there. And most recently, Care First worked, as many of you know, we operate in Washington, D.C. too. And that bill just recently passed, and that also has that generic language that's referenced in my testimony. I know you all have a long day, so I will just leave it there, but would urge a favorable report with the sponsors' amendments.
Thank you. Nice to see you at the table.
Thank you.
Next, please.
Madam Chair, thank you very much. Committee members, thank you. For the record, my name is Lance Kilpatrick. I'm the Maryland Government Relations Director for the American Cancer Society Cancer Action Network. I want to qualify that my testimony in favor is based upon the original legislation, as I have not seen the amendments yet and cleared them with folks who are much smarter than me within my organization. Okay, but let me say this. The cost of buying cancer-fighting medications can be very expensive, as you all know, often running in the thousands of dollars. And for those with high deductible health insurance policies, the out-of-pocket costs for these medications can be incredibly burdensome and prohibitive. In our 2022 ACS CAN Survivor Views survey, over 70% of respondents were worried about affording care, and half of cancer patients and survivors reported incurring cancer-related medical debt. Women and African Americans in particular were most likely to experience cancer-related medical debt. Now, I want us to keep the eyes on the prize, if you will, and the intent of this legislation, and that is helping patients with their out-of-pocket costs. Any amendments being offered, and like I said, I have not seen them yet, but any amendments being offered that serve as obstacles or barriers to that intent should not be viewed favorably. Whenever a patient gets financial assistance, it all should be able to be applied to insurance deductibles. and insurers should not be able to pocket that money and tell patients, it doesn't count, you still owe us. So please, I ask that you report out the strongest version of this legislation and favorably at that. Thank you very much.
Thank you. Nice to see you in that role. Congratulations. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association. I will be extraordinarily brief. We're honed in on the section of this bill that has to do with patient choice. And we believe that patients should be able to use whatever pharmacy of their choosing to acquire their drugs. So I'll just be brief and say we support the bill. Thank you.
Thank you. Are there any questions for this panel? Seeing none, thank you so much for being with us today and for being at the table. We appreciate you. Next, we have Ms. Kaufman. Is she here? All right, let's go to a panel of unfavorable. And if I may have Heather Casconi, Michael Johansson, and Camille Fish.
Good afternoon, Madam Chair. I am happy to keep my testimony brief. In fact, given consideration of the bill in its amended format, PCMA would like to request the permission to officially change our position, which was previously entered into the record here, and we are now favorable with amendments and with our thanks to Delegate Johnson.
Take a picture of that.
Okay. Okay. Thank you so much. That is wonderful. You see, I'm speechless. Go ahead.
Well, we're
Any questions?
appreciative of the compromise and very appreciative of all the time and effort on the bill. Thank you.
Thank you very much. Delegate Hutchinson.
Madam Chair, I'm sorry, just who do you represent? Just want to be
Oh,
clear.
I guess that's, yes. Hi, I'm Heather Cascone and I represent PCMA, which is representing the Industry Association for Pharmacy Benefit Managers.
Thank you.
Okay.
Sorry.
No problem. That's it. That is wonderful. Thank you so much.
Thank you.
You have a blessed day. We appreciate it. Camille, are you testifying? You got it? Okay, great. Great to see you. Okay, let's go to a virtual favorable. Megan, do you see her there? And also Keith Lake. There's two people, Megan Wenranch and Keith Lake. And this says virtual. Only Keith? All right, will you be so kind and let him in? Thank you. Thank you, Marcy. Marcy volunteered with us today in the committee. It was her first day volunteering. Yeah, thank you. Hi, Mr. Lake, how are you?
I'm great. How are you this afternoon?
I'm doing well. Thank you for asking. Can you be so kind and give us your testimony?
Yes. Well, good afternoon. My name is Keith Lake. I'm a regional director for state affairs for AHIP. AHIP is the national association whose members provide healthcare coverage and services to hundreds of millions of Americans, including to many in Maryland. I am appearing before you today to ask for an unfavorable report on the as introduced version of the bill. However, given that, as we just heard, the sponsor has agreed to several amendments, so I'm not going to give that original testimony. Instead, I'll just ask that you take a look at the letter that I submitted on this bill, which provides some greater detail about our concerns, particularly about the market manipulation effects of drug manufacturer financial assistance, and also how copay accumulator programs hold manufacturers accountable. So I will comment briefly about the amendments. I do look forward to seeing them, but based on how they were described by Mr. Celentano, they sound like they are definitely a step in the right direction, particularly if the accumulator ban is limited and not applicable when generic or biosimilar equivalents are available. In addition, the amendment that would require coupons must be offered in a fair and equitable way by ensuring that assistance must be provided to enrollees for the entire plan year. That sounds promising as well, as it would limit some of those market manipulation effects that we see due to manufacturer assistance. So I appreciate the sponsor's willingness as well to make these changes. And I'll stop there. Thank you.
And thank you for being with us and being patient. Are there any questions for this witness? Seeing none, thank you for being with us, okay? We appreciate you. This actually concludes the bill hearing on House Bill 879, Next, we have House Bill 1270, Delegate Gazoni. Will you be so kind and come up with your panel? Health benefits plans, prescription drugs, rebates, and calculation of cost sharing requirements. Today is Gazoni Johnson Day. Love the combination. And I believe you have Mr. Worthen, Stewart, and Ms. Callahan.
She's going to be virtual.
She's gonna be virtual. Will you be so kind and bring her up, please? Thank you. Good afternoon again, Delegate.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. Again, I'm Delegate Pam Gazoni. I represent Howard County's District 13, and I'm here in support of House Bill 1270, the Maryland Share the Savings Bill. Currently, many patients with commercial health insurance are saddled with substantial out-of-pocket expenses for their prescription medicines, often far exceeding what the insurance providers pay for the same medications. This stark disparity arises because health insurance plans and pharmacy benefit managers, or PBMs, frequently negotiate substantial rebates and discounts with pharmaceutical manufacturers. A lot of challenge there, sorry. Yet fail to pass these savings along to patients who need them most. It's important to note that in 2022, thanks to these negotiated rebates and discounts, net prices for brand name medicines were on average 50% lower than the list prices. However, patients often find themselves paying the full list price or a significant portion thereof, exacerbating financial strain and creating barriers to accessing essential medications. This burden is particularly pronounced for individuals living with chronic and debilitating conditions, who disproportionately bear the brunt of these inequitable policies. The crux of the Maryland I'm sorry, I'm a little tired. Let me start that sentence again.
Take your time, take your time.
The crux of the Maryland Share the Savings legislation is simple, yet profoundly impactful. It ensures that the rebates and discounts secured by manufacturers on prescription drugs directly benefit the patients who rely on these medications by reducing their out-of-pocket expenses. Specifically, under this legislation, patient cost sharing for each prescription is determined based on an amount equal to at least 85% of all the rebates received or expected to be received on the drug. By enacting HB 1270, Maryland can lead the charge in promoting fairness and affordability in healthcare. This legislative reform directly addresses the concerns of patients at the pharmacy counter, providing tangible relief to individuals grappling with the burden of exorbitant prescription drug costs. Moreover, by enhancing access to vital medications and fostering greater medication adherence, this bill has the potential to improve healthcare outcomes and enhance the overall well-being across our communities. By championing the Share the Savings initiative, we can uphold the principles of fairness, equity, and compassion in our healthcare system, ensuring that all Marylanders have access to medication they need without undue financial hardship. I respectfully request a favorable opinion on HB 1270.
Thank you.
You want to go first, Brad?
Sure.
Thanks.
Again, for the record, my name is Brad Stewart. I chair the Maryland Tech Council. Delegate Gazoni, thank you for inviting me to be here. More importantly, thank you for the bill that you've put here in front of the committee. As I mentioned earlier in the day, the Maryland Tech Council fully supports any legislation that this body pulls together that actually directly reduces the cost that the citizens of Maryland have to pay out of their pocket for prescription drugs. As I mentioned, the pharmaceutical industry provides hundreds of billions of dollars a year in discounts on medications, many of which never reach the patients. I think this is a well thought through and great opportunity to begin to require those discounts to flow directly to the patients and reduce the burden that provides to our citizens in the state of Maryland. So from that perspective, we're fully supportive and hope that this committee favorably reports out on this bill.
Thank you. We're going to make you an honorary member of our committee, Mr. Stewart.
Thank you. That would be an honor.
Thank you for saying that. Next, please.
Hi, thanks, Chair Benamelic, and I appreciate your being so welcoming to all the testimony today. I'm Dr. Angus Worthing. I'm a rheumatologist in Maryland and here representing as the president of the ATAP Action Network, a national organization that on the state and federal level is concerned and derived of patients and providers, a nonprofit which advocates in favor of patient access to medications, and transparency issues related to drug pricing. ATAP is concerned about the role PBMs play, like others have said before, in the alarming price increases and the out-of-pocket costs of prescription drugs, which result in loss of patient access to affordable and life-saving medications. We see that a lot in rheumatology. PBMs are supposed to keep drug costs low, but really the reality is drug prices are increasing. PBMs use their intermediary position to negotiate rebates in exchange for including manufacturers' drugs on the tiered formulary, and the formulary tiers then determine how much coverage and out-of-pocket costs the patient pays. And they claim to pass a portion of the rebates back to insurers to help drive down costs for patients. But due to the opaque nature of the contracts, most of these funds appear to go to the PBM's own bottom line. And so unfortunately, there's very little transparency surrounding PBMs and no legal requirements to pass negotiated savings on to payers or patients. And the delegates' bill 1270 would fix this by requiring at least 85% of rebates received be passed on to patients. This is a critical reform to contain drug out-of-pocket costs and the PBM abuses. We encourage the committee to actually consider enhancing the bill to require 100% of rebates be passed through to make prescriptions even more affordable to people in Maryland and to be in line with enacted legislation across the country, including Florida, Indiana, Arkansas, West Virginia. Excuse me,
You can take your-
half a sentence. Thank you. And that active legislation in several other states. Thank you again. Be happy to answer any questions.
And thank you for your testimony today. I'm gonna open it up for questions now. Are there questions?
Madam Chair?
Yes.
Could we have Erin
Oh,
do her testimony?
absolutely. Absolutely. I completely forgot. I apologize.
No worries.
Ms. Callahan, will you be so kind and give us your testimony?
Thank you, Madam Chair. I may be difficult to remember, but impossible to forget, so I'm told. I'm Erin Callahan with the Diabetes Patient Advocacy Coalition and the Patient Pocket Protector Coalition. We represent millions of Marylanders and Americans living with chronic conditions here today to express our support of House Bill 1270. We come to you on behalf of patients like me, asking for relief from rising prescription drug pricing by sharing PBM negotiated rebate savings with patients at the pharmacy counter. We heard earlier that the average rebate on branded drugs is about 48%. On insulin, they reach a staggering 80%. It should be noted that the top 3 PBMs, which cover over 80% of the US market, are in fact owned by the health plans they represent. And while rebates are an effective and certainly profitable tool for these entities, 1 in 4 people are still rationing insulin due to these costs artificially inflated by rebates. This is wrong. Our opposition claims that PBMs and health plans retain rebates to keep premiums down, to which I counter that by asking the sick to subsidize the healthy is a perversion of the insurance system. Never mind the life-threatening absurdity of said system. According to the current rate filings, both West Virginia and Arkansas, states that have passed and implemented such rebate reform, have shown no increase to their premiums as a result of their legislation. I want to close by sharing that all 3 of the largest PBMs can pass through rebates to patients today, and they're doing it in West Virginia and Arkansas, as well as to fully insured plans. In fact, all 3 are on public record agreeing that rebates should be passed through, even going so far as to confirm that reduced patient cost sharing as a result will result in better patient adherence and outcomes. On that, we can agree. I thank you for your time today and respectfully request a favorable vote on House Bill 1270, which has the ability to improve healthcare and save lives in Maryland. It also directly impacts patients. I'm happy to answer your questions and really appreciate your time and the accommodation for my virtual participation. Thank you.
Absolutely. Anytime. Now I'm going to really open it up for questions. So are there any questions? Delegate Morgan, followed by Delegate Woods.
Thank you, Madam Chair.
My pleasure.
Hey, good afternoon. Looking at some opposition testimony. From PCMA. The last paragraph of their opposition says manufacturers offer rebate discounts on a very limited number of brand patient protected prescription drugs. 90% of the drugs dispensed in the United States are generic. Manufacturers offer no rebates for them. 10% are brand patient protected, and only 3% face competition from the manufacturer selling the drugs. So they're saying that there's just not that many manufacturers offer these rebates. Do you have any examples of how many or how many rebates are actually offered?
My God. So I think their testimony is actually in favor of this bill. If there aren't many rebates offered, this should be stunningly simple for them to administer. Yeah.
If I could address, happy to just chime in
He
that,
can have a follow-up. Do you not want to follow
oh, sorry.
up?
There you go.
Yeah.
Thanks, Delegate Morgan. I'm sorry. From just treating people with rheumatoid arthritis, that we try a generic 30-year-old plus pill first. Half the people, it doesn't work for them, it fails them. And then we're on to biotech drugs, biologic drugs, and biosimilars. And those all have high costs and rebates deriving the formulary. So it's life-changing for half the people with these diseases.
And Delegate Morgan,
He needs he would need another follow-up. You want another follow-up, Delegate Morgan?
I'm good.
You're good?
it's the
Okay.
answer.
Thank you. Delegate Woods.
Thank you, Madam Chair. Can I ask what your follow-up was going to be?
yes. I was going to say, I agree completely with those statistics. About 90% of drugs that are dispensed are generic drugs, and there are definitely issues with the way that people are charged for generic drugs also. But I, in no sense, would say to step away from taking positive action that's going to take money that is already being discounted out of the hands of pharmacy benefit managers and putting them into the hands of patients.
Thank you. May I follow up, Madam Chair?
Absolutely.
And this is a question, I'm really asking it just for the sake of asking a question, because what I really want to say is to you, Delegate Gazzoni, thank you so much for this legislation. It's extremely important. And I guess my question may be kind of a crazy question, but I'm always baffled and curious as to what are the justifications that these PBMs use for preventing these rebates or this cost sharing that should benefit the customer to not in any way benefit them.
Mind if I-
Yeah.
Okay, sure.
We can.
Can I take one step back and explain why PBMs exist and why this bill sort of brilliantly solves a problem that I'm not surprised I would have suspected they would have brought up. So as I mentioned earlier, our healthcare system is stunningly complex and arcane in the way that things are paid for. It's mind numbing for someone who spent decades working in it for me. Pharmacy benefit managers were created because the amount that any person in this room pays for a drug is going to be different depending on who your insurer is, what the drug is, and everything else. So they were created as sort of a clearing system so the pharmacy could figure out how much to charge you and then how much to charge your insurance company and then how much was supposed to be rebated to them. So there's a service they provide. What they found over the years is that those are administrative fees, much like we talked about earlier, the administrative fees pharmacies get to collect. They're not that profitable for them. What they found is what's very profitable is by pocketing as much of that difference as humanly possible. When you talk about how the lack of transparency in the system, it's pitch black. There is no understanding of who's paying what to whom for what amount of money. So the challenge that usually you see from pharmacy benefit managers, they say, well, we can't do this because then we would have to disclose proprietary information to you because those contracts between the drug companies and the pharmaceutical companies are all proprietary. The brilliant part of this bill is it avoids that whole thing. They don't have to disclose what those prices are. They don't have to disclose any proprietary information. All they have to do is rebate at least 85% of that amount to the patient. So I think that's one of the challenges in the system, and the opportunity here is to do something that says, great, we accept that. You're going to make 15% profit, or you'd prefer 0% profit on that. But let's at least do the right thing and try and get that money directly to the patient.
You're welcome. Delegate Hill.
Thank you, Madam Chair, and
You're
thank you,
welcome.
Delegate Gazzoni, for this bill. Since you're not going to get a chance to come back up, the question I have is based on the letter from the American Health Insurance Plans. And they make this point: POS rebates only benefit a small number of consumers, right? They say that the savings from rebates are passed on to all enrollees through improvements to benefit packages, reductions in premiums, and or lower out-of-pocket costs. But this bill, HB 1270, eliminates the shared benefit all consumers receive when carriers and PBMs negotiate rebates on costly drugs. POS rebates won't help most patients who take generic drugs. Do you have any response to the idea that this doesn't help enough people to matter?
I could be fumbling this a little bit, but from everything I understand, by enacting something like this, we'll have minimal change in the rates that people will be paying for their insurance. And yes, it probably won't benefit a ton of people, but the people that it is benefiting are paying a lot for expensive medicines. And this will change what they get when they are visiting the pharmacy counter. Excellent example.
All right, thank you.
Thank you.
May I have a follow-up, Madam Chair?
Yes.
Thank you very much. And this is for whoever you want. They go on to say that based on California and that experience, similar rebates or similar mandates were adopted under Medicare Part D. The CMS actuaries estimated that it would increase premiums by 25%, cost taxpayers between 200 and 400 billion, and lead to 137 billion windfall for pharmaceutical manufacturers, suggesting that, and I don't know how close the California legislation is to this, but they're suggesting that even more profits to the pharmaceutical companies and even more cost to the taxpayers and the premium payers. So somehow this would cause everybody, I don't know where the extra money comes from, but can you address that at all?
I know that Ms. Callahan has her hand up.
Oh.
May we allow her since
Sorry.
she hasn't had an opportunity?
Thank
Ms.
you.
Callahan, go ahead.
Thank you, Madam Chair. Just a couple of notes on the earlier questions. I will address the most recent one first. With regard to that Medicare Part D study, as we all know, Medicare Part D only covers prescriptions. In a typical health plan, prescription costs are about 10 to 15% of the total plan, whereas the other 85 to 90 are major medical. It would be the equivalent of saying what percentage of the ocean has sharks in it, and going to a shark tank and saying, this is the ocean is 100% sharks. We know that's not true. And if you take something that only has prescriptions in it and ask if the prescription cost is going to rise, yes, it will. But when you extrapolate it across the entire cost of the system, again, we have an actuarial study that we can provide for you showing that if at all, premiums may increase by 0.4 to 0.6%. And in the cases of West Virginia and Arkansas, who have passed and have implemented rebate reform at 100% to patients at the point of sale, there has been no appreciable increases beyond cost of living and year over year to their premium rate filings.
Yes.
And if I may touch on the generic question as well, in recent years, less than 50% of drugs that are on generic tiers for you and I who go to the pharmacy are actually generic drugs. Generic drugs are being discouraged from coming to market. I have a great example in the case of insulin, where a generic insulin came to market and it was not picked up on formulary by any of the PBMs or health plans. As a result, they sold and became a branded name drug, and suddenly they were in play. The higher brand drug or the higher cost drug will win. And that is harmful to patients across all chronic conditions.
Thank you, Madam Chair.
You're welcome.
Thank you, Madam Chair.
Thank you. Any other questions? All right. Thank you so much for being with us today. We appreciate it. We're gonna go now on to, if I may, 1 second. I'm going to go to a panel of unfavorable, since that was a favorable, just to be balanced. And we have Matthew Celentano. They're not gonna take this picture.
In his usual role.
In his usual role, playing himself. We have Heather Gascoigne, Michael Johansson, Camille Fesh, and Tricia Swanson, and Allison Taylor, and Kimberly Robinson. Let's bring everyone up. Just pull up some chairs.
Matt Celentano, back to my normal posture, opposed to House Bill 1270 on behalf of the League of Life and Health Insurers of Maryland and AHIP. This bill would increase costs for the vast majority of enrollees by shifting rebate amounts to individual enrollees instead of allowing the plan to apply the rebates to reduce costs for the entire plan and the beneficiaries. Mandates will likely increase the cost of premiums for all enrollees in the plan. The bill also eliminates choice for purchasers. Health plans are sensitive to their enrollees' needs and design plans that reflect those needs. This bill takes away a lot of that choice. Premium cost is a major factor in these decisions, and state mandates that eliminate a plan design option that may better meet the needs of the population is a deterrent to that creativity. House Bill 1270 doesn't address the underlying epidemic of high-cost drugs at all. State point-of-sale rebate mandates may provide short-term relief for a few plan enrollees, but they don't address the growing problem of increasing drug prices and the longer-term impact on premiums. This is a classic sugar high policy approach that looks one way and ends up creating more issues later. And that's why the League and AHIP are urging an unfavorable report on House Bill 1270. Thank you.
Is
Good
this, if I
afternoon.
may, 1 second, this is the first time I hear this sugar high policy.
I got kids who want ice cream for breakfast.
I'm gonna start a little list here. Go ahead.
Thank you, Madam Chair, members of the committee. Heather Cascone for PCMA. Rebates are one of the few meaningful tools that plans have to offer lower costs for all members of their plan. While some patients would benefit from cost sharing reductions at the point of sale, most beneficiaries would see little benefit. Thank you, Delegate Morgan, for calling out my testimony earlier. It's true that it is just a very small percentage of drugs that face the type of competition in a therapeutic class, about 3%, where a rebate is offered. Having rebates at the point of sale could have the negative consequence of incenting patients back toward more expensive brand medications. Ultimately, point of sale rebates won't help the majority of patients who take generics or lower cost brands and instead result in an increase in everyone's premiums. For years, PBMs have offered employer plan sponsors the option to apply rebates at the point of sale, but plan sponsors do not choose this option, preferring rather to apply drug cost savings in a manner that best serves the enrollees on a broader base. And because the cost sharing at the pharmacy counter is more visible than premium or other plan design savings, patients often are unaware that rebates reduce their total costs even when not passed through at the point of sale. It is for these reasons that we must request an unfavorable report. Thank you for your time.
Next, please.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson here, respectfully, in opposition to the bill. We understand the goal that the plan sponsor is seeking to reach with this bill, but I won't repeat all the things that my colleagues have said. What I think has been challenging about these first two bills and some of the things that have been said is there's been a lot of misinformation about how and what PBMs do what we do. For instance, we do not pocket a single penny from a coupon. None of that money goes to a PBM, but you were told that on the first bill. On this bill as well, the money that's being recouped in the rebate is not used to the benefit of the PBM. It's used to the benefit of the plan sponsor, the employer, or in this case, the health plan in our state, which is who this will affect, who is purchasing our services for the benefit of their enrollees. And what they choose to do with that money, as Ms. Cascone just said, often is to use that to go back into all the plan costs, because for them, that's the most equitable way to share that money across all of the enrollees. If I reduce everyone's premium, as opposed to the 3% who are on the biologic drug that has the rebate, but everybody is now benefiting because those large dollars are being spread across. For the plan sponsor, it's meeting their goal. And so we're here today in opposition to the bill because it takes the choice away from the plan sponsor, not the PBM. The people whose patients are earning that rebate, who are able to deploy those funds as they see fit to best impact the cost of their plan, that's who loses the choice today. You also heard testimony that the PBMs who are associated with health plans, that's the reason why we don't like it, but you're also going to hear from your largest carrier who's not associated with a health plan, or a PBM rather, that this negatively affects them too, because they again are a plan sponsor. And on behalf of those who are trying to do their best to keep healthcare affordable for your patients, we oppose the bill. Thank you.
Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente. Kaiser Permanente does not use a PBM, but this bill applies to carriers too, which is why I'm here today. One point that has not been made yet is that a point of sale rebate bill like this is very difficult to administer. So that's one reason why we prefer the approach that the sponsor of the last bill made with the copay accumulator and the sponsor amendments, which we think gets at the same goal, but is more easy for Kaiser to administer.
Okay. Yes.
Thank you, Madam Chair. I'm Mike Johansson with the Rifkin firm on behalf of PCMA. We are opposed to the bill. You heard that it's a limited number of drugs that have rebates. It's also a limited number of people that pay a copay or a cost share that actually would be affected by a substantial rebate reduction. 24% of Marylanders are in Medicaid, maximum copay is $2. You can do whatever you want with the rebate, but it's not going to help that person at the counter. If you're on the state employees health plan, maximum copay is $50, $75, maybe $100. You know, a rebate is not going to impact your copay. It's shared with the rest of the people. If you look at, there's a budget analysis, DBM budget analysis personnel, page 23, shows there was $823 million worth of expenses in the for prescriptions in the state health plan, and a return of pharmacy rebates of $268 million. That $268 million, which is 100% pass-through contract with DBM and its PBM, that $268 million goes to offset the premiums that the state and its employees, roughly 75% for the state and 25% for the employees, are paying. That's where those dollars go. If those dollars go to the handful of people that actually, you know, had the expensive drugs, which they only have limited copays to begin with, it's going to the right place. It's offsetting the cost for the entire state employee pool, not just the people with high costs. So we suggest the bill is misplaced. It's kind of making an issue out of something that is not an issue for most people. Thank you.
Thank you. Are there any questions for this panel? And I'll call the others in a minute.
Just a me too. So I don't.
You're, so can you tell your name and tell us what you're well, actually, why don't you just come up? And
Trisha
Camille.
Swanson on behalf of Care First. I'm just a me too with this panel.
Okay.
Thank you.
Camille?
Mr. Johansson.
Okay.
And have it covered.
Okay, great. All right, so let's ask, are there any questions for this panel? Yes, Delegate Woods, followed by Vice Chair Collison, followed by Morgan.
Thank you, Madam Chair. My question is for Ms. Robinson. I would like to ask you to clarify something for me. You talked about monies going to the sponsor. So if the insurance company owns the pharmacy that employs the PBM, can you make the connection for me or clarify for me how that is not?
Okay, so I'm going to take a step back on your question because the facts you laid out aren't what actually happens in terms of who's related to who.
So can you tell me then?
Absolutely.
Thank you so much.
Okay, so the model that's got a lot of conversation happening, you're going to probably continue to hear it today on these bills, is that in a large corporate family, you've got a parent company who owns several companies that do various things. And so there is a model in the world where you have a parent company who owns an insurance company, and that parent company also owns a PBM. They are separate companies. They work as separate companies. They may contract with each other for services, so that insurance company might have a contract with that PBM because they're going to use their sister company to do their pharmacy benefit management business. But there's this belief in the world that because there's a corporate relationship, that there's all kinds of things that are going on that I'm just going to tell you are not, right? So there's a lot of assumptions that people make from the outside looking in who just don't have any familiarity with what those relationships actually operate that way. And that insurance company is out selling their benefits to employers across the country. here in the state of Maryland, whether we're talking about large employers like a Marriott or a small employer or an individual, is going to buy their health insurance potentially from that health insurance company. And then that PBM is selling its PBM services to all kinds of businesses as well. They may work with the insurance company that they are affiliated with, but lots of other people are using their services as well. And so that PBM is often hired by those same large employers to manage their pharmacy benefits because they contract for them separately. Think a General Motors, think an Exxon, think a Xerox, right? They contract with a PBM to do their pharmacy, and then they contract with an insurer to administer their health benefits separately. A lot of the testimony has been people outside of the industry telling you what the industry does. And I just invite the committee who would like to learn more about what the industry does to talk to the companies who are represented here. And we can really help educate the committee about what it really looks like and how all of this works together.
Just a follow-up, Madam Chair. Thank you so much. So am I hearing you say that it is not true that the connection between the pharmacy benefit managers, the insurance company, and the pharmacy does not have a positive relationship in terms of benefits?
So some of those same parent companies who may own an insurer, may own a PBM as well. They also may own some kind of a pharmacy. Everybody doesn't, some may. Yes.
Are they not making a benefit, a profit from each other? Are you saying to me that there is not a profit being made between these connected companies?
A profit being made between each of those companies is seeking to be profitable as a company. I think the challenge is the assumption that what one is doing with another isn't being done the same way they do it with any other customer that they're servicing, right? So if my PBM is doing the PBM work for my insurance plan, it's doing it in the same way it's doing it for Blue Cross of Tennessee, who is an insurer that we don't own, but we also do services for. So it's not unique that I'm doing it in a particular way because I'm affiliated. I'm doing it in the same way I do it with any insurance company I have a contract with. And I have contracts with insurance companies that are not affiliated with me. I think the suggestion underlying that says that I'm doing something different with the one I'm affiliated with, and that part is not true. It's the same with any insurer client that I have.
So can you answer the question?
I felt like I did, so maybe I'm not understanding the question.
My question is there a financial benefit being made when these connected entities, the pharmacy benefit manager, the insurance company, and the pharmacy are working together?
I mean, arguably, I think there's not in the context of rebates. I mean, in general, yes, I'm sure there are certain synergies that make sense. That's part of being part of a corporate family. So like any corporate family, you're going to benefit from that. And yes, the goal for all of those individual companies is to be profitable. I guess I'm struggling with the implication that it's saying there's something untoward. Of course, everybody is working because they're for-profit businesses to make profit. I think it's the implication that there's something untoward in the relationship, and I'm going to say there's nothing untoward in the relationship.
All right. Thank you so much.
My pleasure. Vice Chair Carlson, followed by Delegate Morgan.
Thank you, Madam Chair.
You're welcome.
I'm not sure whom to ask, because you all know the answer, I think. But why don't the manufacturers just stop the rebates and make the drug prices and lower the drug prices overall?
Yeah, sure. Well, thank you for the question, Delegate Cullison. I think it's a great question. I think what's been fascinating about so much of the stuff in the drug space is that also one of the things you keep hearing is PBM set the price, PBM set the price, manufacturer set the price. And if the manufacturer has the wherewithal to rebate the drug, they have the wherewithal to discount the price. I think there's, when to Delegate Wood's question, we want to ask where profit motives may lie. I think there's a question about what is the benefit of having the coupon or having the rebate and not just making the drug less expensive to everybody who needs it. Why are we picking and choosing? Why are we only making them available to some people instead of just simply bringing down the list price of a drug? If the list price was where it should be, there'd be no rebate to negotiate.
Absolutely.
So do you think there's a relationship between what you just said, and competition to get on everybody's formulary?
Yes, I do.
So in other words, the manufacturers are providing rebates, not to everybody, but to particular plan entities, so payers, in order to get on their formulary.
Favorable placement on the formulary makes your drug possibly reach more people because it's going to incent people to pick it because you've allowed it to be on a lower tier because you've lowered your costs. Absolutely.
Okay, thank you.
Are there any other questions? Oh, yes, sorry, I said it twice, Delegate. Go ahead, Delegate Morgan.
Thank you, Madam Chair.
Thank you.
Heather, Mike, since I called your letter out in the last panel, I wanted to give you a chance to maybe elaborate on that a little bit. If you're saying that there's just not that much profit in the rebates and they're hardly worth it, then what would a plan that didn't have a pass-through option, what would be the percentage increase about if the rebates were passed on to the consumer and not taken to reduce the overall cost of the plan?
I don't, if I can clarify that, I don't think we're trying to intimate that the value of the rebates is minimal because the percentage of drugs that are eligible for rebates is minimal. The value could potentially be large based on what the drugs product manufacturer decides and how much they want to incent formulary placement. It's not a small task to estimate what the rebate value could be because of the way drug manufacturers offer rebates. They offer them based on a per fill volume basis that's then trued up on a quarterly or semi-annual basis with the plan and the PBM. And so when you fill a prescription for a drug that has a rebate that's offered on it, the PBM and plan do not know what the value of the rebate for that prescription fill is at that moment. Because if the plan's participants fill just one prescription versus 1,000 prescriptions, the value of that rebate would change. And so operationally, it is difficult to predict what patient utilization will be on a quarterly or semi-annual basis. But I certainly did not mean to imply that it was a small amount.
Sure.
And I appreciate that information. I'm trying to think. So when you're negotiating with a manufacturer over the cost of a prescription drug, does a PBM ever recommend a rebate for a set drug? Is that part of the negotiation between the manufacturer?
Yeah, thanks for the question. The offer of a rebate lies solely in the discretion of the manufacturer, whether they have an incentive to move patient utilization to their product. That only happens when there's competition for their drug. And we're not talking about necessarily generic competition. We're talking about other brand patent protected drugs that exist in the therapeutic class, of which there's really a small amount of, like I said in my testimony, about 3% of the drugs, the 20,000 that exist in America today. It's solely their discretion as to whether they want to offer a rebate.
Sure. Okay, are there any other questions? Oh, yes, Delegate Chisholm, I just saw the light. Go ahead.
Yeah, because she said something that sparked my interest.
It's
So,
okay.
Thank you, Madam Chair. So PBMs obviously are very complicated, but there's very, very intelligent people that work for PBMs. And when Mr. Johansson's okay.
Oh, really?
So when you're talking about something of this magnitude, you have data sets. And when I hear, well, we really don't know how many prescriptions are going to be dispensed or I mean, that's hard for me to fathom, in that if you look at, I mean, you can look at data sets for the last 5 years and there's got to be a lot of repetitive formulas that can be equated
Sure.
to give you an answer on, all right, this is what we expect. I mean, there's a variation. This is why we have models. So there's got to be a little bit of a variation, but why is there so much uncertainty to the PBMs about what is going to be ordered? I mean, I know that we have different things that happen in society that might cause one thing to spike or another, but for the most part,
Right.
it is about being able to recognize patterns.
Sure. I think I understand your question and thank you for it. When a PBM is negotiating with a drug manufacturer, they are doing so on behalf of Plan 1. And then they are negotiating on behalf of Plan 2. And so the plan participants at any given time in Plan 1 could change. What prescription drugs they are prescribed by their prescriber could change. And you're right, there are sophisticated modeling that our plans use in order to support the plans who do decide to pass through rebates at the point of sale. We do our best estimate on prior utilization in the prior year, or the prior quarter, to predict if there are refills that are available on that prescription for that particular patient, that they're likely to fill it again. And we can make our best estimates to meet as close to accurate a prediction of what, in this instance, 85% of a rebate might look like for a patient. But there are a number of variables that change patients' utilization of drugs all the time. Everything from brand manufacturer commercials to manufacturing issues, delays. The patient basis of a plan could change, go up or down. What drugs they're taking could go up or down. They could experience, medication interactions and just decide to change their medication altogether. So there are some variables that we have to consider, but you're right, we do our best to model it when our plan sponsors ask us to do that. It is an option to plan sponsors today.
Any other questions? I don't see any. Excuse me? I have.
Hanson can't get away from
No, it's funny, I have been here in this committee now. I'm gonna date myself, but 18 years, right? And I've seen a lot. And what's really common, and I would call it the usual suspect in the bills that we have every session, are PBM bills, right? And I've been thinking a lot about, why is that, right? And 79%, almost 80% of the market are controlled by 3 companies, which is, Express Script, which is Cigna, CVS, Caremark, and Optum RX have almost 80% of the market. What happens when you have that much control and monopoly is that you have the price control, right? And not a lot of competition, which creates a lot of the problems that we see in this committee. And we can disagree on the issues, but the issues center on the retention of the rebates paid by drug manufacturers and on the what is called the spread pricing, right? That we usually see here. I don't know what the solution will be, and I know we have found ourselves having this discussion year after year after year, but I know that we must do more and we must do better because there is a problem. I don't know whether these bills are the solutions, right? This is just a hearing and the subcommittees will look at it and peel the onion and try to get to the truth somewhere. But there is a problem. And I hope and pray, I don't know that we would get it done this session or next session, but I do honestly hope that we get to the bottom of it and that we try to find some solutions. Because this is every year we're here finding solutions for this problem. I'm gonna leave it there. It's not a question, but I do welcome solutions and conversation. It's important, all right? Thank you so much for being with us today. Really appreciate it. We have next, Mr. Bajad. Could you go to the virtual witnesses and call them all, please? Thank you. Are they there? Mr. Bajad? Will you go to the? Will you please, yeah, disconnect from the YouTube channel because you're gonna get that feedback. Let's see, Ms. Jones, will you be so kind and get started? Then we will go with Mr. Tarp and whoever else I see on the screen. And thank you for being patient and everyone else waiting for the rest of your bills. Hang in there tightly, okay? We'll be with you. Go ahead, Ms. Jones.
Okay, can you hear me?
Yes.
Okay, great, thanks. Okay, thanks for having me. Good afternoon. My name is Sarah Jones and I work in community outreach for eosinophilic and rare disease cooperative. We have the honor of supporting people impacted by rare disease in 35 states, including Maryland. People impacted by chronic and rare disease are faced with unexpected and unwanted life quakes that upend their life in every way. One of the most significant ways that chronic illness creates long-lasting harm is the economic burden, and it does not have to be this way. I applaud you for considering passing this legislation that can ease this burden. PBMs pocketed $540 billion in profits in 2023 instead of passing along savings to patients. Adding to the suffering caused by the lack of transparency and PBMs not passing along the rebates, they prohibited essential access to new and life-altering medications. In fact, 600 were excluded from formularies of the largest PBMs you mentioned, Optum, CVS, Caremark, and Express Scripts. I live with EGPA, a very rare form of vasculitis. I've spent my career working in healthcare nonprofits advocating for improved access to care and medication. My healthcare costs are between $60,000 and $100,000 per year. I now take 27 medications. I took 3 before I was diagnosed. I know this system. I've taught other people to navigate it, and it is maddening to experience the shenanigans that the PBMs are playing. I spend hours and hours each week trying to secure my medications, exploring ways to help with costs and running in circles as I try to nail down my PBM. One of my meds alone costs $10,000 a month. This medication has kept me out of the hospital with lung issues and pneumonia, and I am eternally grateful for it. No one should have to spend precious hours of life chasing down benefits that should be automatic. While pharma plays an important role in setting medication costs, we've historically ignored the role that insurance companies and now PBMs play. The secrecy and patience cause suffering.
You can
okay.
finish.
Thank you. I just want to encourage you to pass HB 1270 to ease the burden on patients and family and require that 85% of the rebate and discount is passed along to the patients. Thank you so much for giving me the opportunity to talk with you today.
Thank you for being with us, and I'm glad you're doing well. Go ahead. Who's next? Mr. Tarp.
Yes. Good afternoon, Madam Chairwoman and committee members. I want to confirm that this is a discussion of Bill 1270 as opposed to Bill 876.
Yes.
Thank you, ma'am. My name is Louis Tharp. I'm a Towson native, now living in New York, and executive director of the Global Healthy Living Foundation. I'm commenting on behalf of chronically ill patients in Maryland whom we represent. I want to begin by telling you, as I have before, that the healthcare system works, just not always for patients. Thank you for allowing me to comment today in support of House Bill 1270. The legislation would ensure that patients are able to realize the full benefits of the deals and rebates that insurers and pharmacy benefit managers negotiate with drug manufacturers. Through often proprietary and non-disclosed arrangements, PBMs offset their acquisition costs for drugs using manufacturer rebates. This lowers the net cost of the drug. However, this net cost is not used to offset patient copay and coinsurance costs because the patient's coinsurance isn't a percentage of the net price paid by the PBM, but rather a percentage of the list price. There is a huge difference. This results in patients paying much more for the prescription than their insurance plans do, providing pure profit to the PBM. Worse, the patient has no idea they're overpaying. So this invisible profit-generating program forces our patients to walk away from the prescription counter when they're unable to pay for their medications, or they ration, or they skip doses in order to make one prescription last longer. Thank you very much for allowing me to speak today, and I am in support of House Bill 1270.
Thank you for being here. Good afternoon, sir. Can you unmute yourself, please? Thank you.
Hi, can you hear me?
Yes, we can. Thank you for being with us. Can you give us your testimony?
Yes. My name is Joshin Bajaj, and I'm in support of Bill 1270. I live in Baltimore, the city of Baltimore, and I have both type 1 and type 2 diabetes, which makes life a lot of fun. I cannot stress enough just how much time and effort goes into leading a day-to-day life with dignity, and having costs rise year after year on these medications that I didn't choose to want to take. I take them because I need to live. It's a bit maddening. And so I strongly urge that this bill get passed so that costs can come down for patients like myself. Last year, the worst month I had was $600 in 1 month. Over the course of the year, it was a few $1,000s. And to find out that, you know, the majority of these rebates are not being passed along to the patients that are actually using the medication is quite disappointing, to say the least. And by, you know, allowing these rebates by the drug companies to be used by the patients, we could actually have millions of diabetics across the country, and now in Maryland, you know, thousands of diabetics start to afford their medication. It's a very scary thing to have to ration your insulin. I hope that none of you or your families ever have to do it. I've had to do it in the past, and I hope I never have to do it again. And so if we can just pass along 85% of the rebate to the consumer, we can lower those prices drastically. I believe other states have already passed it without any increase in premium prices for the health plans overall. And so I really urge the members of the committee to pass Bill 1270. Thank you so much.
Thank you. And thank you for sharing your personal stories with us. We really appreciate it. And I hope you stayed healthy, okay? We're going to open it up for questions now. You're welcome. Are there any questions from the committee? Seeing none. Oh, yes. Vice Chair Collison, go ahead. Your hand was covering the light in my defense.
Thank you, Madam Chair, and thank you all for being here. I really appreciate it, and thank you for sharing your stories. So, and we heard Mr. Tharp say that patients don't know whether or not their drug is rebated. And we know for a fact that it may be rebated in one plan, but it's not rebated in another because of the competition that goes on between manufacturers and those who represent payers. So do you know, and if I may, Madam Chair, ask both of them, do you know that the drugs you are taking, that you would benefit from this particular bill?
Who are you asking?
I could speak to that for a moment. I am on a biologic, and I do not know because I don't know what the rebate is. And I know there is a rebate. It is a very, very popular drug. But I think that's an excellent question. And we should be able to know that.
Thank you very much.
All right. Any other questions? All right. Seeing none, thank you so much for being with us. I hope you have a blessed evening, okay? We have a couple more people left virtually. Will you be so kind and add them? Thank you. And thank you everyone for being patient. We're making progress. Are they there? Yes. Good afternoon. Is there a Keith Lake? Yes, Mr. Lake. Nice to see you again.
Yes, hello
Final
again.
seat.
Yeah, exactly. And you might see me again too. So
Yeah, it's okay. You're welcome.
thank you. I'm here to testify on behalf of AHIP in opposition to this bill, House Bill 1270. I also submitted a letter on this bill, which gives more detail about our concerns. In fact, Delegate Hill read earlier from this letter. So I'll be real quick. I'll echo Ms. Swanson from Care First and say I'm a me too with respect to the previous unfavorable panel, but I will just reiterate the point that point of sale rebate proposals have repeatedly been found to have a high price tag and fiscal notes. And so AHIP is concerned about the impact that these requirements will have on insurance costs in Maryland. You know, it's true that a few patients may see their costs go down at the pharmacy counter, but premiums and out-of-pocket costs could go up for everyone. In addition, a proposal like this reduces drug manufacturers' incentive to actually lower the price of their drugs, as is the case with so many of the bills on this committee's agenda today that deal directly or indirectly with the cost of prescription drugs. The problem is the price, which manufacturers alone set and control, as Ms. Robinson pointed out already. So given those concerns, we urge an unfavorable report. Thank you.
Thank you for being with us. Are there any questions for Mr. Lake? Seeing none, thank you, Mr. Lake. Oh, there is Delegate Hill.
Yeah, thank you, Madam
Go
Chair. And thank you for the detail of your letter. I do want to ask or echo the question that the Vice Chair asked a while ago. Do you have any answer to why the manufacturers and the PBMs don't just get rid of the rebates and just tell the manufacturers as a PBM, we just need lower prices in order for us to offer these medications?
I do not. I'm not privy to how those negotiations go. That's a question certainly you would probably want to ask of the manufacturers.
All right, thank you.
Any other questions? Seeing none, thank you so much, sir, for being with us. You have a blessed evening.
Thank you.
I have one witness left. It's favorable with amendment. Last name Cross. Not here? Okay, let the record reflect that person is not here. So this will conclude the bill hearing on House Bill 1270. Next, we have House Bill 726, Delegate Kipke, Pharmacy Benefits Managers Definitions of Purchaser and Alteration of Application of Law. And I understand that your panel, Delegate Kipke, is it Mr. James Doyle and Stephen, you coming? Caitlin McDonough? Jill McCormack? Kaylee Locklear? Tom Wyland, why didn't you come up and just pull up a chair, please? Thank you. On the other side as well. I didn't want you to be by yourself, Delegate Kipke. Go ahead.
Mr. Chair, Katie Locklear had to leave for another scheduled meeting.
Okay, thank you. Good afternoon, Delegate.
Thank you, Chairman, Vice Chairman, members of the committee. It's Groundhog Day in HGO. House Bill 726 is a bill that seeks to expand provisions of existing state law that regulates PBMs. It seeks to expand state law to all the categories of products offered in the state that we can regulate. This exact bill passed the Government Operations Committee last year, 22-0, passed the House of Delegates, 137-0. But unfortunately, I say with a smile, it was among a group of bills that ran out of time in the Senate Finance Committee. I remember.
Okay, all
it
right.
took you all a little while.
All right, let's stay focused.
Took you all a little while to catch on, but I'm glad you got my comedy. I'll recall, one of the laws that are on the books that is related to pharmacy and therapeutic committee requirements was passed in 2008. It was House Bill 343, and it was sponsored by me and then Delegate Pena Melnick.
I like that combination.
And when that bill passed and other bills passed, you know, when I was a new delegate, I was, you know, learning a lot through a fire hose, as I'm sure some of you can appreciate. It's very complicated. But you know, you're excited to know you're passing this law that's going to make things better for people. And then you find out that our laws can only impact a very small percentage of the market. To round it off, 20%. However, in 2020, there was a Supreme Court case that was taken up out of Arkansas called Rutledge versus PCMA that basically said as long as the laws that are passed in the states do not interfere with plan design, the state laws can apply to the entire market in the state. And, you know, to make it plain language, you know, the small group, the business insurance, or the self-insured groups. And we did pass in 2021 a law that reacted to that Supreme Court case that extended all of the provisions about how pharmacists get paid. You know, if you weren't here, then there were a ton of different schemes of which PBMs would reimburse pharmacies, and they changed almost monthly, it seemed, but at least for our purposes, each session we had a new law that would put some rules, some guardrails around whether it was GER or DIR or club, you know, all these different ways that they were grabbing money out of pharmacies. And we were successful in passing a law that extended those protections as it related to reimbursement. I think out of the sensitivities towards the pharmacies in our community that were at that time even in tears at this table, begging us for help. But the lobby against the bill, which, you know, fought tooth and nail to prevent that from passing, as it is the custom, we gave some deference to their concerns and just addressed the reimbursement aspects of the law. We did not extend the additional protections that we could have at that time. We asked the Maryland Insurance Administration to take a look at that and to let us know if there's anything in the state law that they believe would run afoul of the Supreme Court decision. They provided a document to the world and us, letting us know that we can extend, if we want, all of the protections in the state law. And so what this bill seeks to do is exactly that. And I have a feeling that the opposition is going to bring up legal concerns as they did back at the time. In fact, we all received a document, the title, it says Groom Law Group. And I'm just going to run through, and I apologize for not being brief, but I feel like it's important to know this. Quickly, I'm going to just run through a few of their concerns. One of their concerns is they cite is in the insurance code 151611. And if you go to the book, the law book, and you check it out, their concern there is a bill that we passed. In fact, Delegate Bromwell was the sponsor. I was jealous that he did it and I didn't get to do it. But it was a common practice that if a good pharmacist knew that somebody presenting at the counter could pay less by retail, it was in their contract that they couldn't tell that consumer. I mean, how immoral is that, right? We called it a gag law. They were gagged from giving consumer the information that would benefit them. Don't run it through your insurance, just pay cash. It'd be a lot cheaper for you. So that's a law that we wisely passed. If you look at it, it was debated, you know, it was a full public hearing. There was lots of debate. There's a lot of, and if you read through it, nothing about this impacts plan design. And nothing about this is this is a red herring. The concerns about ERISA, come on, it's ridiculous. It really is. And I mean that respectfully, but you know, lawyers can argue every side of everything, and I get that they have a job to do. The second thing that they mentioned is related to audits. I can remember a time where we had to put an 800 number, or required to have an 800 number for pharmacists to be able to call to discuss the specifics about their audits. They would come in and ask for thousands and thousands of things to be audited, unannounced. Now, these pharmacists can't go back, there's no need for the surprise visit that there is in certain instances, like when you inspect a nursing home, for example. The transaction's already been done. So we created some rules that were heavily debated, and it has nothing to do with plan design. They have very successfully, the opposition, brought in, because I believe this is very complicated stuff, different payers, different local governments, certain unions, and they have been sold that this will raise costs. And I really have to tell you, if you actually read what we're talking about and you think to yourself, how does that raise costs? It just makes they got an 800 number to call now. That law that we passed in 2008 about the therapeutic interchanges, if you read through it, we had to make the PBMs file with the MIA. What is your policy for a therapeutic interchange? If you want to switch out a therapy for something else, what is the policy? Put it in writing so that we know what you're doing, because they were just switching things out willy-nilly. And pharmacists were complaining to us that it wasn't the right thing for the patient in the interests of medical care. So I could go on and on and on about the specifics of it, but I ask you not to take their word for it. Look at the claims that they make in their legal analysis. Go back to the law book and read through it and ask yourself, does this interfere with plan design? Are they allowed to have all the specialty drugs that they want? Unfortunately, yes. Are they allowed to have only certain products covered on their plan? Yes, they're allowed to make those decisions that drive cost. That's what plan design is, and they continue to be allowed to do it, even if this bill passes. What this bill does is, in my opinion, extend a civil balance for these pharmacists in how they operate in their pharmacies. And lastly, I'll mention three additional quick things. By extending this, extending all of the laws in the insurance code to all the products that we're allowed to regulate, it creates uniformity. Pharmacists have told us that they'll file a complaint with the MIA just to be told it's one of the 80% that the MIA that we can't do anything about. So the pharmacists who are already overworked, as we all know, they say, why even bother? Why even bother doing it? Because it doesn't, 2 out of 10 might maybe get worked out into their favor. The second thing is you have a letter from the Office of the Attorney General. Our Attorney General this year and last year, this year is a little stronger language actually, says this is the right thing to do. They've studied the legal merits of the issue, and they've studied the, I would say, moral merits of the issue. And the Attorney General says in writing, they are in support of this bill. The fiscal note says there's a minimal expense to the Maryland Department of Health and no expense to the state health insurance plan, because we're already doing all this. State employees plan is already covered by every provision of this law. The only people I feel bad about is I feel bad for the Maryland Insurance Administration, because they're probably going to have more work to do, but they say they can handle it with existing resources. So with that, Madam Chairman, Vice Chairman, and committee, I rest my case and ask for your favorable consideration. Thank you.
I appreciate your testimony, because as you were talking, I wrote here, request AG letter. I was reading the legal document. If you wonder what I'm doing here when I sit here, and then you just went bang, bang, bang. I don't have homework. Thank you. Next, please. I move the bill, she says. Next, please.
And Madam Chair, if I could just say this, this is Ritchie Pharmacy, and no longer in my district, is Gary Simmons' district. This guy, Tom, is a saint. He works in an environment that's very difficult, high poverty, and he has reached out over the years about how he can help people with substance abuse issues. He helped us figure out ways to get pharmacy techs and training into service. And this guy, he's not making much money these days, I don't think, doing what he's doing. And I mean that respectfully, of course. but he is open all the time in a community where there's no other resources. And so with that, Madam Chair.
Thank you, sir, and welcome, and thank you for the work you do. We really appreciate it. You can get started.
Go ahead.
No, don't need to touch it. It's okay.
Good afternoon. My name is Tom Whelan and I own Ritchie Pharmacy up in Brooklyn Park, Maryland. And I'm here to support House Bill 726. I was also here yesterday for its sister bill in the Senate, Bill 626. Yesterday when I was here, I was kind of disappointed because unlike in the years past, when I would turn around, I'd see a whole room full of white coats. And I think somebody else mentioned that today. They're not here today. Why? Well, they can't afford it. They can't afford to pay a pharmacist to come in and fill in for them while they come in here and work. Thankfully, I'm an old fart and I get Social Security, me and my wife, so I can have a little bit of extra money to take a couple times off. One of the reasons they don't have any money is because of low reimbursements. PBM's taking our money. And I don't know how much longer it can go on. Luckily, I'm in my 70s, so I probably won't be coming visit you guys much longer. One of the things that happened yesterday is after the bill was presented favorably, the PBMs got up and said, well, you know what, if you pass all these bills, oh my gosh, it's going to cause all the employers all kinds of problems and difficulties. Well, I've been doing this for over 40 years. And I remember 10 years ago when nobody even knew what a PBM was. And I don't remember employers having any cost problems or any issues. But now that they have so much power and they control just about everybody's business, things are getting worse. And one of the things they talked about was employers. I'm going to tell you, and I've kind of come off a little bit of what we're here for is I didn't go into pharmacy to help employers. I'm an employer. I have 4 employees. I went into pharmacy to help people. And today, I don't know any doctors or nurses or dentists that went to school and spent hundreds of thousands of dollars now to graduate, and you end up in huge debt. And they didn't do it for the employers. They're doing it because we're here to help people, and we need to get paid for that. So I'm worried that this year, after 40 years of Ritchie Pharmacy, I may be closing myself. I hope that you can support some of these bills, including the 726 as well as the 880 bill that was talked about earlier. Thank you for listening.
And thank you for your service to the community. You know, we try every year to try to work on this issue, so we will continue to do that, okay? Thank you so much. Next, please.
Jim Doyle here on behalf representing the independent pharmacies of Maryland. I want to take a little bit different tack because Delegate Kipke did an excellent job in explaining the history of the bill and what the bill does in terms of the provisions of the bill that are all excellent. Instead, I wanted to focus on something that I heard yesterday and kind of presumptively rebut what the PBMs are, I think, going to get up here again this afternoon and say as to why this bill cannot be passed. And that is, they do it every year. They say, well, it can't be passed because of ERISA preemption. And yesterday they cited a case from the 10th Circuit, McLeary, I think it's called, Mallory, from the 10th Circuit that says, well, this kind of legislation violates ERISA preemption. They didn't recognize or refer to the fact that there's another case out of the 8th Circuit, the Webby case, that held the opposite conclusion, that these kinds of provisions are totally permissible and do not involve ERISA preemption at all. So you have one case from the 10th Circuit finding one way, you have another case from the 8th Circuit finding a different way. But the point is this is the 4th Circuit. No matter what the 10th Circuit says, no matter what the 8th Circuit says, doesn't matter. What does matter is this. Rutledge says, as Delegate Kipke pointed out, that everything in this bill is fine and legal. The Maryland Insurance Administration did a study a year or two ago and concluded that everything in this bill is legal under ERISA. And finally, the Office of the Attorney General has apparently concluded the same thing in its support of this bill. So we would urge a favorable report.
Thank you, Madam Chair and members of the committee. Caitlin McDonough, on behalf of Epic Pharmacy Network in support of House Bill 726. Listening to some of the previous bills, I had some comments that I was developing, although the chair kind of stole some of my thunder with her closing on the last bill. But one of the comments we heard from some of the insurers is that they have very few tools to lower costs. And I would argue they have many, many tools to lower costs, and that they're the subject of legislation every year. And what I found working in this committee is that this committee works really hard to strike a balance so that there are cost concerns. There are tools that the insurers, and including the existence of PBM, that they have to control cost and lower cost. But this committee works really hard to balance that with, providers being able to provide services in a functioning way and patients being able to have their protections. So all the protections that are alluded to in this bill are protections that have passed this committee in a very collaborative and, difficult way. I mean, I think we know nothing comes out of this committee without compromise and working. So, those protections passed, and they passed in a format that, was ultimately found to be palatable and ultimately found to be in the benefit of providers and patients as they provide those services and receive them. So, the extension of those protections to to kind of control or regulate PBM activities that are acting on behalf of ERISA plans, I think is appropriate. They've all been vetted by this committee, and I'll defer to the Attorney General and the MIA on their suitability. And then finally, in regard to the plan sponsors, I certainly appreciate everything employers do to provide affordable healthcare to their patients. I am fully confident that even with the restrictions of this bill applying to ERISA-based plans, that they'd be able to work with their payers and their plans to present an affordable, host of options to choose from, similar to how the state has done under their plan and how the small market or the state regulated plans do currently in the state. So with that, I'll urge a favorable report, and I'll switch seats. Thank you.
Okay.
Saving the best looking for last. My name's Steve Weiner with Mount Vernon Pharmacy. Again, I'm not going to talk about the legal aspects. There's smarter people than me at this table that can do that. The other side will tell you putting a postage stamp on an envelope is plan design, and I will tell you nothing is plan design. And if there were only an impartial person in the state of Maryland, like the Attorney General, that had an opinion, we could sort of settle that issue. Let's look at the specific parts of this bill, because we're talking about fluff and distractions. Let's talk about the bill clauses. 15-1611.1 prevents a PBM from self-dealing and restricting patients to a network where they own the pharmacy. So let's not be mysterious. Caremark should not be able to restrict a network to CVS. Caremark can restrict a network to Walgreens. And of course, that sounds preposterous to us. It shouldn't, but it does, because we know they'd never do it. So is that right? Does a monopoly with the payer and the pharmacy network save money? Have monopolies ever saved money? That's what they're fighting for. 15-16-12 prevents a PBM from paying their own pharmacies less than they pay everyone else. Is that unreasonable? Does it pass the sniff test when I tell you they shouldn't be able to do that? And this is the best. 15, 16, 23, and 24 is not even shown in this legislation, but from your last hearing, it makes the PBM show the payer all the rebates. It makes them show them before they sign the contract. It makes them show the rebates throughout the year in the contract. And because it wasn't listed, I printed it on my last 2 pages of testimony. And then lastly, common sense audit stuff that's already been passed. So to finish, specifically, I don't know what raises prices that are not a reasonable ask that have already been compromised. I thank Delegate Kipke and the committee for their time.
Thank you very much. I'm going to open it up for questions now. Are there any questions? Delegate Morgan.
Thank you, Madam Chair.
My
Delegate
pleasure.
Delegate Kipke, this is the same bill that we passed last year in the exact same format?
Yes.
Okay, no further questions. Thank you, ma'am.
Move the bill. I know everyone is in favor, right? So did you change a word?
No.
Okay, thank you. Any questions? And can you do me a favor? That AG letter, will you give it to our council, please? She has it. Can you give it to me?
Yes.
I would like to have it. Thank you. Excuse me? That'll be great. Thank you. It's not in my file.
Is it the one from the Consumer Protection Division or the?
Which one is, 1 second, Delegate, Kipke, did you request a letter?
No, it's their testimony. I
Is
did
it-
request a letter last year,
Okay,
which it's the same bill that I'll give you that.
can you give it to me, please?
Yes.
Thank you. And then yours should be, I didn't see it in the file, but maybe I skipped it.
Probably the same letter. I mean, HGA you as part of. Yeah.
Yeah, we got it. Thank you. I'll look for it. All right, are there any questions? Seeing none, thank you very much.
Thanks, everybody.
Okay. Why don't I call the Heather Forsyth? Why don't you come forward? And may I call Gio McCormick? Are you here? Kaylee Locklear is not here. He's somewhere else. And how about Tom? You just testified. Anyone else in favorable that I didn't call? Go ahead, Heather. And thank you for being patient. We appreciate your testimony here.
Thank you very much. Actually, it's worth the 4-hour wait, even just for these 2 minutes to testify in support of this bill for the Office of the Attorney General. For the record, I'm Heather Forsyth, Deputy Director of the Health Education Advocacy Unit. As you've heard, there is no doubt that this bill brings value to patients with important consumer protections and also to independent pharmacies who are not treated equally by PBMs. So I won't repeat these arguments, and they're also in our written testimony as discussed. But instead, I want to bring up a few points that you might want to consider as you hear from the opponents of this bill. They'll say, despite federal jurisprudence to the contrary, that this bill is impermissibly straying into ERISA territory. Both the MIA and the Office of the Attorney General disagree. They'll say, probably often, that cost to self-funded plans will skyrocket. But I have never seen any evidence of that statement. There's no evidence that regulating PBMs raise costs. You might ask them for the data. I may be interested to see it. They might tell you, as they told the Senate Finance Committee yesterday, that businesses will flee from the state over the cost of healthcare benefits if this bill passes. But again, we've seen no evidence to support that claim. Lastly, they might tell you that regulating PBMs will pose an existential threat to the market. Apparently, life may end if PBMs can't continue their grip over all aspects of the pharmaceutical industry. Yet, as of November 2023, 44 states have passed legislation prohibiting gag clauses. 23 have prohibited discrimination against non-affiliated pharmacies. 16 have established reimbursement regulations, and 10 allow state audits. Despite this, the sky has not fallen. PBMs cannot be innocent players. They've gained greater control and consolidation of the market, and in some cases, overcharged plans by millions of dollars, and costs have soared. I'll stop there.
You can take your time.
Oh, okay. This bill ensures that all Maryland patients are protected equally, regardless of plan type. The protections Maryland already has in place for Maryland regulated plans. So we ask you to please support House Bill 726.
Thank you. And thank you so much for your very thorough presentation and research. Are there any questions by Chair Collison?
Thank you, Madam Chair.
Mm-hmm.
Just want to make sure and confirm, Heather, the things that you mentioned that have been passed in other states, that they all apply to ERISA plans? Because many of those things we have
Yeah.
in our law for.
Not necessarily, and I did not look at every single state law to see which ones applied to insured plans and which ones did not. But I think the fact that any argument that comes up about regulating PBMs is a suggestion that the sky is going to fall and prices are going to go up, and that just doesn't happen. Regulation goes in place as it should, and if most of the research that you do will show that rising costs of anything are related to the PBMs themselves. As the chair mentioned, I mean, 3 companies regulate 80% of the market. When you have that kind of monopoly, and lack of transparency, frankly. I mean, if the PBMs are really the good guys, they want you to believe that they are, can they please just open what they're doing and let us see it? Like, look behind the curtain? Thank you for the question.
So I just asked, I wanted to know, when was the last time we had a PBM work group in the interim? Because you just outlined all those states, what those states have done. And I'd like to know, I know we've done a lot, but I really want to know, where are we? What have we done? Where do we fall, right?
Mm-hmm.
So I think I'm going to put something together in the summer, and I'd like you to be very much a part of it. Are you willing?
Yes, of course, absolutely.
Okay, great. So I'm going to give it some thought. I'm going to talk to my expert to my left and some other people, and we'll put something together. The other expert to my right, and we are going to put something together, because I like to know what the states have done, right? And where are we? What have we done? What have we not done? What can we do, right? Because this comes up constantly. And trying to find, again, in this committee, we're balanced, we're reasonable, we really are. And I say that in a very humble way, with a lot of modesty. We try our best to make sure that everyone is heard and that we have a compromise. But I want to find a compromise where the sky doesn't fall, but it does help our people.
Yeah.
And I think that is important. So I will be doing that. I will, and I thank you again for volunteering, although I asked, but I appreciate it.
I'm happy to be volunteered.
Yes, thank you. Thank you so much.
Thank
Since there are no other questions, we're gonna go now to the rest of the committee, which is basically unfavorable. There's no one else left, which is Heather Cascon, William Kress, Matthew Chantilano, Kimberly Robinson, Michael Johansson, Camille Fesh. And will you bring the 2 virtual witnesses, unfavorable witnesses? If you can all come up and pull up a chair, please. I appreciate it.
Time is getting late, so I'm going to go, Madam Chair. Matt
Absolutely.
Celentano on behalf of the League of Life and Health Insurers and AHIP in opposition to House Bill 726. For decades, state laws related to state health plans, including all prescription drug benefits, have only been applied to fully insured health subject to regulation by the MIA and not plans exempted by federal ERISA law. We understand the Supreme Court Rutledge decision changed that landscape, but the subsequent Mulready challenge has swung the pendulum back towards status quo. It also doesn't change the fact that the proponents are trying to mandate changes to plan design. By extending the provisions of prior PBM law structure to self-insured plans, these proposals will restrict the opportunity for health plans to reduce their prescription drug costs. This will also come as a surprise to a ton of these businesses who have likely no clue these discussions are ever happening and will probably see sticker shock if this bill moves forward. The League and AHIP thinks that the bill intent misses where the financial burden of this, where it will land, which is businesses trying to provide coverage at affordable levels to their employees, who will ultimately bear the burden of this legislation. And for those reasons, we request an unfavorable report on House Bill 726.
Next, please.
Madam Chair, thank you. Heather Cascon for PCMA. I do think it's important to note there have been several legal updates that have occurred since the passage of Rutledge. So I'm going to take some of my time and testimony to talk about that. In August of 2023, the 10th Circuit Court of Appeals unanimously ruled against the state of Oklahoma in a law that sought to regulate self-insured plans or ERISA plans and their administration of the pharmacy benefit. We refer to this case as the Mulready case. The court's decision expounded upon the breadth of ERISA preemption and how the Oklahoma law regulated core self-insured plan design an area of federal concern. Shortly after that decision, a request was made by way of an appeal by the Oklahoma Attorney General for an en banc rehearing, where the entirety of the circuit court judges would rehear the case. But the request was denied unanimously by the court, letting that ruling stand to this day. While it may sound like this is an issue about PBMs, PBMs are merely agents, third-party administrators to a self-insured plan. State laws that impose burdens on PBMs and any other TPA, like a dental provider, are ultimately passed through to plan sponsors, and they are increasingly concerned with the risk to their self-insured benefits, as evidenced by the numerous and diverse plan sponsor voices who've weighed in with written statements today. Given the importance of unions offering cost-effective benefits for their workers, erosion of ERISA preemption does pose a real threat to organized labor at its core. If enacted, this bill would send a shockwave of concern to all kinds of plan sponsors, as it would create a cumbersome and inefficient and costly patchwork of potentially conflicting state-by-state benefit requirements. There is, the previous speaker spoke to the need for uniformity, but there's also a need for uniformity for plan sponsors. And Maryland would be the first to create such an uneven patchwork. Thank you for your time.
Good afternoon, Madam Chair, members of the committee, Kimberly Robinson, in respectful opposition to the bill. Following up on what Ms. Cascone had to say, you know, I've heard it said several times in the legislature, everybody's entitled to their own opinion, but not their own facts. And I just want to go back to the case that really started us down this path, which is Rutledge, which has been characterized as giving the state the ability to simply regulate ERISA plan sponsors and the way they do their pharmacy benefit managers. But that's not what that case said. Even the initial decision, Rutledge says very clearly that the only thing that's being conceded is that ERISA still continues to preempt anything that attempts to affect a central matter of plan administration or interfere with national uniform plan administration. And the one space that it carved out, it's very specifically talks about cost and cost regulation. And to that end, Maryland did, in fact, in 2021, pass legislation that addressed all of the provisions that were about cost. The provisions that are in this bill absolutely are different than the ones that Rutledge contemplated and the ones that it spoke to. And as Ms. Cascone just shared, we have already had a court, when presented with provisions that would have applied to an ERISA plan sponsor that were outside of cost regulation, rejected it uniformly as a court. And that case is very likely going to be the first to go to the Supreme Court to test the theory of whether or not Rutledge is going to stand with all other ERISA laws that only extend to cost regulation, or if it's going to allow states to go further. So that's where the most recent court decision, and the one most likely to advance, has taken us. You have, unlike last year, lots of testimony from plan sponsors who are waking up and speaking up and saying to you that typically you do not interfere in their plan benefits, and they are not the ones who are asking for it. Not a single plan sponsor is a proponent of this bill, and no one can say this year it's because they're not paying attention. They're paying attention, and they let you know. At the end of the day, we administer whatever a plan sponsor wants to purchase. And often we are standing in their space because we understand what the implications of the laws you pass will have on them. And on their behalf, I respectfully request your unfavorable report.
Thank you, Madam Chair. I'm Mike Johansson on behalf of PCMA. It was mentioned that this bill promotes uniformity. Well, perhaps for the pharmacists it does, but for the ERISA plans, it creates a lack of uniformity across states. Many ERISA plans are large employers, headquartered, for example, in Bethesda, and they have employees throughout the country. And this would create a lack of uniformity for their plan in the state of Maryland. Secondly, it was said on this bill and another bill that this improves transparency. Transparency to whom? The plan sponsor has the ultimate control of transparency. The lawyers, the auditors that work for the plan sponsor have the ultimate control of transparency. It was kind of suggested that plan sponsors really don't know what they're doing. Well, the local governments, okay, many of which you all are very familiar with, the local school boards, the labor unions, all of whom hire legal counsel and can read the PBM contract and have complete transparency as much as DBM does when they issue their RFP for a PBM. So those employers aren't asking for those things. If someone suggests that transparency means the independent pharmacy gets to have transparency into how that contract's being administered between the plan sponsor and the PBM, they're just wrong. That's not what they're going to get. So transparency doesn't go outside of that employer sponsor and the PBM relationship, because those are the ones that have the contract and those are the ones that need to trust each other and make sure each other's doing the right thing. So we do oppose the bill. Finally, I will say, as much as we oppose these provisions, and we did oppose the pricing provisions previously, we know there'll be bills in every year to continue to expand this. And whether it's next year, they want to say you can't have a mail order preference, like is in some regulated plans today, where they say you can't have a limited network, which I'm sure has been mentioned before. We're going to see all these issues, and then it's going to try and extend them further to those currently exempt plans. Thank you, Madam Chair.
So before I open it to question, as I said last Friday, I spoke on the floor. And I said, for us not to speculate about what next year will bring, right? Let's deal with what we have in front of us, because I don't like to act on speculation. And the same goes here in this committee, okay? Let's stick to what we have in front of us, because it's important. It's very important to me to not speculate and act with what we have in front of you. And I mean that respectfully, okay?
Sure.
That being said, are there any questions from anyone on this panel? Seeing none, thank you very much for being with us, okay? Yeah. And who did not come? Let's see, Camille Bachis, okay, and how about, is there anyone here in person who did not get called on this bill that needs to testify in this bill, besides the people that we have virtually? All right. Yes, sir. Mr. Brown, will you be so kind and give us your testimony? Thank you.
Thank you, Madam Chair and members.
You're welcome.
My name is Fred Brown, President of the National Labor Alliance of Healthcare Coalitions. The NLA is a coalition of health care purchasers from across the country with over 6 million covered union family lives. Many of our fund members are ERISA health plans on the East Coast, with a high percentage located in the mid-Atlantic states, including Maryland. As you know, union health benefits are key components in attracting high-quality workers and employers to be signatories on their union contracts. Any attempts to undermine these benefits can be threatening to the union's competitiveness. Now, Madam Chair, you mentioned earlier that these PBM bills are complicated, and I agree, but in the remaining time, I'd like to focus on just 2 key points. First, despite the recent conversation, we have 6 million covered lives, and almost all of them are ERISA plans, and we are keenly aware of the court decisions in Rutledge and Mulready, and we have no doubt that if the 10th Circuit's Mulready decision is applied to this bill, it will be found preempted by ERISA when applied to our plans. Secondly, there has been much suggestion recently that greedy insurance companies and PBMs can cover the increased costs imposed by this bill. However, our union ERISA plans are not funded by insurance companies. Instead, they are self-funded through the collective bargaining process, whereby our unions decide how much to allocate to wages and how much should go to benefits. And when the costs charged to the health plan go up, the value of the wage package goes down. Finally, there are many dozens of PBMs in the marketplace, and union health plans competitively hire and fire them as needed. As the PBM's contracted purpose is to save money for their union customers, they would not be retained if they did not provide value to our plans. In summary, given the increased costs imposed on our health benefits by this bill, we urge an unfavorable report. Thank you, Madam Chair.
You're welcome. Thank you for being with us today. We're really grateful. Are there any questions for this witness? Seeing none, and thank you for waiting as we call your bill, okay? We appreciate your patience, okay? You have a blessed day.
Thank you again.
My pleasure. So we are actually Mr. Lake. Is Mr. Lake there? Mr. Lake, will you be so kind, and great to see you again.
Long time no
Three
see.
times is a charmer.
Yes. Well, on behalf of AHIP, I'm here in opposition to this bill. First of all, let me point out, though, that we're not seeking to relitigate the policy decisions that the General Assembly has already made and that already apply in the fully insured commercial market. Our concern with this bill focuses on its extension to employer-provided health plans that are regulated by ERISA. As already been noted, ERISA exists to set standards and to create uniformity for the employers who manage their benefits across multiple states. The definitional change that's contained in this bill will subject Maryland's self-insured employers to new coverage requirements. That's a fact. Thus, House Bill 726 would jeopardize the single cost-saving standard that the state's self-insured employers rely upon to provide uniform and affordable health insurance coverage to Marylanders. The sponsor referenced a legal analysis of this bill that I provided. The legal experts that reviewed this bill and did that analysis identified 4 provisions of the bill that exceed the scope of the Rutledge decision because they impact a core function of health plan administration. The Rutledge case clarified a very narrow set of activities that states can regulate. It did not create a new category of permissive state regulation, which is what House Bill 726 attempts to accomplish. And because of that, and because the bill would contribute to a patchwork that will increase healthcare costs by subjecting self-insured employers to these new state requirements, AHIP respectfully asks for an unfavorable report. Thank you.
Thank you. Are there any questions for this witness? There are none. Thank you so much. Appreciate you being here. This actually concludes the bill hearing on House Bill 726. Now we have House Bill 876, Delegate Johnson, Health Insurance Pharmacy Benefit Manager, Specialty Drugs Dispensed by a Physician. And then we will have one bill, which is 1368, Delegate Martinez. I want to thank the people who are here for both, for being patient and for being here. And let's get it done. Wow. I love it when you guys know exactly what to do. Go ahead, Delegate.
Thank you. I have to change my testimony here because now it's good evening, Madam Chair, Vice Chair, and members of the HGO Committee. For the record, I'm Delegate Steve Johnson here to present my last bill of the day, HB 876, Health Insurance Pharmacy Benefit Manager, Specialty Drug Dispensed by a Physician. House Bill 876 is about giving patients choice in how they access their specialty medication when they are at their most vulnerable, suffering from a chronic, complex, rare, or life-threatening disease. The bill is considerably narrower than it has been in the previous years and would only require coverage when the patients access their specialty drugs directly from their physician in certain situations where immediate access is essential to their treatment and health outcomes. When it's essential to their treatment and health outcomes. I want to make sure I emphasize that. And only applies to drugs dispensed by a physician under their limited physician dispensing permit and would not create across-the-board substitution for the current specialty pharmacy network. Currently, physicians who dispense drugs in the office can bill insurers under the pharmacy benefit. This bill would not alter that process. Rather, it simply specifies that circumstances when those drugs should be covered due to the specialty nature of the patient's individual circumstances. This bill is supported by the specialty physicians and the practices that support these patients and by the patients who have been impacted by delays and other barriers accessing their medications from an off-site specialty pharmacy. HB 876 creates another tool for serving our most vulnerable patient populations, and I urge the committee's favorable report on House Bill 876.
Next.
Whoever wants to go. You want to start down there, Dan?
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of Arthritis and Rheumatism Associates. We're going to hear a lot about this bill. This is not the first time it's been before this committee, and as the sponsor indicated, it's a narrower bill, in an effort to kind of put some guardrails around what we're really trying to accomplish. And I think what we're really trying to accomplish is take into account the needs of patients. You're going to hear from Dr. Worthing about the patients that he treats, those with autoimmune disorders, rheumatism. These are lifelong, life-altering conditions. And part of that care that's involved is the patient working with their provider, their physician, to establish a routine of care that's going to keep them productive, keep their lives active, and prolong their life in many cases. And what happens is there's that interchange between the relationship between the doctor and the patient, and then the pharmacy benefits and how they get their medications. And many of their medications are specialty drugs. And as you'll hear again, there's a lot of specialization around how you get specialty drugs. And for many of the patients, getting them by mail order or going to pick them up after they get delivered from a specialty pharmacy works. But when it doesn't work, that's what we're trying to do. We're trying to establish a little venue here where a physician can dispense the drug to the patient, oftentimes show them how to administer the drug. And that has a couple benefits. One, it eliminates unnecessary waste for those who can't rely on a mail delivery system because of maybe the neighborhood they live in or the refrigeration needs of the drug or even the timeliness of it. If they can get it from their physician, that yields tremendous benefits. The other thing is too that these people are suffering a condition that, as I said, is life-altering, it's debilitating. If they miss a dose, it could throw off the course of their treatment and maybe put them back in the hospital. So they want to make this as easy as possible for them. This gives them that option. We hope that you'll consider the bill as drafted. Thank you very much.
Next, please.
Thanks, Madam Chair and the committee. I'm Dr. Angus Worthing. I'm a rheumatologist, practice at Arthritis and Rheumatism Associates, as Dan mentioned. And we have 5 clinics across Maryland, treat approximately 30,000 people a year, some of whom have autoimmune diseases like rheumatoid arthritis. And when autoimmune diseases flare and are untreated or partially treated, people not only have pain and can have joint damage and other organ system damage, but that can limit their lifespan because of the increased inflammation in their heart, causing heart attack or stroke or serious infections. And as Dan said, this bill would help us in some of those patients who need specialty medications, and for whatever reason, it doesn't work out for them to have the currently mandated mail order delivery. And it would reduce that barrier to these important critical medications. People with rheumatoid arthritis pay for the delay and the barriers with their own personal pain and disability. But I wanted to talk about a couple things related to costs that you might hear later on from opponents. This bill will not only help us streamline care and treatment, providing the medications at the site of their care, but also would not raise drug costs, and in fact might possibly cut costs. Number one, when we sign up as part of a network with these PBMs, we take contracts that are pretty much non-negotiable. You can take it or leave it. So we're not increasing the costs of medication to the plan. And number two, this year, especially in the United States, we're moving a lot of people to what's called a biosimilar that I heard mentioned earlier, and I'd be happy to answer more questions about this, but it's data suggests that when people move to a biosimilar, less expensive drug, and it's positively framed, like at a doctor's office, where they can learn how to use this new syringe medication, it can actually be more cost effective. So we're strongly supporting 876 and appreciate your time. Thanks.
Thank you. And thank you for your testimony. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Courtney Horn, and I'm a pharmacist in the medically integrated dispensary at Maryland Oncology Hematology here in support of House Bill 876. Medically integrated dispensing, or MID, is a key aspect of an outcome-based, collaborative, and comprehensive model for delivering quality care and therapies to cancer patients. The MID model allows us to dispense patients' anti-cancer medications directly from the physician's office in a timely manner and easily billed under the pharmacy benefit. Our MID team is involved in the patient journey before treatment begins and all the way through treatment monitoring. We help the physician and patient navigate new medications, dose adjustments, patient adherence, financial assistance, and toxicity monitoring. As a direct part of the patient's care team, we have pre-existing relationships with the patients and access to their medical records, which enables us to make critical clinical interventions as needed in real time. So how does MID compare to external care coordination? Traditional mail-order pharmacies provide education and oral oncolytic refill management, but these services are provided by personnel with limited knowledge of the patient's individual circumstances, no access to the patient's EMR, and inadequate access to the patient's oncologist. As an example, some oral oncolytics like Krazati and Kisqali require baseline EKG testing before starting therapy. Our MID team can and has identified patients missing a baseline EKG, contacted the provider, and even had the patient brought in sometimes the same day to have the test done so that we know it's appropriate and safe for the patient to start the medication. In the last decade, there have been multiple studies across many specialties showing that clinical interventions made by MID teams lead to better patient compliance, outcomes, satisfaction, and reduced financial toxicity. For these reasons, MID is an important part of cancer care, but it is not a replacement for traditional specialty pharmacy. House Bill 876 establishes coverage for these services in appropriate clinical situations, and I urge the committee's favorable support.
Thank you.
Good evening, Madam Chair and committee members. My name is Paul Berman. I have a rare form of blood cancer. I've traveled from Silver Spring to be here today to urge you in person to support House Bill 876. For years, I have received excellent, highly personalized care at Maryland Oncology Hematology. I see Dr. Ferozvi there every six weeks, so he and his staff are aware of the slightest change in the indications of my cancer, including my demeanor. They carefully monitor all my medications for the effect on my disease and for drug interactions. 3 years ago, my cancer worsened so that I needed a new medication, which is only available through specialty pharmacies. Last year, my insurance carrier Cigna allowed me to use the medically integrated dispensary at Maryland Oncology Hematology. I was able to go to the office to pick up my medication and was welcomed to a warm personal relationship with the staff, who also monitored my blood levels and were in close consultation with Dr. Ferozvi. Earlier this year, when I called for a refill, I was surprised to learn that Cigna would no longer engage with MOH. I was forced to use a specialty pharmacy that is part of the Cigna enterprise. I had no advance notice of this change and no opportunity to choose a different plan or carrier that would engage with MOH. The Cigna specialty pharmacy is anything but personal or caring. Communications are most often by robocalls or text messages or through its app on my phone. Each time I call, I'm routed to a different person who does not know me or my health. Cigna specialty pharmacy has provided inaccurate information on when my medication will be delivered. Indeed, my medication, my blood cancer medication, is now delivered by UPS, left on my porch, exposed. Members of this House committee, you have an opportunity with HB 876 to provide specialty drug patients like me with choice to integrate our drug and medical care in a way that best contributes to our health. Thank you.
I want to take a minute to say thank you for coming here. I know it takes a lot under normal circumstances to come to this building. So I want to thank you for making the time to come to share your story, your journey with us, okay? And I want you to know that we don't take it for granted, okay?
I very much appreciate that.
You're welcome.
Thank you.
Next, please.
Good afternoon, Madam Chair and members of the House Committee. My name is Kasha Ferozvi, and I'm an oncologist in Maryland Oncology Hematology, here in support of House Bill 876. MOH is an independent practice throughout the state of Maryland that accepts every insurance or no insurance. And we take care of every patient that walks through our doors and provide millions of dollars a year of charity care without hesitation because we are a community practice and therefore we take care of all members of our community. Why is this bill important? As an oncologist, I treat very sick patients who need personalized multimodality treatment plans that are customized to their complex, rapidly changing medical conditions. Caring for a cancer patient requires a coordinated team approach for members who are in constant communication with one another, which is what happens every day with our MID. I'm currently taking care of a physician colleague who has stage 4 prostate cancer. After many heart-wrenching, challenging conversations, he decided he recently wanted to stop taking his olaparib and enter into hospice. However, when the pharmacy called him to verify he was still on the medication, he had not made that difficult decision to stop treatment. And so the drug was mailed to his home anyway. This is the drug. It costs $14,000 a month. This is his prescription. He brought it to me. This is just one patient, one drug. In the past month, my one office of 7 physicians has collected these extra deliveries from our patients, which costs a total of $77,200. The financial impact of fragmented care is real. Forced steerage to remote, unaffiliated PBM pharmacies who lack access to records and real-time changes in clinical conditions is inadequate for many of our critically ill patients who need dose adjustments and changes in medications. This practice is unacceptable. Some of the oral medications have to be delivered in coordination with injectable medications or radiation, which requires precise timing. Sadly, these plans are now also requiring remote delivery of injectable medications, resulting in poor outcomes, waste, harm, and treatment delays. We've talked a lot about wasting money, but to a cancer patient, nothing is more valuable than time. Forced steerage results in not only significant waste of money, but more importantly, a waste of the most precious thing a cancer patient has, their time. And for all these reasons and many more, I ask you for a favorable report for House Bill 876. Thank you.
And thank you. And I want to thank you for the work you do.
Thank you.
Thank you, Madam Chair and members of the committee. For my last bill today, Caitlin McDonough in support of House Bill 876 on behalf of Maryland Oncology and Hematology. I appreciate the panel and the sponsor and kind of fleshing out the bill and the history of it and how it's changed over the last couple of years to really be narrowed down on medically integrated dispensing. I think we are getting close to some potential amendments to the bill that may make it fairly palatable to all the stakeholders. I'll thank Ms. Robinson in particular for working with us on some of the cost control language. I would caution the bill's already been narrowed pretty significantly to, medically integrated dispensing in certain circumstances with certain patients, certain drugs, and with certain clinical triggers. We do get a little hesitant to narrow it much further by specialty state, as we heard from some of the members of the panel. This is a service that's available in a lot of not a lot of specialty practices, but in specialty practices that are providing highly specialized integrated care. We do think it has value, obviously in the cancer space where timing is so important, but across some of the other disease states as well. We welcome the opportunity to work with the stakeholders in the committee and the subcommittee, but that would probably be our outlying concern, is that narrowing. I believe we are very close on cost control language that would make it more palatable to the payers. So thank you for everyone's work on the committee, for everyone's work on the bill for the last couple of years, and we'd urge a favorable report and welcome any questions.
Thank you. So I'm going to open it up for questions now from the committee. Are there any questions? Delegate Kaiser.
Thank you, Madam Chair. My question is for Mr. Berman. First, Paul, my constituent and friend. Good to see you. I'm certainly sorry to hear about your cancer. I think this is the first I've heard of it. So I want to express my sympathy, first of all, but so glad to see you here. And to everyone else, Paul is one of those people that emails you a couple times a year and says, make sure you're doing this and make sure you're doing that. Keeps us on our toes. My question for you, I want to hear about a little more in terms of the personal experience, and I think part of what you provided. So if the medicine can't come to you easily, what would happen? Would it be on your front porch? Would there be concerns with temperature control? Would there be concerns with privacy? Give us a little more of the description of the situation of what would happen if we couldn't pass a bill like this.
Let me give you a contrast. I have some familiarity through my prior professional life with drug labeling and what it means when it says store your drug at room temperature quote, excursions permitted, close quote. I take that quite seriously to mean that I really should strive to have my drugs, especially this cancer drug, specialty drug, stored at room temperature, so that when I fly, for instance, I put it in the carry-on bag, and so it doesn't go underneath. When I called for my refill, I was given some options. Sort of, it reminds me of dealing with Amazon. It really is. It's the same in personal nature. You go online, you tell them what date you want it, and it shows up on a UPS truck. The day it was delivered was really, really cold. The delivery was in the afternoon. It appeared to me when I picked it up that the medication was close to, I don't know what it freezes at, but close to, 32 degrees or below, and had been on the truck for a long time. That just raises anxiety for me as to, is this drug still stable? Is it still as potent as it's supposed to be? Is it really working the way it is? And that's the reason why I want to use an office, if I can, where I go and pick up my drugs and I have them, my pharmaceuticals, and have them under my control. And I know that when I deal with MOH, I walk into the office, I have a conversation with them. Even though it's a little awkward, I know they're looking at me and Courtney here and her staff. How's he doing today? What's it like? And and that just provides more reassurance in a situation that is fraught with anxiety to start out with. So I'm looking for comfort and control, and just the option of being able to do it the way that makes me feel like, okay, my medication is going to be as potent and as strong as it should be.
Absolutely.
Thank you. And then I just want to further ask Paul, with the concerns of the temperature control, and I would also ask if you've ever received, medication of the wrong dosage, strength, whatever else. Describe what happens if you call to say, hey, I've received the wrong thing, and how do I get the right thing?
That hasn't happened to me yet. I just have no assurance. I know that when I deal with MOH, I get a phone call from them. And if I haven't called in a while, that there's something, is there something amiss? And I've only used, as soon as I found out that Maryland Oncology Hematology had an MID that I could use, I went right to them. So I've only, and so I try to use the Cigna specialty as little as possible. And it was this year, the beginning of the year, when I was told, no, you can't use MOH. You've got to use Cigna. So it's been twice. And the problems, there have been issues with both deliveries. I was heading for a trip. I wanted to be sure I had enough medication before the trip so I didn't run out. I dealt with the specialty pharmacy. Its name is Accredo. And I called to make sure that it would get there on time. I told them I needed it within 3 days. I monitored the website very carefully. It said in process, including the night that they told me that it was going to be shipped. I called them and they told me, well, yeah, sometimes our website isn't up to date with what's really going on in the warehouse. And I don't need that additional, I don't need that additional stress. I want the choice to be able to go where I know I'm going to be cared for and to have all the information about me to take care of me. That's all I'm asking. Thank you.
Okay. Any other Delegate Hill?
Thank you. Really quick, Delegate Johnson, thank you for the bill. And you were one of your panel. Opposition is saying, that there's a markup at the office that's more than, but we just heard earlier testimony that the manufacturer sets the price and the lower price comes in because there's a rebate that the PBM works out and decides how to put it into the pharmacy that will take it. So can you address this issue of the patient, or in some cases, the insurance company will end up paying more if it's allowed to be, if there's a ban on it going to specialty pharmacies?
Can I answer? So I think there's a comparison of apples and oranges here a little bit, in the sense that We are under pharmacy benefits and our drugs reimbursement is not dictated by us. We don't really have any ability to negotiate that. When we use our MID, we are being paid what's being told that this is what you're going to accept. As Dr. Worthing said earlier, we don't have a choice. When we're delivering drugs in our infusion center through our medical benefits, that's a different story. That's where we have 100 employees, perhaps. We have social workers. We are taking care of every single patient who walks through the door. We never turn anyone away, insured or no insured, undocumented patients. We take care of everybody, and we're finding ways to take care of them. And so there is a markup in that, but it's a markup to take care of all the resources that we're providing all of the care for. It's still a markedly less markup compared to what a hospital provides, but it is still an apples and oranges comparison, I think. No, nothing.
Yeah. Can I just ask, if I may, the delegates and people here, can you just stay in the building and do not go out, please? Stay in the room. If you could do that, I really would appreciate it. All right, just stay in place. Any other questions from anyone? Seeing none, thank you so much. Okay, is Heather, Kaylee Lackler here? No. And if you have to leave, can I ask you to just stay here for a little while? Okay. Excuse me, the witnesses that just testify, I will ask you respectfully to stay in the room for a while. Please don't leave. Thank you. Until I tell you so, okay? Thank you. May I have, Heather Lackler is in another room. How about Ms. Kaufman? Yeah, thank you. Okay. Oh, where? Yeah, it's okay. You can go to the hallway. Okay. All right, go ahead, give us your testimony.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Dana Kaufman. For the record, I'm here on behalf of MedChi and the Maryland DC Society of Clinical Oncologists. I can be very brief. I think the panel before me laid out the bill very, very nicely. We are in strong support, and I will continue to stay in touch with Ms. McDonald as the amendments are drafted. So thank you very much.
Thank you. Any questions? Seeing none, may I have the favorable with amendment or people that are working on amendments? Can you come up, please? Thank you. Thank you very much.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson here, favorable with amendments on the bill. As you heard from Ms. McDonough, we have been talking about this bill for several years. And I think over those years, we've been understanding what the concerns were on both sides. And we have been working on amendments to this bill throughout the current legislative session. So I think we are, as she said, I think we're getting very close to an agreement about what the bill ought to look like. To Delegate Hill's question, because you talked about markup in particular, I think that different settings produce different markups. And one thing I'll say about the proponents of this bill, as you heard, they're not the setting that is typically where that concern stems from most significantly. You may hear that on another bill that you're going to hear that's focused on a different setting. But in this particular setting, we have included in the amendments and in the conversation and negotiation, making sure that there are the right guardrails so that by shifting the source of the drug, you are not also increasing the cost to the patient. And that's been something that the proponents have been open to, because that is in fact not their goal. And that's not our goal either. Our goal is to ensure that there is good patient care that is going to happen for those patients. And we appreciate their cooperation as we try to have a meeting of minds on both sides. And I do think we are very close. I'll stop rambling at this point and turn it over to the other two witnesses.
I'll just say me too to what Ms. Robinson said. I think we're close to an amendment or close to a bill that we can all work towards.
Madam Chair, now Matt Cholentano, a bit distracted, but here favorable with amendment on House Bill 876. We are favorable with amendment. We promise to stay at the table to try to get to a solution on this bill.
Thank you. Thank you so much. Thank you so much for your testimony. and for working on this bill. And I know that you will come to a solution. Thank you very much.
My
Is
pleasure.
I have two people virtually. Will you be so kind and call them, please? And thank you very much, everyone, for your patience, okay? Favorable with an amendment, okay. Matt is on a road here. Excuse me, the people that are on virtually, will you be so kind?
This bill for several years, and
Can you turn off the YouTube? And I have Mr. Tarp again and Keith Lake again. Will you please come up?
I think we are, as she said, I think we're getting very close to an agreement about what the bill ought to look like. To Delegate Hill's question, because you talked about markup in particular, I think that different settings produce different markups.
Mr. Tharp, there we go. Pardon? Mr. Tharp, you need to turn on your video now. There we come. Nope, there we are. Oop. Now, third time's a charm.
Thank you. All right. Good evening, Madam Chairwoman and committee. My name is Louis Tharp, a Towson native, now living in New York. I testified earlier today. I'm the executive director of the Global Healthy Living Foundation, and I'm commenting on behalf of chronically ill patients in Maryland who we represent. This is, as I've said before, another example of the healthcare system working, but not necessarily for patients. And I know I've said that before, but I think it's important. Thank you for allowing me to comment today on House Bill 876. I supported HB 650 last March, and I want to tell you that very soon after I testified, I was approved for medically integrated dispensing. This was after 3 months of arguing with CVS Caremark. As I also said last year, we've been here before. Maryland car insurance companies used to force customers into contracted repair shops. Then in 1994, Article 10-503 of the Maryland Insurance Code prohibited this. The parallel is clear. Today, consumers can choose their own body shop. The monopoly car insurance companies had over accident repair was eliminated. We need to do the same with healthcare. Pharmacy benefit managers in Maryland are doing exactly what these car insurance companies used to do. They're steering people into their high profit monopolies. And when this steering is prohibited, the medication from pharmacies they know and trust, or from doctors' offices they know and trust, not the pharmacies that deliver the highest profits, will be used. The days of Maryland being railroaded into contracted pharmacies that only serve to enrich insurers and their PBM partners need to be over. A vote in favor of 876 will restore this balance of power in the healthcare system, shifting it back towards the individual. We wholeheartedly support the bill.
Thank you, Mr. Tharp. Any questions for this witness? Seeing none, thank you very much for your time and your patience today. Pardon? Oh, okay.
Did he testify
Yes, he
already?
did.
Mr. Lake, will you be so kind and give us your testimony? And this is the fourth time. You know what? We have a rule here in this committee, Mr. Lake. And I think this is, you have become an honorary member of the committee now. I think Delegate Shalenga agrees with this. You must provide something, some kind of dinner for the committee. Just kidding, you were not allowed. But if you were a member, at this point, you will probably owe a whole week of dinners. But go ahead, Mr.
Right.
Lake.
Yes. Or maybe you owe me.
Go ahead.
Well, thank you. I want to just begin by acknowledging that House Bill 876 is narrower in scope than House Bill 1368, which is the next and last bill, I think, on your agenda today. Still, we do have concerns with the as introduced version of this bill and would respectfully urge an unfavorable report on it in its current form. But as Ms. McDonough, Ms. Robinson, and others indicated, it sounds like we're getting close on some potential amendments to House Bill 876, particularly related to cost control. And AHIP certainly appreciates those conversations and the sponsor's willingness to entertain these possible changes. And as a result, I'll forego giving my planned testimony on this bill, and let's get going.
Thank you so much, Mr. Lake.
Thank
Are
you.
there any questions? Seeing none, thank you so much for being with us. Is there anyone here that did not get called? Anyone virtually waiting for this? I believe not. Okay, great. So this actually concludes the testimony on House Bill 876, and we are going to the last bill of the evening, which is Delegate Martinez, House Bill 1368, Health Insurance Carriers and Pharmacy Benefit Managers. We have clinician, administer drugs and related services. Delegate Martinez, I believe your panel is Dr. Farag, Dr. Courtney, Jake, and Dr. Leah. And Leah is virtual. Will you please bring her up? Thank you. Hi, how are you?
Good. Hello,
Good.
everyone.
Thanks for being with us.
I was going to say I'm between you guys and going home, but something else might take the chat for that. Good evening, Madam Chair and colleagues. I am Delegate Ashanti Martinez, here to present House Bill 1368, Health Insurance Carriers and Pharmacy Benefit Managers, Clinician Administered Drugs. Many of you here might not be familiar with the term white bagging. That's when payers require patients to get their medications from a specific pharmacy. This bill aims to reduce white bagging between the payee and the payer and provide options. It doesn't outlaw it. We're just trying to provide more options. For instance, if the patient and the provider determine that white bagging is the best option for the patient, they may proceed with that option. Running through a quick scenario in regard to white bagging, medication gets delivered to the clinic or hospital via third-party delivery service where the medication is to be administered to the patient. In this scenario, the hospital and clinics already have the medications readily available in stock and can procure the medication themselves to be administered to the patient. Since that is the case, then why are clinics and hospitals having to wait for medications to get delivered if they already have it available? That is because the payers are receiving financial benefits from requiring patients to utilize a specific payer-designated pharmacy. This bill is similar to the bill that we just heard from Delegate Johnson. One of the major differences between the bills is that instead of just allowing for physician clinical settings to be the exemption from white bagging, this allows for all settings, and it just increases patient options. I ask for a favorable report. Thank you. And then
Who would you like to go next?
Good evening, Madam Chair and committee members. My name is Farah Tavakoli. I'm a clinical pharmacist working at the University of Maryland Medical System. I have lived in Maryland my whole life, and I'm excited to be here today to support Bill HB 1368 to contribute to improved healthcare access for residents of my home state. This bill prohibits payer-mandated white bagging in all care settings, whereas the bill you heard previously only prohibits white bagging in one care setting. To further explain white bagging, I want to start with an analogy. Imagine you have a dining plan. You plan a nice evening out at a restaurant. Instead of ordering off the menu and having the chef use their own ingredients, your dining plan requires a specific grocery store to deliver your steak, potatoes, and wine to the restaurant and ask the chef to prepare your meal for you using this food from the outside. That is absolutely absurd, and we would never ask a restaurant to do that, nor would a restaurant agree, due to several health and safety issues. And that is exactly what white bagging is. It is when payers require patients to get their medications from a specific payer-mandated pharmacy, and then that medication gets delivered to the clinic or hospital where the medication is to be administered to the patient. On the favorable panel today, you are seeing frontline healthcare workers. We see patients every single day. and deal with the inefficiencies of white bagging and the patients that have to deal with delayed medications and constantly rescheduling appointments. In the opposition panel, who will you see? You see payers who are benefiting from white bagging. When is the last time they saw a patient in person? They are receiving financial kickbacks by keeping white bagging in place. The opposition panel is going to spew out outrageous numbers to instill fear in you. I want to remind you all that we are in the state of Maryland. We are under the Maryland waiver, and our reimbursement is set by the HSCRC, Health Services Cost Review Commission, and by our GBR, the Global Budget Revenue. In the state of Maryland, we are in no way able to mark up drugs at 200 or 400%, as you will hear from the opposition. With that, I urge a favorable report of HB 1368.
Thank you. Next, please.
Good evening, Madam Chair, Madam Vice Chair, and committee members. My name is Courtney Henry. I'm a medication safety pharmacist. I practice at MedStar Montgomery Medical Center, and I'm here to share my support of House Bill 1368 as a representative of the Maryland Society of Health System Pharmacists. Payer-mandated white bagging is a patient safety and quality issue, and I urge the leaders before me to support this bill. The purpose of this bill is to increase access to care, prevent delays, and to allow for a safer model. In hospital pharmacies, white bagging means we are accepting liability for medications that we cannot maintain a chain of custody. Drug ordering generally is a streamlined process in hospitals, and there's a serious impact to hospital processes when dealing with disruptions due to white bagging. The end impact of this results in disruption to quality patient care. Hospitals in Maryland cannot grossly benefit from clinician-administered medications. Our reimbursement rates are regulated. Therefore, we must either turn away patients or accept a practice that we know is flawed and does not translate into improved patient care. Day of treatment changes are very frequent, and delays and waste will continue to occur with white bagging. Patients will continue to receive care from hospitals, and we too have infrastructure. We have sterile compounding. I could argue that our sites are the safest place to receive some medications, but that's not what I'm interested in pursuing today. I want to see improved access for care. Cost savings is also a favorite talking point, but there's not strong data showing that white bagging actually reduced costs, and I would urge any opposition to show evidence where these suspected cost savings are actually passed down to plan sponsors or patients in the form of reduced premiums. I would also like to remind those before me that patients are the end user of this model, and they are going to come to our hospitals. They will come to clinics. They will come wherever they can to receive care. And that if we continue to do this, our patients are going to have delays in care and lower quality. Thank you.
Thank you.
I'm so sorry. My name's Courtney Henry. If there was a question about
Thank
that.
you. Yes. Thank you, Courtney. You know what threw me off? I have you both virtually and you're here in person. So go ahead.
Sorry about that.
Oh, no, we love to have you in person. Go ahead.
Great.
All
Thank
right.
you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Jake Whitaker on behalf of the Maryland Hospital Association, here to testify in support of House Bill 1368. Instead of allowing hospitals to dispense drugs already available from its own inventory to a patient, drugs that are already on site, down the hall or down the stairs in the pharmacy, white bagging requires patients to wait while a payer-selected specialty pharmacy ships the same drugs to a payer-approved site for administration. If there are shipment delays, such as a storm and FedEx can't deliver on time, then a patient suffers because they can't receive a drug that day. Also, if a patient's condition changes, drugs sometimes have to be adjusted. For example, increasing or reducing a dosage on the scheduled day of administration. If a hospital can use its own inventory, modifications can be made on the same exact day. Under white bagging, that is not possible, and a separate order will have to be placed, and the patient will have to wait until that new shipment arrives. At best, these delays are an inconvenience, but they can have some serious health consequences. And I'd just like everyone to imagine what it would be for a loved one to have their treatment delayed. So for these reasons, we urge the committee to support House Bill 1368 to help patients receive the drugs from providers they trust instead of a location chosen by insurance companies. Thank you, and I'd be happy to answer any questions. Thanks.
Thank you. And nice to see you in your new role, Jake.
Good to see you as well, Madam Chair.
Thank you. I'm going to open it up for questions now. I see Delegate Hill.
We have one more.
And we have a virtual as well.
Oh, excuse me.
We have a virtual for the favorable panel.
I'm going to leave them and then go to in our favor and then bring them. Is that okay? Just to balance, or is this person part of your?
She's part of the sponsor panel.
Oh, okay, great. So why don't we go to that person? Good afternoon, go ahead.
Hi, thank you. Good evening, Madam Chair, members of the committee. My name is Dr. Rossman, and I am a certified specialty pharmacist and clinical pharmacy specialist. I have spent my entire professional career in Maryland, and I am testifying today in support of a legislation that will preserve and improve timely patient access to critical medications. I have worked in the inflammatory bowel disease program at University of Maryland Medical Center for over 4 years, assisting with both medication education and access. Insurance mandated dispensing of clinic administered medications, usually through insured owned specialty pharmacies or white bagging, has resulted in delays and lapses in treatment for a significant number of my patients. I would like to share some specific examples of problems we've encountered with white bag mandates. For patient number 1, the subcutaneous instead of intravenous formulation of medication was delivered to the infusion center, resulting in delay of therapy. For patient number 2 and 3, temperature-controlled packages were delayed in delivery for days, resulting in medication becoming unusable. Medication had to be reordered, resulting in delays in therapy initiation. For patient number 4, medication was lost inside a healthcare center, resulting in patient receiving a large bill for stock medication. For patient number 5, her refrigerated intravenous medications were shipped to her home instead of the infusion center, resulting in leading to compromised cold chain stability. Patient number 6 was unable to find an infusion center covered by his insurance willing or able to accept the white bag medication. A lengthy appeal process had to be formed, resulting in months-long delay in access to therapy. These are only a few examples, and similar situations have occurred for dozens of my patients since white bag mandates have become more common. I often counsel patients that having a chronic disease is like having a part-time job. You need to set aside time to manage your treatment, therapies, follow-ups, and evaluations. White bags mandates increase the administrative burden on patients while also increasing the risk of errors and opportunities for medications to become compromised. As both a compassionate clinician and as a multiple sclerosis patient who relies on office-infused specialty medication, I urge a favorable vote on House Bill 1368, which will improve healthcare equality, improve economic competition among infusion providers, and ease already heavy burden on chronically ill Marylanders. Thank you.
Thank you. Thank you for your testimony, doctor. We appreciate it. Anyone else for your panel?
Nope.
Is it? Okay, we're going to open it up for questions. Delegate Hill.
Thank you, Madam
You're
Chair.
welcome.
It sounds like this is really specific problem, particularly with infusion centers and all, but I want to make sure that I understand how it might impact some others. So sometimes at the hospital, I may have medications that are cheaper for me to have the patient buy and I bring in, I need permission to use it. And sometimes the pharmacy has to examine it and make sure it's okay. Does this in any way affect my ability to save my patient money by bringing in a medication that I want to use, say in surgery, that the hospital would have a markup? Can someone answer that?
I know you feel like you want to touch it, right?
Oh. Yeah.
It's okay. You can go now.
Thank you, Delegate Hill, for your question. This bill is in relation to medications that cannot be self-administered by a patient. They require a healthcare provider to administer those medications. And it is coming in, it's primarily related to oncology medications, autoimmune disease medications, and are typically infused in the clinic setting.
Yes.
And so I think it wouldn't prohibit it, but Delegate, I'd sort of like to have that conversation. So for instance, this Exparel is a medication we use in surgery. And often the hospital cost is higher. And if the patients self-pay for the procedure, it's just easier for us to get it and bring it in.
Yeah, no, like I said earlier in my opening remarks, this is about providing as many options as possible for our constituents. And so I would love to work with you offline to make sure that's not prohibited.
Yeah, and just to clarify, this would not impact Exparel or medications typically used in surgery. And again, does not prohibit white bagging, but allows the patient and provider to make that choice to determine, is white bagging the best choice for me? If so, let's move forward. If not, let's use our other options.
Okay, thank you. Any other questions or concerns? Seeing none, thank you so much, and thank you, Delegate, for your work. I'm going to call a panel of unfavorable: Matthew Shalentano, Heather Casconi, Michael Johansson, Camille Feshi, Tricia Swanson, Kimberly Robinson, and Keith Lake. Can you bring him up, please? I think that if you were delegates, you also will owe dinner here today.
Well, Madam Chair, if you don't mind calling my wife and my mom, who are freaking out, I'd really appreciate that.
It's so good. You
But
know what? Calm. It's all good. We're in great hands.
tell that to my wife, please.
We are
All right.
in great hands. Anyone listening at home, we're in great
We're good.
hands. We're good. Praise God. We're good. Go ahead. sir.
Madam Chair, Matt Celentano here today for the last time on behalf of the League of Life and Health Insurers of Maryland and AHIP opposed to House Bill 1368. Carriers use lower cost specialty pharmacies because they save money for patients and help to make premiums more affordable. Specialty pharmacies can deliver drugs directly to the physician's office or to a patient's home right before a patient's appointment. This means that patients can avoid inflated fees and other costs that hospitals and physicians charge to buy and store specialty medications themselves. For example, specialty pharmacies can protect patients from a hospital's markup for prescribed drugs, which on average run between 200 and 400% on the hospital's acquisition cost. There are a lot of studies in my written testimony that will point you to these numbers. Specialty pharmacies are used only for prescription drugs that may be safely delivered in this way. These lower cost pharmacies are subject to the same supply chain safety requirements as any other dispensing pharmacy under federal laws and state licensing laws and regulations. Specialty pharmacies must also meet extra safety requirements for specialty drugs imposed by the FDA and by drug manufacturers. They must satisfy stringent state and federal requirements for safe storage, handling, and dispensing of the drugs. So many of these specialty pharmacies employ clinical specialists that are available 24/7 to provide additional support to patients. In some cases, the clinical specialists directly administer these medications to patients. This bill will upend that. I know from personal experience, this is the kind of service that specialty pharmacies provide. I won't belabor the point. Like I said, I have extensive written testimony on this bill, and I ask for an unfavorable report on House Bill 1368. Thank you.
Thank you.
Madam
Next,
Chair,
please.
I'm going to go
Yes.
next. Heather Cascone on behalf of PCMA. I want to share three main points with you today. First and foremost, that white bagging is a very safe and secure practice. Specialty pharmacies use shipping protocols based on the U.S. Pharmacopoeia to ensure that a drug's safety, including its temperature-controlled packaging, specialized shipping containers, and that they find the most safe and direct package route and journey, even taking into account weather throughout the course of the trip. It's important to know that the specialty pharmacies use the exact same common shipping carriers that provider and hospital offices use to obtain the medications themselves. Second, the practice of white bagging is more affordable than buy and bill. Specialty pharmacies evolved in part because the practice of buy and bill grew to be increasingly costly. Instead, specialty pharmacies buy in bulk. And just like you would saving money at a Costco and buying paper towels, you avoid the additional markups from the provider by using the white bagging system. And ultimately, plans and PBMs are able to pass savings to patients. Lastly, there is a number of statistics and research that support this point of view. There are approximately 80 drugs administered in this way, and they are projected to cost the system $230 billion in 2023. Several studies outlined in my written testimony cite dramatic cost markups in physician offices and hospitals. You can note the research from the Massachusetts Health Policy Commission. In the absence of provider commitment to limit these costs, we must urge an unfavorable report respectfully. Thank you.
Next, please.
Good afternoon, Madam Chair, members of the committee, Kimberly Robinson on behalf of Cigna. For the last time today.
Are you sure? Go ahead.
I am certain. Respectfully requesting an unfavorable report on this bill. I'm not going to fully repeat what you've heard from Mr. Celentano or from Ms. Cascone. I'm just going to highlight a couple of the things that they said. As you heard, the same
process by which any drug arrives at the hospital is the same process by which these drugs arrive at the hospital. White bagging is not taking a different route, a different path, a different carrier to bring those drugs. And we do adhere to all of the same safety standards that any shipped drug is required to in this country, whether it's through the FDA or through other boards who certify how we do this. And also not insignificant is in fact the cost differential. I thought it was interesting when Delegate Hill talked about, even in her space, her own experience about why she wants to be able to bring a drug in because she knows it's cheaper than what it is in the hospital. That is part of what gave rise to this practice in the first place. And so I know that there's a feeling that there's not a lot of evidence to that, but I know that both the written testimony of Ms. Cascone and Mr. Celentano cite several studies that have in fact looked at this. I think with the Massachusetts being the most recent, where that state actually looked at it for themselves and came to the same conclusion. We certainly respect the work and appreciate our partners in the hospital setting who are taking care of our patients. We want to ensure they're getting the best care. We do have exception policies for when something is not appropriate. We fill the prescription that is submitted by the provider, and sometimes things do change from when that was requested and when it's received. And we do not charge the patient more for that. We are not going to charge them for their substitution drug. We're going to make sure they get what they need. It just takes letting us know so that we can go ahead and make sure that's covered appropriately. And for all of these reasons, I just simply urge your unfavorable report.
Next, please.
Madam Chair, Madam Vice Chair, for the record, my name is Camille Fesh for the first time today.
I know. Don't worry about it. You're
Mr. Johansson.
you're free today.
Playing the role of Mike Johansson today. Here on behalf of PCMA, I'm just going to leave you with two quick vignettes. Most of all the points have already been mentioned, but an AHIP analysis of the cost of 10 drugs commonly delivered through a specialty pharmacy for provider administration found that hospitals on average charge double the prices for the same drugs compared to the specialty pharmacy. And on average, physician offices charge 22% higher prices for the same drugs. And costs per single treatment of drugs administered in hospitals were an average of $7,000 more than those purchased through specialty pharmacies. Drugs administered in the physician's offices were an average of $1,400 higher. So for these vignettes, as you can see, this is from 2022. And from the points already mentioned, we respectfully urge an unfavorable report on this bill.
Thank you. Next, please. Yes. And is this your second time today?
I think this is my fourth time
Oh,
today.
fourth,
Madam Chair, Madam Vice Chair, members of the committee, my name is Tricia Swanson here on behalf of Care First. I won't repeat what's been said. I just wanted to share a little bit of information with all of you. I know you've heard Care First talk about it and others talk about the fact that we spend 35 cents of every healthcare dollar on pharmacy. And I wanted to add a special point about specialty pharmacy. 3.8% of Care First members participate in our specialty pharmacy network. Those 3.8% of members account for 54% of our total drug spend. This is a very, very large number, and it's our ability to have exclusive specialty pharmacy networks, or ESPN, which I was very confused when I got an email a couple of weeks about ESPN, but our exclusive specialty pharmacy networks allow us to try and keep those costs down. But it is something that's on the rise, and we believe that a bill like this would exacerbate that cost. And so we would respectfully urge an unfavorable report. Thank you.
Thank you. All right, are there any questions for this? Oh, you do? Oh, yeah, go ahead, Delegate Hill.
Because where are we gonna go? Here's the question. So, Mr. Ciantano, I heard you say that you're protecting the patients. And I heard several of you comment that it's the same routes, it's the same this, but we just had sort of on the ground testimony from people who have experienced problems with the delivery and of the right products for their patients in a timely fashion. And so I guess the question is, I understand how it's supposed to work, and I think you were testifying to how it's supposed to work. But if we have evidence that it's not working that way, why would we not want patients to have the choice, the opportunity to know, well, this is what it's going to cost if I use the specialty pharmacy, this is what it's going to cost if the infusion center goes, and make their own decisions? Why would we not want to pass this bill just so they can have the information and make those decisions.
Who's the best person?
I'll tackle it. Thank you, Delegate, for the question. There is, of course, human error involved in every one of these processes, correct, right? So we know that when a drug ships from a specialty pharmacy, a lot of things happen long before it ever leaves the specialty pharmacy. A phone call is made to the patient, notifying them that the drug is about to be transported to their physician or provider's facility, and confirming that that's what they intend. A phone call is also made to the recipient facility and the doctor that's going to be administering that treatment to confirm that they have the address correct, that they're going to be open at the time that the drug gets delivered, that there is someone that can accept in the chain of custody that medication and then be responsible for it. That being said, there are certainly examples that I'm sure where things did not go properly. And to your point, we should try to avoid those things at all costs. However, they are the exception and not the rule. We don't have patients here joining us in testimony talking about all the times that it did go right for them. And so while we as plan sponsors and PBMs need to keep cost in mind, we need to be mindful of the fact that this is a system that works for the vast majority of patients, and try to solve for those exceptions. It's helpful for us to hear the testimony. We can take it back and try to solve for those problems. We're very understanding and want to be working towards a positive result for everyone, but we need to be mindful of the cost at the same time.
Sure. Thank you very much. And I appreciate that answer. I guess it's still sort of the underlying question is this: if indeed it is cheaper for the patient and reliable to get it only through the specialty pharmacy, and we were to pass the bill, then the overwhelming times the patient would still choose to get it through the specialty pharmacy. So the free market would dictate, and it wouldn't really impact your corporations at all, because the specialty pharmacies would still be doing the bulk of the deliveries, correct?
I would qualify that statement by saying the out-of-pocket responsibility to the patient would likely be the same. It's the plan that bears the increased cost through the additional billing made by the provider. So the patient's out-of-pocket cost would likely be the same. There would be no incentive one way or the other for them to vote with their feet, so to speak. But the plan sponsor would realize that increased cost from physician buy and bill.
Okay, but again, if the great advantage is with using the specialty pharmacy, wouldn't even the physicians and the practices and all that realize that it's just easier and there's no real net savings, and it's actually costing us more to do this way? And so it would the default will go back to taking it from the specialty pharmacy if the market were allowed to just do what it wants to do instead of being directed.
Yeah, you want to go?
Madam Chair, is it okay if
Sure.
I respond? I think what Ms. Gascon is trying to reflect to you, Dr. Hill, is that if the price difference is masked to the patient, they don't quite understand where all this cost is coming back, right? As you heard Ms. Swanson say, 3% of her members are 51% of the drug spend. And that's without any markup that's going to occur if those patients in some substantial number move to a 250 to 400% markup on those same drugs. And so without a real transparency that's going to tell that patient, or some skin in the game financially for that patient, there's not a reason for them to understand it, because the challenge, I think, with health insurance premiums and the way those rates get spread across everyone is that you don't feel it personally. So using, round numbers, if my drug is $100 one way, but it's going to be $300 another way, but I don't feel it directly. I don't realize it. But then in a year, I'm complaining because I don't understand why my premium went up so much without seeing the connection.
Right.
And that's part of what we're concerned about.
So that's why the amendment that we might add saying, and it's the total cost would be disclosed to the patient so they can make that transparency, that they actually know the cost.
I mean, I think
and see that they're only paying 2% and this is going, they could see that price and know. So like on my when I fill out my prescriptions, right? Express Care, whatever it is, or Sure Script or whatever it is. And it actually says, here are 5 other drugs. And this is what they're actually going to cost. And this is what it's going to cost the patient. I can actually see and say, maybe better to use that, even though I may not personally feel it. The patient may have the same copay, but I can actually see that getting it from this company is more expensive. That's so that more transparency. That's great. Is that what you're saying?
So one, shout out to you and your real-time benefit check. We love it. We love to see it because we think that is really so important because I think it helps providers help patients have the best choices as you're taking things and making the best clinical decision, but also factoring what's happening to them financially. I think transparency is always important. I think in contrast to the conversation that we're having with proponents of the bill before this, they are actually working with us to make sure that they are not creating financial disadvantage to their member or their patients. And so we're actually working on, cost containment language there that I think we've got a pretty good meeting of the minds on between the two sides because they're not focused on the markup, they are focused on their patient. And so they're working with us so that we are at least protecting the patient financially. That's not a feature of this bill in any way. I don't know at all if the proponents would be open to that. It's a much more significant markup in their space than the other providers who are at the table today. So I don't know where that would go.
Appreciate it. Thank
Delegate Johnson. And then Martinez.
Thank you, Madam Chair. Thank you,
My
panel,
pleasure.
for helping us sort all this out. I was reading a report that says today's specialty pharmacies distribution errors outnumber dispensing errors 2 to 1. This leads to patients not receiving their critical medications and often having to be readmitted to the hospital. And they blame this on there are various dispensing software solutions that help to automate in-pharmacy workflow. But there are not many that help with specialty pharmacy distribution. So can you guys, anybody talk to us a little bit about that?
I'm not familiar with the report. Can you share it with us or tell us any more
Tell
about
us who's reported it.
Yeah. Here. It's VPL.
Who? I'm sorry?
VPL.
VPL.
Yeah. It's issues and opportunities with specialty pharmacy distribution.
Okay. I'd be happy to look into it and get back to you. I'm sorry, I can't
All right,
comment
that's
on it. I'm not
okay.
familiar.
Thank you.
But thank you for sharing it.
Okay. Delegate Martinez.
Thank you, Madam Chair.
My pleasure.
To the opponents of the bill, I'm willing to work on language, willing to work with you guys. Many of you I didn't know had opposition until I saw the list of people coming to testify. And so I look forward to working with you guys on anything that you think it can improve the bill, that we can be together having a product we're proud of. So thank you.
Thank you.
Any other questions? Seeing none, thank you. This actually concludes the bill hearing on House Bill 1368. May I ask if you could just stay seated for a minute, please? Can you be so kind? Oh, there's a witness here? Oh, I'm sorry. Wait a minute. It is who? Guess who? Mr. Lake. Mr. Lake, come back. Okay, Mr. Lake.
I'm
Go
glad
ahead, give us your testimony.
Well, you know what? I really don't have anything to add to what that panel just said, so I'm not going to be redundant. I'm not going to keep you any longer. I will just say that AHIP encourages you to support the use of cost-saving specialty pharmacies and to reject this effort to limit this tool, and urge an unfavorable report on the bill in its current form. So, thank you.
All right.
Great to be with you
Thank you
today.
for being with us. I hope we treated you well.
It's treated me fantastic. Thank you.
You have a blessed evening. Thank you for
Same.
participating in this amazing process, okay? Thank
All right.
you.
Have a
Anyone
great
else
evening.
virtually? All right, this really concludes the bill hearing on House Bill 1368. Will you be so kind?